पास 11 बजे हमने किया था जिसमें नंबर कंफर्म हो गया था 1 2 रैंडम नंबर है ना 1 2 Good morning, ladies and gentlemen. Bismillahirrahmanirrahim. Thank you so much for joining us on time. Since you folks are the only one who are here, what we will do is we're going to do a lucky draw for you only so that your probability of winning is much high. So can my team members help me out? Each one of you will be designated a number. And we're going to then do a lucky draw between those numbers. So Anas, can you do me the honors? We'll start from first table 1, 2, 3, 4, 5, 6, 7, 8, 9. You need to be seated, okay? 9 on this table. Dr. Naila is 10, 11, 12, 13, you're 14. You're 14. Wasim, if you may please be seated. 14, 15, you're 16, 17, 18, 19, please remember your number, 19, 20, 21, 22, 23. Ma'am, can you please get seated so that I can assign a number? 24, 25, 26, 27, 28, and the lady in orange will be 29. So from 1 to 29, let's see if I can pick a number. Okay, let's see. Why is it not working? My apologies. All right. Sir, I'm gonna, how do we do this? This is not working for me. कोई और आए तो आप नज़र रखिएगा. Just give me 1 second. My apologies. नहीं ये random. तो उनको नंबर देते जाएंगे ना. हमने 29 दे दिया ना, बस काफी है. तो टाइम पे आ गया था. अब जो आ रहा है. Yes, yes, yes. Why is it not working? कौन सा? Stop watch करना. हाँ. Start stop. Okay. ठीक है. लेकिन बिजनेस शुरू का नहीं है. कोई भी कर देते ना. या नहीं होगा. 29. हाँ हाँ. All right, we're going to just begin on the count of 1, 2, 3. Lucky number is 24. Who is number 24? There you go. Lucky number 24. Where's the gift, sir? Please come up on stage. A tablet. All right, we're going to do this before every session, and I would like to invite my moderator for the next session to please come up and start on time, and I'm sure you're going to keep us on time. Thank you very much.
Assalamu alaikum and very good morning, everyone. I welcome you all to day 2 of SMOP Best of ASCO Annual Meeting, and I'm hoping that today again it will be a fantastic day. So, and the first session for today is head and neck and sarcoma session. And for this session, our first speaker is Dr. Tom Chen. Dr. Tom Tin he's a consultant medical oncologist working at National Taiwan University Hospital, Taipei, Taiwan. He's going to talk about GIST and rare sarcoma in Asian Pacific, along with some interesting abstract presented at ASCO 2026. He's going to join us virtually. Over to you, Dr. Tom. Thank you.
I would like to thank the organizers for inviting me to this Best of ASCO 2026 annual meeting for Society of Medical Oncology Pakistan. I'm Dr. Tom Chen. I'm a medical oncologist in Taipei, Taiwan. Today, my talk will be GIST and rare sarcomas in the Asia Pacific, genomic insights involving systemic therapy strategy. However, I'm talk mostly about the discussions in ASCO 2026. These are my contents. I'll talk about the latest development in the treatment landscape for advanced GIST. I'll also talk about abemaciclib in differential liposarcoma, and I'll talk about is there optimal second-line treatment for advanced soft tissue sarcoma, the second step study from Japan. First, we're talking about GIST. So in advanced metastatic GIST patients, you do first the mutation analysis. You find whether it's PDGFR alpha, DA42V, or it's a KIT mutation. Once you know it's a KIT mutation, then you go through with imatinib, sunitinib, regorafenib, ripretinib, and possibly clinical trials. However, all these studies are KIT-based, so they're not specifically kind of mutation-directed. But in GIST treatment, when we have primary mutation, the exon 9 and exon 11, when you treat it with imatinib, secondary mutation developed. So they're exon 13, 14 from the ATP binding pocket and exon 17 in the activation loop pocket. And we do know that different kind of target therapies have different sensitivities to these secondary mutations. So right now, what we're thinking is we have something sunitinib that is sensitive to the ATP binding pocket, and we have a new agent that is active to the activation loop. And if we combine these two together, maybe we can have a better result for these patients. So this study, the next study we're going to talk about is about a new drug called the bezuclastinib. It is called, when it first developed, called PLX9486. When you see that, you can see that it is also resistant to the exon 13 and 14, the ATP binding pocket mutations. When you combine with the PLX9486 with bezuclastinib, with sunitinib, you can see in the blue box that all the mutations are sensitive to these two combinations. And in the phase 1 clinical trial, you can see these combinations develop very good responses for late-line GIST patients and a good durable response when these two agents are combined. And because it's good efficacy, a randomized phase 3 study called called PEAK was started. At that time, the drug was sold to Cogent, this company, so they renamed the drug called CGT9486. Now it has the name of bezuclastinib. And in ASCO 2026, the combination of bezuclastinib and sunitinib, the PEAK study results was reported at ASCO 2026. So you can see the study design is a global randomized open label phase 3 study. Patients are randomized to bezuclastinib plus sunitinib or sunitinib single agent as a standard second-line treatment. The primary endpoint is PFS by BICR, the blinded independent radiology review, and other secondary endpoints include the like objective response rate and overall survival. And as you can see, the primary result is that the combination of bezuclastinib plus sunitinib has a PFS of 16.5 months versus the single agent sunitinib with a PFS of 9.2 months with a hazard ratio of 0.5. So the combination significantly had a longer PFS compared with the single agent sunitinib. I think it's worth mentioning to say that in the phase 3 studies, sunitinib only gave about 6 months, but right now, even with single agent sunitinib, that we're seeing that in the second line is given a PFS of 9.2 months. Within the subgroup analysis, you can see most the subgroup has a similar direction, with the combination have more benefit compared with sunitinib. There are two classes worth mentioning that patients with exon 9 mutations, sunitinib does a quite good, while the single agent has a PFS of 15 months itself. And for activation, for the activation loop, AL loop mutations, the exon 17 and 18 that the sunitinib single agent does have a very short PFS. In terms of objective response rate, the combination has significantly higher response rate with a 45% versus single agent sunitinib of 25%. Other median duration of response and median time to response, the median duration of response is also longer with the combination. And in terms of PFS2, what we saw is that, again, the combination also outlives with sunitinib single agent, with the median PFS2 not reached for the combination and 21 months for the single agent sunitinib. And in terms of side effects, there's no treatment-related deaths of this combination, and there's only 7% of patients has to discontinue the combination treatment of treatment-related adverse events. So it's quite safe. The safety profile is quite favorable. In terms of the possible side effects, what you can see is more commonly diarrhea seems to be higher with sunitinib. Also, you can see that the ALT, AST elevation is more in this combination arm as compared with single agent sunitinib. Hypertension is also something we need to see, but because it also contains sunitinib, so the rate was similar to single agent sunitinib. What is very interesting is the taste disorder, dysgeusia, is more common with these combinations as well. So overall, I think in the PEAK study, it has demonstrated that these two combinations of bezuclastinib with sunitinib has a significantly longer PFS as compared with single agent sunitinib, and that safety profile is quite acceptable. And then we'll go to another new agent. It's called velzatinib. It's IDRX42. Now this drug is sold to GSK. And this is a very early phase 1b strategist 1 study investigating this single agent in first-line or second-line therapy for GIST patients. So again, this on the left-hand side is a KIT receptor. And you can see that velzatinib is quite different because it's kind of starting from scratch with targeting KIT mutations. So you can see from this slide on the most right-hand column that the velzatinib actually has is very sensitive to a lot of mutations. There's only one mutation, the gatekeeper mutation, that is less sensitive to this velzatinib. And in this phase 1 study, in the dose escalation part, they have confirmed that the dose escalation, the recommended phase 2 dose is 400 milligram QD by capsule or 300 milligram QD by tablet. So you can see that with this phase 1 study, in the first-line patient, in the second-line patient, they're 24 and 49 respectively. The age is around 60 plus, and there's both patients with primary mutations of exon 9 and exon 11. And also in the second line, there's also a lot of patients with exon 13 and 14, and some patients with exon 17 and 18 secondary mutations. As you can see from this waterfall plot and swimmer plot, in the first line settings, there's a very promising efficacy with objective response rate over 60%, and all patients have some tumor reduction in the first line setting with this single agent velzatinib. And the swimmer plot is quite duration of response and treatment and response quite long for patients, and the median time to response is just 1.8 months. In the second line setting, there's more patients with exon 11 and secondary exon 13 and 14 mutations, but you can see the unconfirmed response is still 40%, with confirmed response 38%. And you can see in the waterfall plot or swimmer plot, patients still goes well with this single agent velzatinib in GIST patients. So if we see by the primary or secondary mutations, mostly the objective response rate are quite good, from 36 or 40% to up to 60% for those mutations. So demonstrating this single agent does have efficacy for both primary and secondary mutations in GIST. And the PFS for a second line patient is about 13.7 months, which is, you compare with single agents, so that is just 6 to 9 months, but still probably not as to the number of the combination we have just talked in PEAK. However, this is just single agents. In terms of safety, it is well tolerated. The TEAEs leading to velzatinib discontinuation is just 5%, and TEAEs leading to velzatinib dose reduction is just about 20%. And differently, so side effects include the diarrhea, nausea, dysgeusia. I think we have mentioned this, but very differently from other kind of KIT TKIs, it has a higher neutropenia risk, any grade is 41%. There's about 23% of patient has higher grade 3 or higher neutropenia risk. So this is something we have to bear in mind when you take, if we take this drug when it's available in the market in the future. So overall, I've taken 10 minutes to talk about the GIST treatment in the advanced setting. Currently, the standard kit-based therapy is still imatinib, sunitinib, regorafenib, ripretinib. However, the new PEAK study, combination study in the second-line setting may become a new standard when it's approved by the FDA. And novel single-agent KIT inhibitors such as velsantinib, with its future studies now in the second line or even the first line of GIST patients, are really highly anticipated. Something I haven't talked about is with new agent approaching, we need to understand, also think about the evolutionary KIT mutation that could occur after these new agent treatments. We're now seeing these secondary mutations at ATP binding pockets or the activation loop mutations, but will we see more mutations based on these new agents is something that we need to be very close about. Then I'll be talking about something from the plenary session, the SARC in the ASCO 2026. It's the SARC 041, a phase 3 randomized double-blind of abemaciclib versus placebo in patients with advanced dedifferentiated liposarcoma, report presented by Dr. Mark Dixon. So as you know, liposarcoma, especially the well-differentiated and the dedifferentiated liposarcoma, is one of the most common liposarcomas. Currently, the standard treatment, either doxorubicin or eribulin and trabectedin in the second line, all mostly have PFS around 2 to 4 months. And it commonly occurs in the retroperitoneum, where you can see from the slides. It commonly has the well-differentiated part and the dedifferentiated part. When it has a dedifferentiated part, we call it the dedifferentiated liposarcomas. And within liposarcomas, not only has MDN2 amplification, because CDK4, this gene, is also on the chromosome 12, nearly all of these patients also have CDK4 amplification. And CDK4 inhibitors have shown inactive to have in vitro and in vivo studies in DD liposarcoma patients. The prior palbociclib, abemaciclib single agent, single arm studies in DD liposarcoma showing promising efficacy of CDK4 inhibitors. In this study, abemaciclib was selected because it has more CDK4 inhibition as compared with CDK6 as a CDK4/6 inhibitor. So SARC 041 is an investigator-initiated phase 3 study sponsored by SARC and using abemaciclib versus placebo. There are some questions about why we're using placebo, because right now there's still a lot of debate when is the best time to start doxorubicin and its benefit. Toxicity may outweigh the benefit. So this design was based on that. So it was designed as a abemaciclib versus placebo study. The eligibility criteria includes ECOG PS 0 to 1, patient with recurrent or metastatic dedifferentiated liposarcoma, with purely well-differentiated liposarcomas were excluded. So patients were randomized 1-to-1, stratified by patient whether they have prior systemic treatment or not, 0 versus 1 or higher, to either abemaciclib 200 milligram PO BID. So I have to say that in breast cancer, which is another indication that abemaciclib has been used to treat patients, it's used 150 milligram PO BID plus a endocrine therapy. But right now here they use 200 milligram PO BID as a single agent, and patient in placebo could cross over if they have progression. The statistical plan was the primary endpoint was PFS with a sample size of 108 evaluable patients with an 80% power to detect a hazard ratio of 0.6 for PFS. In the baseline patients that have both arms has 54 patients. There is around a slight higher male proportion. Most commonly, as I said, 80% of patients have abdomen or retroperitoneal tumor. Some have mediastinum, liposarcoma would have saw. Extremities are pretty low at 5 to 10%. And the age and median is around 67. Prior lines, half of these patients are treatment naive with no prior lines of systemic therapy, and about half of these patients has 1 or more lines of systemic therapy. Here comes the results. The result shows that the median PFS for abemaciclib is 9.7 months versus placebo is just 1.5 months, with a hazard ratio of 0.38. To 6 months PFS of abemaciclib was 60%, for placebo was 22%. and the 12-month PFS for abemaciclib was 39%, with placebo 13%. The response rates were not high with abemaciclib, only have objective response rate of 9%. No patient responded in the placebo cohort. When we have this study has a crossover, so patient who crossover had a median PFS only 3.4 months. The median overall survival for abemaciclib is not reached. For placebo, is 25.5 months with a hazard ratio of 0.55. Remember, this is not the primary endpoint, so it was not powered to detect a significant difference between these two arms. And the exploratory analysis by prior therapy, you can see that for median PFS with patients no prior lines of therapy, the median PFS of abemaciclib could go up to 16.4 months. For those who had one or more prior lines of therapy, the PFS expected at 5.3 months. The key adverse events are similar as we anticipated. Just to mention that abemaciclib could induce the pseudo increase of creatinine because the blocking of the creatinine secretion, but without affecting the EGFR, the glomerular infiltration. 39 patients required abemaciclib dose reduction. So compared with the other phase 3 studies done in DDIF liposarcomas, I think the abemaciclib versus placebo is the first randomized phase 3 study demonstrating a positive effect of experimental agent abemaciclib, although it's versus placebo, but still the benefit is quite wide. I would consider my patients, if possible, to consider abemaciclib as one of the systemic treatment for DDIF liposarcoma patients. So the last report is about randomized phase 2 study. It's a randomized phase 2 study about second-line treatment, which one is better for soft tissue sarcoma patients, a second-step study from JCOB, Japan. So as you can know, the first-line study for most of the advanced soft tissue sarcoma is doxorubicin, but in second line, we have trabectedin in liposarcoma and liposarcoma, eribulin for liposarcoma, pazopanib for non-adipocytic soft tissue sarcomas. But in Japan, actually, all of the soft tissue sarcomas could receive any of these treatments. But this is still a very important question. Which one should I choose? And GD stands for gemcitabine and docetaxel. So if you have a chemotherapy, you have target therapy, you have 24-hour infusion therapy, which one would you choose? So this study is aimed to decide for the trabectedin, eribulin, pazopanib, which one should we pick? Should they pick to compare with GD as the standard second-line treatment for soft tissue sarcoma patients? So this randomized study is a 1-to-1 randomization to either trabectedin 1.2 milligram per square meter every 3 weeks, eribulin 1.4 milligram per square meter day 1, then 8 every 3 weeks, or pazopanib 100 milligram PO once daily. So the study design is primary endpoint is PFS with secondary endpoints including OS. So planned sample size 100 with 40 patients each arm. So you can see that arm A, arm B have about 40 patients. The median age is of 59 to 60 years, and a slightly higher male predominant. And the most common histology is leiomyosarcoma, followed by liposarcoma and translocation-related sarcomas. As you can see, for the progression-free survival overall, the pazopanib seems to have higher with a PFS of 3.8 months, with trabectedin and eribulin a slightly lower PFS. In terms of overall survival, in terms of median OS, arm C, the pazopanib also has a numerically higher OS as compared with trabectedin and eribulin. And the objective response rate, interestingly, is that trabectedin does have a higher objective response rate of 17.6%, and pazopanib have 8.1% objective response rate, as eribulin has the lowest objective response rate of all 3 agents. In terms of reason of discontinuation of protocol treatment, most of the patients discontinue the protocol because disease progression. But if we see because of adverse events that patient discontinue, pazopanib actually has the highest number of patients discontinue because of adverse event. But if we expand this to see that include the patient refusal related to the adverse events. So the adverse events is not severe to that you have to stop the treatment by protocol. The patient refused to use the treatment because of adverse events. If we add these together and both trabectedin, eribulin, and pazopanib actually has a similar number of patients that were discontinued because of adverse events. In terms of specific histology, you can see that liposarcoma has, in terms of PFS and OS, that pazopanib has a longest PFS and OS. I think this is worth mentioning because in the pazopanib phase 3 study, liposarcoma was not included in the palette study. So what we're seeing here is kind of a demonstration that pazopanib probably has some efficacy in liposarcoma as well. In terms of Lima sarcoma, numerically, the median PFS is highest for eribulin, as well as overall survival is also highest for eribulin as well. For translocation-related sarcomas, trabectedin does have the highest PFS as well as OS. So it does seem that if you go specifically into details of specific subtypes, that these drugs are kind of based on what we have expected, and the others are similar when we saw. So in terms of discussion, JCOC 1A02 found that overall soft tissue sarcoma cohort, that pazopanib has the longest median PFS and median OS as compared with other agents. So overall, based on this selected randomized phase 2 study, the JCOC is going to select pazopanib as the drug to go forward to compare with gemcitabine and docetaxel. You in a phase 3 randomized phase 2 study to compare which one should have better results as a second line for advanced soft tissue sarcoma patients. So overall, these two studies in SARC 041, it has shown that abemaciclib could be considered as a treatment option for dedifferentiated liposarcoma patients. AE management remains critical, and although various second-line systemic treatments are available for advanced soft tissue sarcoma, no one treatment stands out in terms of efficacy. The phase 3 pazopanib versus GD could provide further insights into treatment selection. So lastly, I want to thank the Center of Excellence for Sarcoma and Sarcoma NDT team at NTUH, and I'm happy to answer questions.
Thank you very much, Dr. Tom, for the excellent talk. So our second speaker for today's session is Dr. Samreen Liaquat. She's a consultant medical oncologist working at Royal Darwin Hospital, Australia. She's also co-chair for the clinical trial unit and has a special interest in head and neck, lung, as well as skin cancer. She's going to talk about recent advances as well as management of head and neck cancer. Thank you.
Assalamu alaikum and good morning, everyone. Thank you so much for having me here. It's wonderful to be back in Lahore. And to be honest, if there is one thing common in Lahoris and medical oncologists, that would be we all have strong opinions about what the best option is. I have been given the task to discuss the advances from ASCO this year on the management of advanced head and neck cancer. And 20 minutes is a short time, but I'll try to focus on the advancements that I think are really important and are going to change the management of head and neck cancer in the coming future. So why does head and neck cancers matter? I never used to like head and neck cancers when I was training, and I always thought cisplatin is probably the only thing that medical oncologist has to know about head and neck cancer, but that's not really true. Head and neck cancers are morbid diseases, and probably one of those diseases where the impact of our treatment is probably as evident as the disease itself. The treatments are morbid, include surgery, disfiguring, cosmetic outcomes, radiation, chemotherapy. This is disproportionately common disease in low and middle income countries. And despite the curative intent treatment, about 50% of the patients reoccur. Most of the recurrences occur early in the first 2 years, and about a quarter will happen within the first 6 months. Most of the recurrences are regional, but distant metastases are present in about a quarter. Head and neck cancers presenting with de novo metastatic disease is relatively uncommon. And all in all, the metastatic relapsed recurrent disease has a poor prognosis. If your patient is a smoker or HPV negative, the prognosis is even poorer. So what is our current benchmark? What is our current standard of care in the management of advanced head and neck cancer? This comes from the KEYNOTE-048 trial using pembrolizumab platinum 5-FU. We now use that as a standard of care first-line treatment, at least where I work in the developed countries. Everybody with a metastatic disease should be offered chemoimmunotherapy or immunotherapy at least. But if you look at the results from the KEYNOTE-048 trial, they are not that impressive. With the pembrolizumab alone in the PD-L1 high population with a CPS of 20 or more, the response rates are sitting somewhere close to 20%. And overall survival, median overall survival is about 15 months. 5-year survivals are really dismal at 20%. When you combine immunotherapy with chemotherapy with the platinum doublet, this improves a little bit, particularly in terms of the overall response rates, which improve to 30 to 40%, depending on the PD-L1 expression. But the median OS remains the same, and the 5-year survival does not move much. So there is a 60 to 80% of the patient population that do not do well with the best that we have, with the chemoimmunotherapy. So probably our best is not the best. When the patients do progress on this treatment, what is the standard second-line treatment that you would use? There is no standard second-line treatment. We tend to do what we have not done before, a combination of another platinum with a taxane. Sometimes we tend to add on cetuximab to the combination drug if the patient is really fit and well. Unfortunately, cetuximab, where I work in Australia, is not funded in the second-line setting, so we don't have that option. For patients with the poor performance status, we go with a single-agent chemotherapy. Sometimes I use cetuximab, make my hospital pay for the drug. And sometimes we also use oral methotrexate or afatinib. I have never used afatinib in this setting. But what I want to highlight here is the high unmet need for the patients who are PD-L1 negative. What do we do for them? Patients who are high risk because of the early recurrence, HPV negative status. Yes, these drugs, they work for 20% of the population, they work really well, but what about the rest of the population? What about the patients who are ineligible to have immunotherapy? And what about those who relapse or progress early on our best combination? So surely we can do better, but to do better, we probably need better drugs, and we need better combination of the existing drugs. And ASCO this year was particularly exciting for me, at least as a head and neck medical oncologist, because there were a few new drugs on the horizon, which I think was really, really exciting and hopeful. So we all know that recurrent and metastatic relapsed head and neck cancers overexpress EGFR. EGFR is overexpressed in majority of the patients with the recurrent head and neck cancers, along with MET overexpression. And all in all, it portends a poor prognosis for the recurrent disease. MET overexpression in head and neck cancers is associated with increased proliferation, metastasis, immune evasion, and also resistant to the anti-EGFR therapy. When we use cetuximab as a single agent for the relapsed head and neck cancer, all we get is a response rate in between 20 to 25% and a median overall survival of 8.6 months. So probably EGF targeting alone is not enough. That's where amivantamab comes in. We are all familiar with amivantamab. It's already being used in lung cancer, in EGFR 20 insertions, and the relapse setting in the sensitizing EGFR mutation. Amivantamab is a good drug. It's a bispecific antibody with the dual targeting of EGFR and MET. And it also has some immune cell directing activity. So the first exciting abstract from ASCO this year was the pivotal results from the phase 1b/2 Origami study. Origami is a multi-cohort study, and the results that were presented at ASCO this year as an abstract were from the cohort 1 that used amivantamab alone in HPV-unrelated recurrent or metastatic head and neck cancers after they have progressed on our best treatment of chemoimmunotherapy. So all in all, the eligibility criteria was pretty standard. You had to have recurrent disease, no prior EGFR therapy, good performance status, and HPV-positive patients were excluded from this trial. They all had amivantamab subcutaneously, which is now the standard way of delivering amivantamab. The primary outcome of the study was overall objective response rates. And if you look at the response rates, they are actually pretty exciting. The overall response rate was sitting somewhere around 40%. About 15% of the patient had a complete response. And I would say in a disease that is morbid, even when it is locally recurrent, a response is really important. It helps us improve the quality of life of these patients. An impressive CR rate of about 15%. The responses occurred pretty early. Median time to response was about 6 weeks. Most of the responses were deep, as you can see from the waterfall plots, and they were durable. Most of the patients who did respond responded for more than 6 months, and one of the patients was still responding at 22 months. And in terms of the secondary endpoints, the toxicity profile was pretty consistent with what we know of amivantamab. The toxicity is related to the EGFR inhibition, MET inhibition, then some fatigue, hypocalcemia, and anemia. The infusion reactions were relatively uncommon because amivantamab was delivered subcutaneously. And though it was a secondary endpoint and the number of the patients was small, but looking at the curves of the progression-free survival and overall survival, I was excited to see that they are headed where we want them to head. A good, impressive median progression-free survival of 6.8 months. More than 50% of the patients were progression-free at 6 months, and more than 50% were alive at 1 year. And the median of overall survival was 12.5 months, which I would say is pretty reasonable compared to what we have with anti-EGFR alone. There is an ongoing phase 3 randomized trial in the first-line setting, Origami 5, which is comparing subcutaneous amivantamab with pembrolizumab and carboplatin with our current standard of care of chemoimmunotherapy with pembrolizumab. I would look forward to the results of this trial. Another very exciting and interesting drug discussed this year was Ficerafusp alfa. Ficerafusp is a bifunctional EGFR-directed antibody that is combined with the TGF-beta ligand trap. Head and neck cancers, the relapsed HPV-negative head and neck cancers, are pretty immune-resistant kind of disease. And the reason behind this is because these cells have a very fibrotic stroma, and they have a lot of immune exclusion. They are immunologically cold tumors. And that's why the response rates with the immunotherapy are not as impressive as they are in the lung cancer. And primary and secondary PD-1 resistance is pretty common. That's where Ficerafusp alfa comes in. So the TGF-beta ligand trap actually neutralizes the TGF-beta in the tumor microenvironment, while EGFR helps target the particular tumor cells. So dual effect from Ficerafusp alfa allows to break the physical and chemical barrier within the tumor microenvironment, allowing immune cell penetration and improving response rates with the immunotherapy, while providing the direct anti-tumor effects with the anti-EGFR treatment. And Ficerafusp alfa and the TGF inhibition is also meant to decrease resistance to EGFR inhibition by preventing epithelial to mesenchymal transition. Pretty early results from a phase 1b study, only small number of patients, 25 evaluable patients, where Ficerafusp alfa was combined with pembrolizumab in PD-L1 positive relapsed metastatic head and neck cancer. 2 results were presented at ASCO this year. And very impressive, deep, durable responses with an overall response rate of more than 54%. What was more impressive was that the responses were higher in HPV-negative patients, where the clinical benefit rate was approaching 86%. Now, I want us to remember that this is the poorer prognostic population for which the responses are relatively lower with our best available option. The progression-free survival and the overall survival was also relatively better in HPV-negative patients compared with HPV-positive patients, with a median PFS of 9.9 and a median overall survival of 21 months. This compares favorably with what we have at the moment. And I would say even what we have with the chemoimmunotherapy with pembrolizumab, where the median overall survival is just 15 months. There is an ongoing trial, which my center is participating in at the moment, Fortify Head and Neck 01. Ficerafusp alpha is being compared in combination with pembrolizumab alone for the first-line treatment of HPV-negative, PD-L1 positive, recurrent metastatic head and neck cancer patients. And this is a phase 2/3 trial with the primary endpoint of overall response rates and overall survival. I would await the result of this trial. Another important front in head and neck cancers discussed this year was AKT inhibition. So resistance, primary and secondary resistance to PD-L1 blockade in head and neck cancers is pretty common. And theoretically, it's probably being mediated through activation of regulatory T cells in the tumor microenvironment. And AKT pathway plays a critical role in Treg activation in head and neck cancer. So working on the concept that theoretically, if you inhibit the AKT pathway, you prevent the activation of the regulatory T cells, and you combine it with an immune checkpoint inhibitor, you could augment the responses by overcoming the resistance. The results from a phase 2 study of ipatasertib, which is a small molecule oral inhibitor of all 3 isoforms of AKT, in combination with pembrolizumab for the first-line treatment of head and neck, recurrent metastatic head and neck cancers, were presented this year. These patients were treatment naive, and they were stratified according to the PD-L1 CPS score. They received oral ipatasertib plus pembrolizumab versus pembrolizumab alone, with the primary objective of seeing the progression-free survival and safety. Not as impressive as amivantamab or ficerafusp, but still we see a signal of activity and a signal of positive response, with an improvement in the 6 months progression-free survival from 53% to somewhere around 62%. And in terms of the response rates, there was an improvement in the overall response rates from 17% to 40%. About 15% of the patients had a complete response, and the overall disease control rate was actually pretty good at 70% compared with 40% in the control arm. Side effects pretty standard with what we see with the AKT inhibition: diarrhea, fatigue, nausea, some elevation in the transaminases, pruritus. There was no grade 4 toxicity, and most of the toxicities were grade 1 to 2. So another important drug to look forward to. This trial I wanted to discuss probably because it's not going to change what I do for the management of head and neck cancer, but a very ingenious design, a trial done in India by, and presented at ASCO by Minajay Shah, which looked at the utility of ultra-low-dose immunotherapy combined with oral metronomic therapy versus carboplatin paclitaxel in platinum-sensitive recurrent or metastatic head and neck cancer patients. So what they did, they took good performance status patients with normal organ function who were being treated for palliative intent of platinum-sensitive advanced head and neck cancers, stratified by site, prior treatment, age, and gender. About 400 patients were randomized 1:1 to receive carboplatin paclitaxel. This is a suboptimal standard of care, at least in the developed part of the world, where upfront chemoimmunotherapy should be used. But they utilized chemotherapy versus oral metronomic therapy. They had rationale behind the use of all this oral metronomic chemotherapy, but a very unique choice of drugs, where they used methotrexate once a week, erlotinib once daily, celecoxib twice daily, combined with the low dose of nivolumab, 20 milligrams, every 3 weeks. With the primary objective of overall survival, the study was meant as a non-inferiority cum superiority trial. So it was to be tested for non-inferiority first, and if that objective was met, then a superiority testing would be done. Secondary objectives are overall survival, progression-free survival, response rates, duration of response, and safety. All right, that was pretty little time to discuss all the updates. So the primary endpoint, I'll just finish chop. Primary endpoint of overall survival was actually met. There was a 4-month absolute improvement of 4 months in the overall survival with a hazard ratio of 0.57. Overall survival was almost double at 1 year compared with the chemotherapy alone. Secondary endpoint, all positive study, improvement in the progression-free survival from 2.7 months to 5.5 months. Duration of response improved from 3.6 months to 11 months. Objective response rates were higher, and disease control rates were higher. Toxicity was relatively lower compared to the chemotherapy alone, and the quality of life was maintained all through the treatment and follow-up period. I will finish here now. Thank you.
Thank you so much, Dr. Samin, for the brilliant talk. Now let's move to some interesting abstract. So for abstract, I'm going to call upon Dr. Ammara Manzoor. She's a consultant medical oncologist working at NIBD Karachi. Thank you.
Assalamu alaikum and good morning to everyone. First of all, I would like to express my sincere gratitude to the organizers and the SMOP platform for giving me this opportunity. Today I will be presenting 2 abstracts. Now moving on to the first abstract. This is phase 3 trial evaluating ultra-low dose immunotherapy combined with oral metronomic chemotherapy versus carboplatin, paclitaxel, and platinum-sensitive recurrent or metastatic head and neck squamous cell cancer. I will quickly go through this trial as Dr. Samreen have already discussed. As you all know, head and neck cancer remains a major burden in low middle income countries despite different disease biology, having advanced stage disease presentation and higher risk of recurrence. Meanwhile, the access to the immune checkpoint inhibitor is extremely low, creating an unmet need for effective tolerable solution. So the study is aimed to determine that triple metronomic chemoimmuno regime, it improves the survival as compared to the carboplatin and paclitaxel in the platinum sensitive advanced head and neck squamous cell cancer in the first line metastatic setting. This is phase 3 randomized open label non-inferiority cum superiority study in which the platinum sensitive metastatic head and neck squamous cell cancer with ECOG performance of 0 to 2, they were randomized to 1:1 ratio to receive either standard carboplatin and paclitaxel PC arm or the triple metronomic chemoimmunotherapy TMC-I arm with ultra low dose immunotherapy consisting of 20 milligram per meter square nivolumab every 3 weeks along with weekly methotrexate and daily dosing of erlotinib and celecoxib with overall survival as the primary efficacy endpoint. Baseline characteristics were well balanced between the 2 groups. Majority of the patients were male and the median age was 49 to 50 years and approximately 80% of the patients, they have strong association with tobacco exposure. And oral cavity was the most common majority site with predominant histology of moderately differentiated carcinoma. And 50% of the patients, they were treatment naive, and rest half of the patients, they have received prior first line of therapy, either in the form of surgery, chemotherapy, or radiation therapy. And the results, as you can see in this Kaplan-Meier curve, there is the nice separation of the 2 curves, and with absolute difference of 4.1 months, with hazard ratio of 0.57 in the favor of TMC-I arm, and it also doubled the objective, it also doubled the 1-year overall survival. Similarly, clinically meaningful benefit was also seen in the progression-free survival with an absolute difference of 2.8 months, with that is corresponding with 53% reduction in the risk of death. And This benefit was also supported with the absolute improvement in the duration of response, that is 7 months, in the favor of TMC-I arm. This is the forest plot for subgroup analysis showing that the benefit with TMC-I was consistent across all major subgroups except the non-oral cavity primaries. And the benefit of TMC-I arm was consistent in all patients irrespective of PDL1 status. However, the magnitude of benefit was greater in the patients having high expression of PDL1. Beyond the survival, the use of TMC-I doubled the objective response rate as well as higher disease control rates, as you can see in this bar graph chart. Moving towards the toxicity profile, 37% patients in the PC arm, they have experienced grade 3 toxicities, including the anemia, neutropenia, thrombocytopenia, fatigue, and peripheral neuropathy, while only 3.5% of the patients in TMC-I, they have received grade 3 toxicities, including the transaminitis, hyperbilirubinemia, while only 1.5% toxicities were immune checkpoint inhibitor related. 80% of the patients after progression on the first line therapy, they received the subsequent therapy. However, the type of subsequent therapy was different. Intravenous chemotherapy was the most commonly used therapy in the TMC-I arm as the second line, while the triple metronomic chemotherapy and immune checkpoint inhibitor were in higher use in the PC arm. But the survival benefit with TMC-I persisted despite higher subsequent uses of immune checkpoint inhibitor in the PC arm. This is the cross-trial comparison of the different phase 3 trials in the first line that compares the 1-year overall survival and the hazard ratio. It showed that TMC-I have 1-year overall survival as 46.4% with hazard ratio of 0.57%. That is comparable with all other first-line treatment options. In order to conclude, TMC-I significantly improved the patient outcomes in terms of increased response rate, longer duration of action with fewer side effect profile, and while maintaining the quality of life. So TMC-I, it offers a practical, scalable, relevant first-line treatment option in the advanced head and neck squamous cell cancer. Now moving towards the second trial, this is another phase 3 trial. That is evaluating carboplatin-based versus cisplatin-based induction followed by the concurrent chemoradiotherapy in the locoregionally advanced nasopharyngeal carcinoma. As we all know, carboplatin has proven efficacy across multiple solid tumors. However, its role in the nasopharyngeal carcinoma was not well established. So this study is aimed to determine whether carboplatin-based induction chemo followed by the concurrent chemoradiotherapy is non-inferior to cisplatin-based treatment approach. In this trial, patients with stage 3 and 4A of nasopharyngeal carcinoma having the KPS score of greater than 20, they were randomized to receive they were randomized to 1:1 ratio to receive either carboplatin-based induction chemotherapy 2 cycles every 3 weeks, followed by the IMRT with concurrent carboplatin 2 to 3 cycles every 3 weeks, versus cisplatin 2 cycles of induction chemotherapy, followed by the IMRT with concurrent cisplatin 2 to 3 cycles every 3 weeks, with failure-free survival as the primary efficacy endpoint. Baseline characteristics were well balanced between the two groups. Majority of the patients were male, and the median age was 49, and approximately 95% of the patients, they have WHO grade 3 poorly differentiated carcinoma histology, and 2/3 of the patients, they have less than 2,000 copies of Epstein-Barr virus in both groups. Majority of the patients, as you can see, have the locally advanced tumor with predominantly T3, T4 tumor and having the nodal burden of N2, N3, overall stage of 4A, well balanced in both groups. In the results, as you can see in the failure-free survival, there's an absolute difference of 2%, but that is not statistically significant. However, this trial met its primary endpoint, that is predefined non-inferiority criteria, suggesting that carboplatin-based induction followed by the concurrent chemoradiotherapy is non-inferior to cisplatin-based treatment approach. This is the forest plot for subgroup analysis showing that there was no significant difference in the failure-free survival between the two groups. As you can see in these Kaplan-Meier curves, there was no significant differences have been observed in two groups in terms of overall survival, distant metastasis-free survival, and the locoregionally failure-free survival. Coming towards the toxicity, carboplatin arm, they have experienced less grade 3 toxicities including the anemia, neutropenia, nausea, vomiting, and nephrotoxicity, while the patients in the carboplatin arm, they have experienced more grade 1 thrombocytopenia. In order to conclude, carboplatin-based induction chemo followed by concurrent chemoradiotherapy is non-inferior to cisplatin-based induction chemo followed by the concurrent chemoradiotherapy in the patients of locoregionally advanced nasopharyngeal carcinoma, and these findings support the carboplatin-based induction chemo followed by concurrent chemoradiotherapy as a promising alternative treatment option for the locally advanced nasopharyngeal carcinomas. Thank you.
Thank you, Dr. Amara. Now let's move to the panel discussion, and we have some spectacular faculty here joining us for the panel discussion. Online, we have been joined by Dr. Tom Chan and also Dr. Hassan Hamid. So we have already introduced Dr. Tom. Thank you, Dr. Tom, for joining. Dr. Hassan Hamid is a consultant medical oncologist working at the Christie NHS Foundation, Manchester, UK. He has a special interest in sarcoma and rare tumor. And we will also be joined by Dr. Sadaf Charag. She's a consultant medical oncologist working at Hyderabad Medical Complex, Peshawar. And Dr. Hafiz Khush Naseeb. He's the director of Pinar Hospital, Faisalabad. So let's start with Dr. Hassan. Without any, oh, I'm sorry, Dr. Samreen. Dr. Samreen is also going to, yes, please, thank you. Thank you. So, Dr. Hassan, I just wanted to know your opinion regarding a patient who developed metastatic disease after completion of adjuvant imatinib in GIST. So, at which duration you think that we can re-challenge with the imatinib after progression or development of metastatic disease?
Thank you, Jamshed, for inviting me. It's always a pleasure to come back to your own cohort, to our own people. I think I would like to say that, as you just mentioned, that adjuvant imatinib, so the first protocol for these people is to have 6 monthly scans to make sure that we are picking up relapse early. And I think the basic principle in these situations is that these people have micrometastatic disease, which was responding to imatinib in the adjuvant setting. Even once the imatinib finishes, the more relapses we see in the first 3 years. So I think if in the presence of a KIT mutation, my inclination will be to restart imatinib, preferably if somebody has a relapse, because they have 6 monthly scans. So the first point to pick up and relapse is 6 months. So I will be inclined to restart imatinib. The second thing I would like to see is what's the KIT mutation status? Is it a sensitizing KIT mutation present? The third thing I would like to mention is that is this still oligo progression or solitary site of disease? Is there any scope of revisiting any resectable options? So I will be inclined to restart imatinib, potentially within 6 months, and in the presence of KIT mutation. As we just discussed, that we are moving toward precision oncology in GIST, which is very interesting.
Okay, thank you. Dr. Tom, we just listened to your excellent talk. You discussed the PEAK trials and bezuclastinib along with the sunitinib in the second-line treatment. And you showed a very good slide in which every mutation was responding. So are you going to change your practice based on this trial on Monday?
Oh, yeah. So I think now the FDA hasn't approved the PEAK combination yet. But I think once it's approved, I think it will be widely accepted. However, I do have to say that because it's a combination of the drugs, so on the side effects, we still have to be very careful about how the patient's tolerant to that. Although based on the adverse events from what we've seen in the clinical trial, I think most of the patients could tolerate that well. So I think it's going to be a kind of competitive landscape. And there are other second-line studies coming out, for those if they have exon 17 mutations. Probably we're going to see the result from INSIGHT, which is ripretinib versus sunitinib, as both are single agent in the second-line setting. So that's a molecular-guided treatment selection. And we still don't know whether the combo would fare better or the single agent would fare better with ripretinib and exon patient with KIT exon 17 or 18 mutation, the activation loop mutations. So I think these are kind of a fascinating time for GIST patients. We're again seeing the GSK compound. They maybe even go to first line, like I mentioned in the slide. So really, I mean, after kind of a silence of 3 or 4 years, we're really getting very exciting results from the field of GIST.
And you presented SARC-041 trial. I still can't digest that the control arm was just a placebo. How can we justify that? I don't know. How can we?
Yeah, that's a good point. I think that's also how in the plenary session, how the discussion was kind of brought upon that when they use placebo as kind of the control arm, is that kind of a good selection or not? But I think because at least in the United States, they have been experiencing CDK4 inhibitor, not only abemaciclib, but also palbociclib. So if you go to Memorial, I think they would tell you that for DDIF liposarcoma, if it's not like very rapidly or like, life-threatening disease, they may still consider a CDK4 inhibitor. So I think that kind of concept, and because the CDK4 inhibitor is already reimbursed in NCCN guideline, so I think that kind of concept is more applicable to the patients in the United States. Probably in Europe, again, I have a lot of European colleagues who think that maybe they should compare with doxorubicin. But if you go through the picture, for those who had not received prior treatment for abemaciclib, we can see that the DDIF liposarcoma, the PFS is around 60 months, which is still far better than the single-agent doxorubicin in the Bright Line study, which single-agent doxorubicin have about 7 to 8 months of PFS. So I still think that, based on the toxicity and based on its, kind of demonstrated in multiple studies, its work, the CDK4 inhibitor DDIF liposarcoma, I would still consider that as an option for patients with DDIF liposarcoma.
Thank you. So, Dr. Sadaf, in the same trial, the abemaciclib was used with somewhat high dose, around 200 milligram twice a day, and we routinely prescribe it 150 milligram twice a day in the breast cancer. And you have a very excellent experience regarding CDK4/6 inhibitor. What's your opinion regarding the tolerance? Because the dose is further increased in this trial. Do you think our population would be able to tolerate this?
So, in my opinion, like we've been using CDK4/6 inhibitors in breast cancer, and though it's mostly palbociclib, but we do have patients on abema, and the patients are tolerating this dose of abemaciclib 150 mg/d quite well. We do not get very frequent complications of cytopenias, etc. Though with abema, we do get some patients with diarrhea, which can be adjusted with dose reduction. So if a patient can tolerate 150 BD in our setup, and looking at the encouraging results of SARC-041 that achieved its primary endpoints and the secondary endpoints as well, so I think the patients will be able to tolerate 200 mg/d as well, looking at the benefits. Like you can go for dose adjustments if patients do get any complications of cytopenias or diarrhea, which is notably with abemaciclib. So looking at the efficacy and achievement of the primary and secondary endpoints, comparing it with the toxicity of chemotherapy, because what other options do you have in dedifferentiated liposarcomas? It's chemotherapy, and now that we know that it's mostly CDK4 driven, you have got this targeted therapy available, which has got much, much lesser side effects as compared to chemotherapy. So it's a very promising agent in the management to be considered.
Thank you. Dr. Samir, you denied that you are not going to change your practice based on a TMCI trial. So, but for it could be very valid in Australia, but what about the developing countries? Do you think we can adopt this strategy for the low dose, ultra low dose, the immunotherapy, where the cost is definitely a big issue? Because it shows 43% reduction in the risk of death, which I think was quite impressive.
Yeah, I agree, Jamshed. Yes, where I work, first-line chemoimmunotherapy in all eligible patients is a standard of care. And I would consider this comparator arm as suboptimal But these results are really pertinent and relevant in the low middle income countries where the access to immunotherapy is not universal and where most of the drugs are self-funded. I think these results are important and there is a signal of activity. The choice of the combination metronomic therapy is a bit unique and unusual, but I would agree it's a reasonable choice. I don't know how much nivolumab 20 milligrams costs in Pakistan at the moment, sorry for that, but I think it's a reasonable choice. And the toxicity was low, the responses were higher, the disease control rate was higher, and there was definitely some improvement in the progression-free and overall survival. So it would be a reasonable choice in our setting here in Pakistan, yep.
Thank you. Dr. Hassan, I think you are one of the PI for the PEAK study. So I just wanted to know your opinion regarding the PEAK study. Can you please share your opinion?
Yeah, I think I was just trying to add as well that what we are seeing now is a change in the natural history of disease, because these KIT inhibitors are moving from the second line setting to there's ongoing trial exploration of bringing them to first line. So we may see in the next 4 or 5 years precision oncology where the mutations will guide treatment decisions. And also, I think the second important question will be when people progress on these new drugs, bezuclistamab, or we need a new biopsy, we need to know which are the new secondary, tertiary resistances patients are developing and how to target them. So it's a complete change of landscape, and we don't know what's the role of third line regorafenib or ripretinib in these settings. So I think it's a very interesting time for patients with gastrointestinal stromal tumors. The whole landscape is changing. Although we do still await approvals from FDA, but these drugs are here to stay. That's what I could say.
Dr. Tom, so I have a question for you. In the JCOG, I think it's JCOG study, the sample size was quite small. It was around 40 patients. Are you going to change your practice because it showed pazopanib is somewhat superior?
Yeah, that's a good point. I think they designed this. I mean, I'm not specifically involved in this study, but I think the way they designed this is like a, kind of selected pick the winner design. So it's not like formally statistical testing which arm is better, but based on the numbers that they can have, I think they're showing that overall the PFS and OS, the number numerically that pazopanib is better. But I think what they want to do is select one of the 3 arms to go forward to compare in the phase 3 study with GemTax, which is gemcitabine and docetaxel. And I think that's what their main point is. I think a lot of them has, in Japan, gemcitabine docetaxel having a common practice. So they do want to come up with there's a choice. I think they have come up with, I'm not sure how intended this was, but at least they're seeing a targeted therapy versus chemotherapy. So I think at least you can have kind of different ways of thinking when the phase 3 study, probably what's the better one to select first as a second line study for advanced soft tissue sarcoma patients.
Thank you. Thank you so much, everyone. So due to the shortage of time, we are just winding up this session. And thank you so much, Dr. Tom Chen, for joining us, and Dr. Hassan Hamid, and for Dr. Samreen, Dr. Khushnasib, and Dr. Sadaf Chirag. Thank you so much, everyone, for joining us. Thank you.
Thank you. Glad to join. Bye.
Hello, everyone. This is me, Roha. It's my pleasure to welcome you all to the industrial talk and the scientific session brought to you by Getz Pharma. So the topic of today's presentation is rank L inhibition in oncology, translating
टी एग्जीबिशन एरिया में है।
Moving home? Easily transfer your Superloop service to your new address hassle-free. Choose same-day activation or schedule your move.
never, and I mean never, introduce yourself by saying your name.
Hi, everyone. I'm Sarah. I'm really looking forward to working with you all. Hi, my name is Sarah. Never, I mean never.
Panel is Ishan and Umair. So if I could call them once, if they don't come, I'll ask somebody else. मैं आता खास नहीं थोड़ा सा. तो मैंने कासिम पुत्र को कहा था. नहीं, सभा तो बहुत है. अच्छे क्वेश्चंस पूछे जैसे लर्निंग और क्वेश्चन फॉर द सेक होना चाहिए एंड देयर शुड बी नो कमेंट वो होता है आई डोंट हैव अ क्वेश्चन बट आई डू हैव अ कमेंट डोंट डू दैट
I would like to thank the organizers for inviting me.
चलें शुरू करें हमारे स्पीकर तो हैं अच्छा क्या हो गया अभी कुछ और हो रहा है
Let's get started. Thank you very much for showing up on time. उसमें से नहीं करेंगे बहुत टाइम लगेगा Dr. Najib. Once again, we're going to do the same thing. We're going to start counting. आप count करना शुरू करें मैं ये लगाता हूँ. Number designate करते जाएं.
1, 2, 3, 4, 5, 6, 7.
Remember.
9, 10, 11, 12, 13, 14. No 14. 15, 16, 17, 18, 19.
Yeah, 19. 20th, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32, men in black, 33, 34, 35, 36, 37, 38, 39, 40, 41, 42, 43, 44, 45, and 46. You have 45, 46, and now we're going to go do it. Between 1 to 46, just remember your numbers. The lucky winner is number 18. There you go. Congratulations.
हाँ हाँ जाए
ऑस्ट्रेलिया से आए और आते ही जो है
हाँ सीधा ऑस्ट्रेलिया से आकर लकी गाय
It's a tablet. Come. Please. Come. So he presented in Australia and now he's here for this thing. Hasn't slept. Thank you very much. Dr. Nerjis, the floor is all yours.
Yeah, so I'm going to announce from here to save time. Our first speaker is Dr. Irbaz Riaz. We all know him. Dr. Riaz is Assistant Professor of Medicine Oncology at Mayo Clinic, Phoenix, Arizona, USA. And his special interest is in genitourinary cancers, including prostate, but he also does kidney, bladder, and testicular. We know that he's a leading researcher in artificial intelligence, and he has presented on AI in previous meetings. Also, he works on clinical informatics and data science in oncology. So Dr. Abbas is going to talk about paradigm shifts in management of prostate cancer.
So good afternoon. I hope everybody had a nice tea and you're back ready to listen to some talks. I'll be talking about paradigm shift in the management of prostate cancer. I want to start by thanking Dr. Muzaffar and Society of Medical Oncology of Pakistan for this invitation to talk. My brief this morning is paradigm shifts. And what usually what we think about paradigm shifts is, it's a phrase that we use loosely. It just means a few good clinical trials. I want to hold it to a higher standard today. Let me show you what I mean. So I always start talking about prostate cancer by dividing it into states. So this is, all of us have some version of this workflow in our head, but if you look at this map, we think about prostate into these boxes. Localized prostate cancer is when we go for curative intent. Then we have biochemical recurrence where there's rising PSA, but you don't see any metastases on the scans. And then if there are florid metastases on the scan, we call it castration-sensitive prostate cancer, metastatic castration-sensitive prostate cancer. There's a non-biological entity in between where the patient has developed castration resistance, but there are no metastases on the scans. We call it M0, or non-metastatic castration-resistant prostate cancer. And then the last stage of prostate cancer, which is metastatic castration-resistant prostate cancer. So this has been the historic way of thinking about prostate cancer. Now things are moving. So you see the two new boxes, the purple boxes I've added there. These boxes have been defined by new imaging modalities. No change in biology. The prostate cancer remains the same. Just because we have better imaging techniques, now we need to think about these two entities in a different way. The first entity here is PSMA positive biochemical recurrence. These are the patients who developed biochemical recurrence, slowly rising PSA. If you did conventional scans, those were going to be negative, classic biochemical recurrence. But when you do a PSMA PET scan, you see 1, 2, 3 metastases. So this is because, at least in my practice, for almost every patient with biochemical recurrence, we get PSMA PET scans. So now this sort of sits adjacent to metastatic prostate cancer. The question always comes up, should we treat these patients as biochemical recurrence or should we treat them as metastases? The jury is out there. And then this M0 CRPC, this was a state in which the PSA was rising, but there were no metastases on conventional scans. And now, because we are doing more PSMA PETs here, this state is also shrinking. So I added green boxes here, or turned some boxes green, and added a new green box. And the reason why I turned some of these boxes green is where I have new evidence to talk about, or where there's a paradigm shift, or at least a change in guidelines, or upcoming change in guidelines. We have localized prostate cancer, where things are changing, and then MCSPC. And MCSPC is a separate concept of treatment holiday. There are some patients with metastatic prostate cancer now, where we can reasonably safely do a treatment holiday. So localized disease box is teal because Proteus pushed systemic therapy back into the surgery. So that's the first time really where we have an option of systemic disease with the prostatectomy or the prostate surgery. MCSPC box is teal because now it splits 4 ways. MCSPC is now becoming several subsets of disease. I'll talk a little bit more about it. Now we can divide MCSPC management by if they have BRCA mutation, if they have PTEN deficiency, if they have findings on PSMA PET scan, or based on genomic scores. I'll talk more about that. Last but not least, there's evolving concept of treatment holiday here. So there's a selected group of prostate cancer patients with metastases that you can safely stop treatment at some point. So all right, now let's go into the evidence itself for the localized disease. We start on the left-hand side of the map with localized disease, and that's where the plenary trial at ASCO this year was presented, the Proteus trial. So before I go into the Proteus trial, I quickly want to summarize where the localized disease sits. So when patients present with localized disease, the first thing that we generally do is we do NCCN risk classification. We try to think about risk categories. Patients who are very low or low risk categories, they usually go with active surveillance. In my opinion, it is underutilized. We can watch these patients safely for quite some time. And then for favorable intermediate disease, typically, you would do radiation with short course of, with no hormones, or you can do surgery, or active surveillance in some selected patients. At the level of unfavorable intermediate risk, you start thinking of adding small duration or 4 to 6 months of hormones, or you do surgery alone. As you go into high and very high risk, that's where you do intensified hormones with abiraterone and Lupron or something like that for 2 years. The key to note here is that hormones were given with radiation for last 20 years, 30 years. There were no systemic treatment options with the surgery itself. Proteus is the trial which has introduced the hormone option or the systemic treatment options for the first time with systemic treatment. So I'll talk a little bit about the design of the Proteus study because it helps us understand the results. About 2,100 patients, 2,000 patients, and they were either randomized to apalutamide or placebo on top of ADT for 6 cycles, surgery, and then another adjuvant 6 cycles. And after, at the time of reporting of the results, median follow-up was about 61 months. The trial had a complicated endpoint design. It is dual primary endpoints of PathCR and metastasis-free survival. So the results are interesting. Some people, are excited about this. Some people have tempered enthusiasm. If you look at the results of metastasis-free survival, the hazard ratio is 0.80. And if you look at the results of PathCR, the odds ratio is about 10 because PathCR went from 0.9% to 1%, 1% to about 8.9%, so about 10 times higher response rates on PathCR. But absolute difference is about 5% improvement in metastasis-free survival. And then there is risk of increased toxicities, about 10% increase in toxicities. Published in New England Journal of Medicine, it was published the same day as it was presented at ASCO, and the authors called it the new standard of care. But the question is it really a paradigm shift? If you look at the hazard ratios itself, there's a 20% improvement in metastasis survival with hazard ratio of 0.8. But I always like to look at the absolute numbers. If you look at absolute numbers, the difference in numbers is 78% versus 73% at 5 years. And there's no overall survival benefit yet. So you have to think about the cost and the balance. 12 months of extra apalutamide, about 10% increase in grade 3 or 4 side effects, and about 5% improvement in metastasis-free survival. Previous guidance was you do radical prostatectomy, then observe, and salvage on recurrence. Now, I think it is going to make it into the guidelines where high-risk and fit patients who are interested in this 5% benefit consider perioperative apalutamide. I don't think it is for every patient, but in carefully selected patients, I think this is a reasonable choice. All right, so I'll go back to now this smallish state of PSMA-positive biochemical recurrence. So biochemical recurrence used to be one box, as I showed you in the previous slide. EMBARK settled part of it in high-risk biochemical recurrence with rapidly rising PSA of a doubling time of less than 9 months, intensifying with enzalutamide, in addition to ADT, improves outcomes. So that's clear from EMBARK results. What's not so clear is because PSMA PET has split the box. So biochemical recurrence was conventionally was defined by negative conventional scans, and that's where the EMBARK results apply. But what happens if you have rising PSA, but 2 or 3 metastases on PSMA PET? EMBARK really doesn't answer that question. There has been a lot of debate on how to answer this question. Should we start systemic treatment in those patients? Should we intensify? Should we do SBRT to the metastases and just watch and see if the PSA response happens or not? Or you give systemic treatment and do radiation to these oligometastases. So the jury is still out. There are lots of small studies which are popping up here and there, but there's no definitive phase 3 to answer this question. But there's one phase 3 trial which is which has now started, which is going to answer this question definitively. So the bottom line is, rising PSA with clean scans, we used to do either observation or start systemic treatment in high-risk biochemical recurrence. And we were adding enzalutamide now in addition to ADT based on the EMBARK results. But now, all of these patients get a PSMA PET scan. The question becomes, should we radiate? I typically radiate oligometastases, and then based on patient preference, sometimes I add systemic treatment, and sometimes I just observe for PSA response. And this is where things have become most interesting, hormone-sensitive prostate cancer with metastases. A lot is happening in this space. It used to be one box. Now I'll show you how it is evolving quite rapidly. So this is the algorithm I used to treat, or I used for the management of metastatic hormone-sensitive prostate cancer. Everybody gets ADT plus one of the RPs, enzalutamide, abiraterone, darolutamide, or apalutamide. And then the question used to be, should we add docetaxel in some patients or not? And how do we decide? We decided by the volume of the disease on the conventional scans and timing of metastases, whether the timing is synchronous metastases, patient presenting with metastases, or the patient initially had localized disease and now they're recurring with metastases. If a patient had synchronous metastases, high volume disease, fit, I added docetaxel. Like, no real science behind it, just more clinical judgment, and you continue it, the RPs and ADT with 6 cycles of docetaxel unless there is castration resistance. So the algorithm is fairly simple. Everybody gets ADT plus RP, and then you add docetaxel in selected patients if they're chemo fit. But now things are becoming interesting. Now we have 2 positive trials, TALAPRO-3 and Amplitude, both met their primary endpoint of progression-free survival with hazard ratio of 0.48 and 0.63. So now the question is, the way these trials were designed, they included patients who have any of the HRR positive mutations, BRCAs, ATM, CHEK2s, etc. But there's always a question, there's a lot of discussion around it, that whether the benefit that we're seeing is just because of BRCA mutation or also includes other HRR mutations. That I'll talk a little bit more in my talk in this evening. But for today, this morning, there's only one structural point I want to make from this slide. MCSPC is no longer one disease. If there is BRCA positive, we should consider adding a PARP inhibitor. My understanding is the rate limiting step here in practice in Pakistan is not so much getting the drug now, it's testing for these alterations, and the testing is still low. I think it's really important to emphasize that the patients who have these alterations, we should look for these because these patients do so much better if we test and find this alteration. About a few weeks ago, we had PSMA addition study that was published. In PSMA addition study, patients are randomized to standard of care, which is ADT plus an RP, and patients are randomized to either placebo or to the Pluvicto or lutetium PSMA 617. And there was the crossover was allowed. And again, it's a positive trial for its primary endpoint, progression-free survival, hazard ratio 0.72. It's an open label trial and the crossover is allowed. Again, the hazard ratio is 0.72, about 28% benefit. The grade 3 adverse events, about the 10% increase, 51% versus 43%. So that becomes another option now. So now MCSPC intensification could be with a PARP inhibitor if there's BRCA mutation, or it could be with Pluvicto or lutetium if the PSMA PET scan is positive. You just need to have one positive lesion to qualify for this treatment. Another interesting subgroup that is evolving in metastatic hormone-sensitive prostate cancer is these patients who have PTEN activation. Because when there is PTEN loss, it activates the AKT pathway. And this AKT pathway activation means that patient is not going to respond to hormones, Lupron and RPs. So these patients tend to do very poorly on ADT plus RP alone. So this is why Capitello was designed to target these patients, and it turns out we have another positive study. Patients who have PTEN alteration determined by immunohistochemistry, that's important, not on NGS, on immunohistochemistry. These patients have a positive benefit in PFS. It's a toxic drug, not very easy to give. First of all, only 1 in the 4 patients that you're going to test, you're going to find this alteration, but then you have to watch very carefully for diarrhea, hyperglycemia, and rash. So, it's about 8 months benefit in progression-free survival. No survival signal yet, but remember, these trials are not powered to detect overall survival. These trials are powered to detect progression-free survival, and the toxicity is real. This is why in my algorithm, I say consider capivasertib. It doesn't have to be always that you have to give that treatment. And this is another aspect which is most interesting, at least for me. Historically, we've always thought about how do we escalate treatment. Now we're also thinking about how do we de-escalate treatment. Now we have a test that tells us the patients who does not need chemotherapy, who does not need intensification. There is a deciphered prostate cancer classifier that was validated on ENZAMET data, and if the score is greater than 0.5, these patients benefit from addition of docetaxel, and if their score is lower than that, there's not much benefit seen with adding docetaxel. Note the direction of the travel. For 20 years, biomarkers told us who to treat more. This one tells us who to treat less. Key point. This is a really important slide for the management of prostate cancer, and I always like to talk about it. This is the results from a SWOG trial about 20 years ago, published in 2006. 1,300 men with new metastatic disease, and they measured one thing: the PSA after 6 to 7 months of ADT. If the PSA was less than 0.2, there is a 75 months survival before, or 70 months before they progress. And if the PSA is more than 4, the duration of benefit goes down from 75 months to 13 months. That's a big difference for a test that costs almost nothing doing PSA and is available in every clinic. It gives very high quality prognostic information, and you can use this to guide the treatment. And this is where ADREAM study design is also very interesting. This is a study where design matters more than usual, because the selection is really the whole trial. You had to be on ADT and RP, and the PSA had to be undetectable for it after at least 18 to 24 months of treatment. So patient with metastatic disease on ADT plus RP for at least 18 months, if there is excellent response, PSA undetectable, no metastasis on the scans, you stop the treatment. And note the endpoint. The primary endpoint is testosterone recovery and off the drug. So you stop the drug, patient stays off the drug, and the testosterone recovers. Essentially, 41% of the patients were at about 18 months were still off the drug, and their testosterone had recovered. So I think this is a really transferable result for the practice. A treatment holiday costs nothing, restores testosterone and function, and removes the single largest recurring expense for a family paying out of pocket. So this is how the algorithm looks like for now. Backbone still remains ADT plus RP, unchanged. Then you stratify. If patient has BRCA1 or 2, I add a PARP inhibitor. If the patient is PSMA positive, I consider radioligand like Pluvicto or lutetium. PTEN deficient, I consider capi. And if decipher is more than 0.85, I consider adding docetaxel. I reassess at 6 to 7 months. If the PSAs are detectable, that's excellent prognosis. I still go to up to 2 years and then stop treatment based on ADREAM results if the disease response is still favorable. So this is really important. All right, when the evidence moves faster than the guidelines, if you look at what I just showed you, in last 4 months, there have been at least 5 or 6 practice-changing trials in prostate cancer. So ASCO has now moved the guidance to living guidelines, and I've been very heavily involved in this mechanism. My team has built an AI system that now works to constantly scan new evidence, and as soon as new evidence is available, we quickly synthesize it and present to the ASCO panel and keep the guidelines living. So I put a reference here for the living guideline for prostate cancer. It's updated almost in real time. It's published, a new version is published every 8 weeks. I deliberately stay very thin when I talk about castration-resistant prostate cancer. There is a lot of emerging evidence, but the key to understand is now what patients get in MCRPC is really determined by what they got in MCSPC. If the patients had ADT plus RP, the options are different. If the patient got a PARP inhibitor, the options are different. So it's a complicated landscape, but the key defining principle is treatment in MCSPC defines the landscape of MCRPC, rapidly changing. For living guidelines, please look at this version of the guidelines. So in summary, this is the map again. We have defined a new entity, which is PSMA positive biochemical recurrence, M0 CRPC is shrinking, MCSPC is now many diseases. You treat based on the biomarkers and consider treatment holidays. 3 things to take home. Number 1, we have new scans which are defining prostate cancer states differently, and lots of new evidence emerging rapidly. One of the key things that I would say as a takeaway is this year where we learned to stop in oncology. We always thought about adding more. This year we've learned when to stop. Our most powerful biomarkers are in the clinic. Look at the PSAs at 6 months for the treatment of metastases. Thank you very much.
Thank you, Dr. Riaz. We'll have the discussion in the end. Our next talk is by Dr. Syed Hussain. It's a pre-recorded talk because Dr. Hussain is traveling. Just a brief, we know him as well. He comes to Pakistan often. Professor and honorary consultant in medical oncology at University of Sheffield, UK. And his major areas of interest is urologic malignancies, clinical trials, early drug development, and translational medicine. Dr. Hussain, as we know, has also published extensively over the last many years. And his talk is on updates in muscle invasive bladder cancer.
Assalamu alaikum. Thank you very much for the kind invitation. I'm delighted to be part of the Best of ASCO 2026 meeting in Lahore, Pakistan. I'm sorry I could not be with you today as I've got some academic commitments in Australia in the last couple of days. But inshallah, we'll see you all very soon at this meeting next year or another meeting. So I will be talking to you about some of the major changes that have happened in muscle invasive bladder cancer, how perioperative treatment is going to take a center stage in all that, and we'll be discussing that in the next 20 minutes. These are my disclosures. Just to set the scene, in the background we know that neoadjuvant MVAC in this surgical series, way back in New England Journal of Medicine paper in 2003 had shown that there's significant benefit with the use of chemotherapy before surgery, median survival of 77 months versus 46 months. And the MRC neoadjuvant trial also showed continued benefit, 6% survival benefit at 3 years, 5 years, and 10 years. But that 6% survival benefit and the data that I showed you from Grossman's surgical series did not let universal uptake of perioperative neoadjuvant chemotherapy and adjuvant treatment in this sort of a setting. And the reason was that 50% of patients still experience recurrences or progression following radical cystectomy. The survival benefit, 5 to 8%, was considered modest in this sort of a setting. There was restricted patient population. For example, in UK, we could only get adjuvant nivolumab if they were PDL positive. And I think there's a need for better stratification and selection of these patients for perioperative treatment as well, whether ctDNA can take a center stage. So there are a lot of factors and things that will come into play in coming years, and a lot of areas of research that we can all contribute to continue to improve on the treatment outcome for these patients. The Niagara study was one of the key studies which added durvalumab with neoadjuvant cisplatin plus gemcitabine chemotherapy treatment. A split dose cisplatin was allowed in that trial as well for patients with GFR 40 to 60. And the key rationale is that chemotherapy modulates the immune response by various mechanisms, stimulating dendritic cells, inducing immunogenic cell deaths, and stimulating T cell activation. Similarly, a PD-L1 antagonist with chemotherapy may amount an effective anti-tumor effect as well, with promoting antigen presentations, increasing production of protective T cells, or overcoming immunosuppression. So a lot of reasons and rationale for that, and I think that was really an exciting trial that used durvalumab in perioperative setting in combination with gemcitabine and cisplatin, and patients with impaired renal function, gemcitabine and split dose cisplatin with durvalumab. That was given for 4 cycles, followed by cystectomy, followed by 8 cycles of adjuvant durvalumab treatment at 4 weekly intervals. The primary endpoint was event-free survival and path-CR. Secondary endpoints were overall survival and safety and other factors as well. The trial was very well balanced, as you would expect in a randomized trial. The median age was 65, in this trial. And again, you can see that GFR 40 to 60, 20% almost of patients had a GFR of 40 to 60 mils per minute. Again, you had 14% of patients with histology, with mixed variant histology as well, apart from urothelial cancer, and 5% had nodal disease as well. So quite a mix of sort of a patient population that you see. The only thing I will add on, in real world practice, you see almost 1/3 of the patients whose GFR would be 40 to 60 mils per minute, or will be called a full dose cisplatin ineligible because maybe hearing issues or other factors that may make them ineligible for full dose cisplatin. This is the key slide. What it shows is that event-free survival significantly improved in experimental arm with the use of durvalumab in perioperative setting, 12 months 69% versus 76%, and at 24 months 59.8 versus 67.8, event-free survival with a hazard ratio of 0.68. This translated into significant improvement in overall survival as well, and you can see the curve separating further between 12 months and 24 months, from 86.5 to 89.5% at 12 months favoring the experimental arm, to 75.2% in the control arm versus 82.2%, 24 months overall survival in the experimental arm, with a hazard ratio of 0.75. These are key findings because these will drive the change in the use of perioperative neoadjuvant treatment. As I said, that previously there was a little bit of a sort of lack of enthusiasm when gemcitabine and cisplatin or MVAC was the only treatment in perioperative setting, but because of the 6% survival benefit that was seen, 6 to 8% was considered modest survival benefit, though I always say that it was big enough and we should have taken more of those patients towards perioperative treatment. But I think now with the addition of durvalumab and the evidence showing event-free survival hazard ratio 0.68 and overall survival 0.75, these are key changes that are happening. But it's important to see what is the cost of toxicity. Does it delay cystectomy? Does it have an impact on cystectomy at all? Because cystectomy remains the key treatment in this setting as well. Perioperative treatment is an additional treatment that is adding into the survival. And at the minute, we need to be very careful that the curative primary modality of treatment is radical cystoprostatectomy or radical chemoradiotherapy treatment. Again, this trial, Niagara, and some of the other trials that we'll talk about focuses more on the cystectomy patients. EFS benefit favored across subgroups. And even if you look at the patients with renal function, the hazard ratio is 0.69 for patients with GFR 40 to 60. Histology, mixed urothelial cancer, variant histology, mixed with urothelial cancer, the hazard ratio is 0.52. So again, these are really important figures that tells you that across the subgroups, we are seeing the benefits in patients who had additional durvalumab treatment. And again, overall survival that was seen in the same way. In terms of the overall survival in impaired renal function, the hazard ratio is 0.89, but that perhaps reflects the patient groups as well. So it did impact on event-free survival, not so much in OS, because these patients are usually less fitter and a bit more elderly patients as well with a poor GFR. And sometimes they're present with hydronephrosis, big kidney, a big bladder tumor leading to this swelling of the kidneys, hydronephrosis as well. Hydronephrosis is a known poor prognostic indicator. So overall, this is a really exciting trial. In terms of the path-CR rate, we see in patients who underwent radical cystectomy, 33% versus 42%, and those were overall intention to treat 27.5 versus 37.3. So really important, meets the endpoint, meets the primary endpoint in terms of dual primary endpoint of path-CR and event-free survival. If you look at the adverse event summary, again, we don't see any new safety signals with the addition of durvalumab, which is important. There was not much delays in patients undergoing surgery, nor there was patients who did not undergo surgery. In fact, if you look at the safety toxicity, there are no new safety signals. It was very well tolerated. So addition of durvalumab was not leading to any significant toxicity that was causing any delays or any issues with the uptake of the radical curative treatment, which is cystectomy in this setting. Durvalumab had no impact on patients to undergo radical cystectomy. As you can see, 79% of patients completed neoadjuvant chemo and 88% underwent cystectomy in the experimental arm and 83% underwent in the control arm. So this was really good that additional durvalumab did not compromise the use of cystectomy. There was no additional delays, 5.6 weeks versus 5.4 weeks, and median time from randomization to radical cystectomy 16.3 weeks versus 16.1 weeks. And 90% of patients in both experimental arm and control arm had their cystectomy within 56 days after last dose of neoadjuvant chemo. Again, if you look through some of these toxicities, you can see there's no extra sort of a new safety issues. There were no other additional toxicities that we could see here. There was no significant delays in surgery as well. And DFS was improved with the additional perioperative treatment in both patients who had PAT-CR and non-PAT-CR groups. Both benefited from the use of durvalumab treatment, and the control arm, compared to the control arm, the experimental arm outperformed whether patient had a PAT-CR or had no PAT-CR. Similarly, it provided benefit regardless of the ctDNA status as well. So these are important figures. The hazard ratio 0.43 and 0.73 does tell us that actually durvalumab is not adding significantly to toxicity, but significantly adding to the effectiveness of perioperative treatment. So I think Niagara really tells us that perioperative durvalumab plus gemcitabine cisplatin is the standard of care treatment. It's the first phase 3 perioperative IO plus NAC trial, neoadjuvant trial in invasive bladder cancer that has shown statistically and clinically meaningful improvement in event-free survival and overall survival. It was well tolerated, no impact on cystectomy. There was no delays in cystectomy because of durvalumab. And at the minute, current evidence does not support the use of ctDNA in this trial. Again, there were trials like we will talk about IMvigor011, which was designed for ctDNA, 6-weekly ctDNA, that did pick winners in that sense, that those patients who can be de-escalated within IMvigor011 trial. But overall, the field is changing. We have got Niagara reported. Keynote 866 will be coming out, but that there is some release that tells us about a negative trial. Energize with nivolumab is negative as well. EV304 and 303 I will discuss very shortly as well. IMvigor011, I just wanted to mention that this was an exciting trial based on ctDNA. If they were ctDNA positive, but CT scan negative, they were randomized 2:1 to atezo versus placebo, and that was a positive trial. But again, this trial was focusing on 6-weekly ctDNA, and that is important to see. And as in Niagara, the primary endpoint was event-free survival and PAT-CR. Here, you are looking at based on ctDNA. So unless the trials are designed in that, Tembola or other trials, we cannot really say that Niagara and other trials, we can basically de-escalate treatment based on ctDNA status. EV905 was in cisplatin ineligible patient population. Remember, this trial started with pembrolizumab as the experimental arm, followed by adjuvant pembrolizumab. Then enfortumab vedotin was added. Then a further subset of patients were added, patients who decline cisplatin-based neoadjuvant chemotherapy treatment. So there are multiple iterations in the trial as we went along. And allocation to the treatment of pembrolizumab alone arm was stopped in November 2022, and EV plus pembro versus EV plus pembro versus standard of care, which was in those cases, if you call them cisplatin ineligible, they were cystectomy. But as I said, there is a subset of patients who declined. Their GFR was quite good, as we know that a number of these patients had actually GFR above 60 mils per minute. So they were much fitter and better patients in that sense. It did show significant improvement in event-free survival with a hazard ratio of 0.40 and overall survival with a hazard ratio of 0.50. And again, these are important figures. These are really exciting, that and PAT-CR rate of 57%. So again, within that group of patients with PAT-CR of 57%, this is really exciting, that in patient group who are cisplatin ineligible, who otherwise do not do very well, and they had cystectomy as the only treatment option, there was no role of neoadjuvant treatment, although within this trial, one has to be aware of the subset of patients who were declining cisplatin or were called cisplatin ineligible for various reasons like hearing impairment and things, although their renal functions were reasonably good. In terms of safety and toxicity, it is important to learn from what we have seen in metastatic setting. Again, we can see there were significant dose reduction, and 41.3% had discontinuation of enfortumab vedotin as well in this experimental arm. EV304 is in cisplatin eligible patient population, so it's EV plus pembrolizumab followed by adjuvant enfortumab pembrolizumab, while in the control arm it was gemcitabine cisplatinum followed with observation afterwards. And again, within that, in terms of the where adjuvant nivolumab was available, that was added on into that as well. But again, very small percentage of patients received adjuvant nivolumab in that sense because certain countries needed it for PDL positive patient population only, like UK and some other countries as well. But 808 patients, 405 in EVP, 403 in CISGEM. It's really interesting to see that how many started treatment, how many completed treatment. 262 started out of 403 adjuvant phase of EVP. 208 completed, 54 discontinued. We really need to see how many had EV, how many had P. And that is important to look at because toxicity will be depending on those sort of things as well. Hopefully we'll discuss in our Q&A session later on. Again, what was the reasons for no surgery and things? It was generally, again, well designed study, extremely well balanced. But again, you can see that number of these patients had GFR greater than 90 mils per minute. So they will be much more fitter patients, perhaps more younger patients in that sense, although the median age is very similar, 66. But there is a number of patients, about 40%, 36.8%, who had a GFR greater than 90 mils per minute. Again, really exciting results. We are seeing hazard ratio of 0.53 for event-free survival, and overall across subgroups it shows that the benefit continues across the subgroups. Overall survival hazard ratio 0.65. Remember, the hazard ratio for overall survival for Niagara, GEMS plus CIS plus durvalumab is 0.75. And I think in terms of toxicity profile, one has to be very careful with enfortumab vedotin and pembrolizumab, especially number of patients who may have significant toxicities that may either delay cystectomy or that can, in real world practice, that will be really important to keep an eye on. Overall, this trial across subgroups showed benefit, which was quite useful to see. PATH-CR rate again was very high at 55.8%, but remember all these patients were undergoing cystectomy. That was the primary treatment with perioperative EV plus P, and it is important to remember we cannot exclude cystectomy from these studies. They can only be looked at within clinical trials where you're looking through them cystoscopically, ctDNA-wise, and scan, imaging them regularly to see if they're keeping their bladders with good response on imaging or cystoscopy, then it has to be done in a trial. EV209, a trial is looking at those patients who are keeping their bladders after a good response to EVP. Again, you can see the number of patients who could need treatment are significant. Number of patients who had significant events, toxicity are quite high numbers as well. But patients did have significant benefit, and that is a very exciting study as well in that sense. But there are factors like maculopapular rash, 20.6%, and you can see some grade 3-4 toxicities as well. Similarly, there was events of neuropathies as well that was seen. So in drug-related AEs of special interest with EV, skin reaction, neuropathy, ocular disorders with AE, with pembrolizumab was pneumonitis and other factors. But it was overall well tolerated, but there are toxicities. These patients can be cured by surgery alone. We have to be very careful as that what is the additional treatment that we are giving, what is the cost of toxicity. Economic cost is important, what is the cost of treatment, but also what is the cost of toxicity. Both are important to look at. So really exciting new developments have happened. A lot of new drugs like Niagara is a new standard of care. We've got EVP if it's available, but remember 80% of the world still don't have first-line metastatic EV plus P available, and we need to be mindful of those factors as well. Neuropathy, I wanted to mention, it is based on metastatic disease setting, but you can see that 41% had residual skin reactions and 27% had still a grade 2 or more skin reactions of those who had skin toxicity. Similarly, those who had neuropathy, 14% had complete resolution, 86% had residual, and 51% had grade 2 or more. And grade 2 neuropathy, you will struggle to button your shirt, you will struggle to use your phones and your computers. So it's important to look at these as well. More recently, Volga press release has come in with looks at Durva and Tremi with EV in cisplatinum ineligible patients. What is really important, and that group also had those who refused cisplatinum, is that it is a de-escalation in a sense that you use Durva Tremi or Durva alone with EV, but that is used only for 3 cycles. and then you have cystectomy, and then you basically use 9 cycles of durvalumab alone. So in a sense, what this study, which is a positive trial, which has been reported as a press release, which you may have seen on 15th of May this year, that shows that actually Durva plus EV plus P for 3 cycles in perioperative setting met the primary endpoint of EFS and key secondary endpoint of OS, while Durva plus Tremi met EFS but not the OS, although more updated data will be looked at as well. Gusto is subtyping of bladder tumor. This is a trial that is being run by Sheffield, myself, Jim Cato, lead on it, and with Simon from Southampton. So we are leading this trial, and this has now screened 233 patients, subtyping done, and 125 patients have been randomized. What is key is that patients are receiving perioperative chemotherapy with chemotherapy plus durvalumab plus tremelimumab, or if they are luminal infiltrated, they are randomized to durva plus tremi alone versus standard of care chemotherapy. If luminal papillary, standard of care treatment versus surgery alone, and neuronal again durva tremi plus neoadjuvant chemo versus radical treatment alone. So standard of care chemo plus radical treatment. So based on subtyping, that will be quite key and exciting to look at. That will be de-escalation for some patients who will go straight to cystectomy. INVEST is a phase 1 window of opportunity trial, which is looking at patients who are going for cystectomy, whether they are muscle invasive or non-muscle invasive. For muscle invasive, they have to be cisplatin ineligible. And those patients can basically receive intravesical or intratumoral injection of atezolizumab. We started with single dose, then we used to multiple doses, 600 milligram weekly. Now we are at 1200 milligrams weekly, maximum 6 injections. And I can tell you some of that data we presented at ASCO GU, the reference is there. But what I can tell you is that there's no dose limiting toxicity. We are not seeing any toxicities that will be systemic toxicities, and we are deriving significant encouraging benefits as well. This is all possible with a close working relationship between urology and oncology. Multidisciplinary team is key. Here I am with my colleague Jim Cato. I'm not doing robotic surgery, but he comes to my clinic. I sometimes go to his theaters, and similarly, we share each other's practices. We have a joint sort of a parallel clinic that runs where he has his own patients, I have my own patients, but we do discuss cases as we go along. This helps in clinical trial recruitment. This has been a key figure where we have been lead recruiters. INVEST is a single center study. We have recruited 28 patients already for that window of opportunity trial. And Gusto, out of the 125 patients recruited in 20 sites in UK, we have recruited about 38 out of those 125 patients. Key thing will be that shared decision making is important. Patient and disease characteristics have to be looked at for perioperative treatment, and what are the available first-line treatment options will be key as well. If you have access to EVP, if you're using then Gemcis, durvalumab, then if a patient relapses a year, 2 years down the line, EVP may be available as first-line treatment. But it all will depend on what is available as well. But best treatment choice for each individual patient is key. And that is where I will stop. We'll be very happy to take questions later, but delighted to be part of it. And again, thank you very much to the organizing committee for your kind invitation.
All right. So now we have this abstract discussion. The first one is going to be presented by Dr. Ramesh Samar from SIUT. Dr. Ramesh, aa jaye upar.
Good morning, everyone. I will be presenting single abstract titled as an artificial intelligence-based pathology classifier, abbreviated as EPIC, to predict benefit from enzalutamide in metastatic hormone-sensitive hormone-sensitive prostate cancer. Results from ENZAMET study. The lead investigator of this study is Dr. Sebastian R. Medina. So as already told by Dr. Irbaz, ADT and ARPI have been the standard of care for metastatic hormone-sensitive prostate cancer. Despite this combination, there are patients who might not respond to this and thus require treatment intensification. Identification of such patients require biomarker, and currently there is none available in hormone-sensitive prostate cancer. So what the researchers thought of, why not use H&E stained tissue? Why? Number one, first, it is routinely available from diagnosis, and secondly, it is rich in morphological and spatial information. So what they did, they applied a biomarker on H&E stained tissue and developed EPIC. EPIC is an AI tool that comprises 6 spatial and morphological features. They are designed to quantify immune organization and tumor heterogeneity. These are the 6 factors on which EPIC is based. They include nuclear morphology, immune cells organization, nuclear size and shape. So it is safe to say that EPIC was engineered to be interpretable with features describing underlying biology. So when EPIC was being developed and validated, the hypothesis was that variations in nuclear morphology and immune microenvironment would have differential treatment sensitivity. So what they did, they applied EPIC retrospectively to the population of CHARTED trial, the trial that showed this benefit of ADT and docetaxel in high volume, hormone-sensitive metastatic prostate cancer. Also, there were patients who had delay in castration resistance as well within the same subgroup. So when EPIC was applied, EPIC divided patients into EPIC negative and positive. Among those who were positive, they were found to benefit in terms of overall survival and castration resistance delay in high volume group, as well as low volume group in terms of castration delay. So EPIC successfully identified a subset of low volume patients who had delay in castrations with docetaxel and ADT. Coming to the present study, ENZAMIT was a phase 3 clinical trial which randomized patients to ADT plus first-generation non-steroidal anti-androgens or enzalutamide. 1125 patients were enrolled in that trial, of which 633 were excluded, majority due to non-availability of H&E stained tissue. So overall, 492 patients were analyzed for treatment biomarker interaction, sensitivity, multivariable analysis, and circulating cytokines. Coming to baseline characteristics between the cohort studied as well as the overall cohort, there weren't any significant differences. Of note, I would like to state that majority of the population was from Australia and New Zealand. They had Gleason scores of 8 to 10, and majority did not have visceral metastasis on diagnosis. The primary endpoint was overall survival. So as we can see, the patients are divided into 2 subgroups. EPIC negative comprised 64% of the biomarker cohort, while the remainder were EPIC positive. Among those who were EPIC negative, we see that the curves separate early on at about 20 months' time, and they remain so over 5 years. There is an additional 18.2% in 5-year overall survival with the use of enzalutamide, whereas if we talk about EPIC positive patients, they have a detrimental 3.2% 5-year overall survival with the use of enzalutamide. So EPIC identified at least 2/3 of patients who could have avoided treatment intensification with non-air directed therapy. So what about those patients who did not have docetaxel at all? We tend to see that they comprise 63% of the biomarker cohort in terms of EPIC negativity, and they had an additional 21% 5-year overall survival with the use of enzalutamide. I would like to emphasize upon HR, that is 0.4% for 0.4 for this EPIC negative group that did not have docetaxel use, as opposed to the overall population whose hazard ratio was 0.5. So what we can conclude is that the benefit of enzalutamide remains even when early docetaxel treatment is excluded. Coming to treatment biomarker interaction, here we see a significant interaction in terms of p-value being 0.014, depending on EPIC status. The most pronounced effect was seen in patients who were not only EPIC negative, but also had low volume disease. Similarly, in multivariable analysis, enzalutamide remained significantly beneficial with a 48% reduction in the risk of death. And in terms of treatment and biomarker interaction, when clinical parameters were adjusted, it remained significant with a p-value of 0.016. Here we have 2 things. On the left, we have a scatter plot, and on the right, we've got 6 images. First, I'll be talking about scatter plot. Each dot represents a separate tumor sample. There are 2 colors. The darker color is denoted by EPIC positive patients. The light blue color is for EPIC negative patients. On x-axis, we have lymphocyte, non-lymphocyte spatial ratio, while on y-axis, we have EPIC score. So what this graph emphasizes is that the more the EPIC score, the less lymphocyte ratio it is. And vice versa, the less EPIC score is, the more lymphocyte to non-lymphocyte spatial ratio. Now on the right side, I would like you all to focus on the middle images in both the rows. In EPIC negative population, this is H&E stained tissue, which also has significant areas in green. These green areas are immune cells. Whereas in EPIC positive patients, the H&E stained tissue does not have as much green areas, suggesting that EPIC negative disease is associated with lymphocyte-rich environment, whereas EPIC positive disease is lymphocyte depleted. So safe to say, EPIC score is inversely associated with immune infiltration. In terms of circulating immune cytokines, EPIC positive patients are found to have an elevated plasma myeloid progenitor inhibitory factor, MPIF1. This is a chemokine that has negative effect on hematopoietic stem cells, and it is associated with poor prognosis in metastatic hormone-sensitive prostate cancer. So together, these findings suggest that immune cold phenotype in EPIC positive patient contributes to its poorer outcomes and limited response to enzalutamide. So key takeaways are, EPIC is an AI biomarker which is computable from routine H&E. EPIC negative patient is associated with OS benefit from adding enzalutamide to ADT. EPIC positive patients defines a poor prognostic group, so remember, P for positive, P for poor prognostic group, and they benefit with addition of non-ER directed therapy. This trial had its limitation. Only 43.7% of biomarker cohort was available. There was limited ethnic diversity in Enzamet and Charted combined. And also, as this was a retrospective study, prospective validation is needed. These are my acknowledgements, and thank you.
Our next discussant is Dr. Maliha Ashfaq from Civil Hospital, Karachi, and she'll be discussing her abstract.
So, Assalamu alaikum. And a very good morning, 3 minutes to a very good afternoon. So let's thank you, Dr. Narjis, for the introduction and the opportunity. So let's begin. So the first abstract I'll be discussing is the 3.5-year follow-up and response analysis from the phase 3 trial EV302. It was a phase 3 multi-center trial involving multiple global sites. This trial compared enfortumab vedotin plus pembrolizumab to chemotherapy, platinum-based chemotherapy, for treatment-naive patient of locally advanced or metastatic urothelial carcinoma. So a little background, EV302 Keynote A39 study established EV plus P combination as a standard of care for first-line treatment locally advanced metastatic urothelial carcinoma, as it showed significant benefit in OS and PFS versus platinum-based chemotherapy. However, long-term data was definitely needed in order to establish whether efficacy benefits are maintained, safety profile is maintained, and deep responses continue to show durability. So an updated efficacy and safety analysis after a 3.5-year median follow-up was presented. Also, exploratory analysis was done in those patients who initially achieved a partial response and then went on to achieve a complete response, and those who took this treatment for more than 1 year or for more than 2 years. So the study design, 886 patients were recruited of untreated locally advanced metastatic urothelial carcinoma. These were eligible for EVP and chemotherapy, platinum-based chemotherapy. They were checkpoint inhibitor naive patients, optimum GFR, and a good ECOG status. They were randomized to receive either EV plus P till disease progression or platinum-based chemotherapy for a maximum of 6 cycles. The primary endpoints were PFS by BICR and overall survival, and they were further stratified according to cisplatin eligibility, CPS scoring, and liver metastasis. So this is a Kaplan-Meier curve for the overall survival. We can see that the graphs are very well separated, and at 3.5 years, an estimated 44% patients were EV plus P were alive as compared to 25% patients in the chemotherapy group. The median overall survival previous reported was 33.6 versus 16 months. So in the EV plus P arm, all the 43% of the patients who went on to receive subsequent treatment, 30% of these received platinum-based chemotherapy. we can very well see that in this subgroup of patients, the objective response was 21%, and they had a median OS of 10.9 in the subsequent setting. So in the chemotherapy arm, of the 73% of the patients who went on to receive subsequent treatment, 60% received checkpoint inhibitors. Of these, half received maintenance evolumab and half received pembro and atezo. So we can very well see that the complete responses in the EV plus B group were double as compared to chemotherapy. Numerically, these were 30 versus 15%. So the baseline characteristics were very well balanced in those patients who achieved complete response in the EV plus B group as compared to the intention to treat population in terms of age, ECOG, primary tumor location, metastatic disease, and cisplatin eligibility. We can see that those patients who had liver mets, a little proportion of those patients also achieved complete responses. On the left-hand side of the screen, you can see that the cumulative complete responses, they increased over time. And the reason was that on the right-hand side, you can see the blue bars are the partial response. So increased number of partial response were converted to complete responses, which are the green bars. And once complete responses were achieved, only few of them progressed to receive subsequent treatment. So this is documenting the durability of the complete responses. So these are the two graphs which are showing those patients who achieved complete response directly and those who achieved first partial response and then complete response. The survival was the same, translating to the fact that once CR is achieved, it translates to a survival benefit. So at 1 year, 42% of the patients were still on treatment of EV plus P, and at 2 years, a remarkable 23% patients still were getting this treatment. But you can see in the lower half of the slide that 70% of these patients received some dose modification in order to remain on treatment for such a long time. The safety in patients who were able to stay on this treatment for more than 1 year or 2 years was similar to intention treat population, albeit this came with a lot of dose modifications. So some treatment-related adverse events of special interest for EV is neuropathy, as mentioned previously in the lecture, peripheral neuropathy, motor neuropathy, and skin reactions. So there was a moderate increase with, of course, long-term treatment. So in conclusion, of course, at 3.5-year follow-up, EV plus P demonstrates superior overall survival. Platinum-based chemotherapy was the most common subsequent treatment use. Complete responses increased over time, and the survival was the same whether it was achieved directly or after partial response. And it had a consistent and manageable safety profile, concluding that enfortumab vedotin plus pembro is associated with durable and clinically meaningful outcomes in metastatic urothelial carcinoma. Quickly moving to the next abstract is the final analysis of the Protease 3 study. This was already briefly touched on by Dr. Baz. So this is perioperative apalutamide plus ADT versus ADT alone with radical prostatectomy in high-risk localized or locally advanced prostate cancer. This was also a multi-center trial. Now, a little background: despite refinement of radical prostatectomy as a curative intent treatment for patients with high-risk disease, more than half will relapse. So development of METs is associated with poor prognosis, and median time from the development of METs to death has been shown to be 3 to 5 years. So apalutamide is effective in castrate-sensitive and resistant prostate cancer, and it has shown favorable activity in neoadjuvant setting. So Protease was designed and conducted in order to evaluate whether the addition of 1 year of this apalutamide in the perioperative setting plus ADT versus ADT alone would improve the response and the long-term outcomes. So 2,100 patients with high-risk localized prostate cancer was randomized to receive 6 cycles of either APA-ADT or ADT alone. Then they underwent radical prostatectomy, and then they were to receive 6 more cycles of the respective regime in the adjuvant setting. PSMA PET and PSA were done every 3 monthly, and also these were stratified on the basis of nodal disease, Gleason score, and the region of the world they belonged. So we had 2 primary endpoints. One was the PCR and the minimal residual disease and the metastatic-free survival. A number of secondary endpoints were there, including event-free survival, time to first subsequent therapy, time to distant mets, no evidence of disease at 4 years, and metastasis-free survival by conventional imaging. So the baseline characteristics are pretty balanced between the two groups, and majority of the high risk came from the Gleason score of more than 8 and baseline PSA of less than 20. Majority of the patients were less than equal to T2, and they had node negative disease. So this is the primary endpoint, very important slide. Now PCR means there is no residual disease on histopathology, and MRD means that there is a prostate confined disease of less than 5 millimeters at histopathology. So when taken together, it turns out to be 8.9% versus 1% in the ADT alone group. So a 9-fold improvement in PCR MRD at radical prostatectomy after 6 cycles. So the second endpoint was the metastasis-free survival. This also gave us a hazard ratio of 0.8, that is 20% reduction in the risk of METs or death after 1 year of perioperative APA plus ADT. So number of secondary endpoints, event-free survival, curves are separated, significant hazard ratio. Time to first subsequent treatment, 3 years treatment-free interval was added. Time to distant meds, significant hazard ratio. Testosterone recovery was done in 8 months in APA-ADT versus 6 months in the other group. So 95% of the patients had some treatment-related events, 6 times higher dose reduction in APA-ADT, and 3 times higher dose interruptions in APA-ADT as compared to ADT alone. So we'll skip this. In conclusion, of course, it's the largest size to date design. It has novel endpoints, and it has incorporated PSMA PET for response. Then significant benefit, 9 times higher PCR MRD, 20% less risk of metastasis-free survival, 29% less risk of recurrence and death, and 3 years longer time to next treatment. Of course, it was tolerable, albeit with a lot of toxicity. And then, of course, more studies are needed in order to evaluate its role. So Proteus definitely sets a new standard of care in high-risk localized prostate cancer. These are acknowledgements, and thank you very much for the patient listening.
I'll now request our panelists to come up to the stage, Dr. Baz, Dr. Hidayatullah from Quetta, Dr. Numair and Dr. Zishan, if they're here. Dr. Mansoor Zishan. Can I request Dr. Qasim Bhutar if he's here? Otherwise, I think we can do with 3 panelists the discussion. If anyone in the audience has any question, yes, you can.
Assalamu alaikum. Thank you for the wonderful talks. Dr. Abbas, my question is mainly directed to you. I mean, you've shown us a lot of data, plethora of data, and very promising results. But my question is, I mean, we're sort of spoiled for choice. If I go to my clinic on Monday, let's say, and if patient walks in the clinic and has metastatic castration-sensitive prostate cancer, and then there is another one who has metastatic castration-resistant prostate cancer. So what would be your first choice, one choice in both the settings? And please take us through your thinking process as well, you know.
That's a loaded question, almost my whole talk. So let's start with castration-sensitive prostate cancer with metastases, because what happens in castration-resistant prostate cancer first line entirely depends upon what you give in castration-sensitive prostate cancer. For castration-sensitive prostate cancer with metastases, my default is everybody gets ADT and one of the RPs.
Which one? Which one? Sorry.
It doesn't matter. Abiraterone, enzalutamide, apalutamide, darolutamide. All 4 are effective. They all have positive trials. I prefer darolutamide personally. That's because it has least toxicities as compared to others, fewer drug-drug interactions. So ADT with Lupron, for example, or relugolix, with darolutamide is where I start. Almost everybody in my practice gets that. Then I send the patient for NGS, next generation sequencing. If the patient has BRCA2 or BRCA1, especially BRCA2, I add a PARP inhibitor. Because patients who have BRCA2 mutations or BRCA1 or BRCA mutations, they don't do well just with hormones alone. I also send their tissue for P10 deficiency testing on histopathology, not on NGS, histopathology. If the patients have P10 deficiency on histopath, I add capivasertib. Again,
toxicity.
There is toxicity, but the flip side is these patients do terribly on ADT plus RP alone. The other option would be you could add docetaxel in these patients, but because there is targeted treatment, I think capivasertib gives you the highest value. And you can always add docetaxel later in MCRPC if needed. So, and the reason why I would add capivasertib is because these patients do very poorly on hormones alone, right? They usually progress within 2 years. If the patient has PSMA-PET positive disease, you can always add lutetium or Pluvicto. It's not obviously right now clear that if a patient has BRCA2 mutation and PSMA-PET positivity, which one you do. But I usually go with, if anybody has BRCA mutation, I go with PARP inhibitor first. And then if the patient doesn't have any of these targeted possibilities, like if there's no BRCA positivity, you can give PARP. If there is no P10 deficiency on histopath, you can't give capivasertib. Then I think, should I intensify with docetaxel, right? If there's high volume disease with synchronous presentation, I add docetaxel. And if the Decipher score is low, these usually are, it's obvious, patients who have volume disease, they have low Deciphers. So I sort of use them together. So that's sort of how I think would big picture. Usually you need to start narrowing down your possibilities with biomarker-based testing. I don't use any of the AI biomarkers yet because they're not developed enough to use in practice.
Thank you. Thank you.
Dr. Jamshed.
Dr. Irbaz, Jamshed here from Shaukat Khanum. So thank you for the excellent talk. So we know that there is a role of low-dose abiraterone in prostate cancer. And the main data is regarding the castrate-sensitive patients. What's your experience regarding that? And can we consider that strategy in castrate-resistant as well if we are sitting here in Pakistan? Thank you. And what should be the ideal way to give it? Is it the routinely we can give it, or with the low dose, the fatty diet? Thank you.
Anyone, doctor?
Can start. I typically don't use low-dose abiraterone because our patients are usually covered. But I've done this. So it depends upon the reason of why you want to do low-dose, right? The low-dose works with food. Food increases absorption of abiraterone. If it is given with the meals, then there is increased absorption of abiraterone. And so typically you would give abiraterone empty stomach. But if you want to give low dose to get the same therapeutic effect, you give it with food. You could give 250, 500, and you can monitor the response. But there are other reasons that you may want to lower the dose of abiraterone because of liver toxicities, etc. Then you give the lower dose just for the toxicity. So first question, are you going to give lower dose just for the cost reason? If that's the case, then you give it with food. 250, there's some evidence for that. 500 is reasonable. And there's plenty of good data to suggest that if you do the lower doses with food, the efficacy is similar because food increases the absorption of that.
So, Dr. Zishan, in your practice, do you use low dose, or you're not convinced still?
Yes, we have used low dose, but it is very difficult in our practice to explain the patient to how to take it, like with food, with more fatty food. So rarely I have seen any positive results using low dose. There are other indications of using low dose because if the patient has so many pills, patients with other comorbid condition, and they want that there should be less number of pills. So in that case, yes. But the results were not promising as compared to full dose.
Dr. Hidayat, do you have any comment?
Yeah.
I think doing low dose is, well established. There is evidence for that. And in a setup like ours, where there are cost restraints, if we have evidence for something, I think we should do. I usually do it.
Okay, all right. Dr. Qasim Buttar.
Dr. Arbaz, excellent talk. I'm Qasim Buttar. I would like to have your comments on the dose of leuprolide in metastatic castration-sensitive prostate cancer. There are some studies which show that 11.25 probably is as good. Me and Dr. Kamran once talked to Oliver Sarter, and he said you can start with 22.5 and then subsequently go to 11.25, and the next dose check the testosterone level. So what are your comments on that?
Lupron is a depot injection, and the dose is based on the duration. The 22.5 dose is good.
That's 3 monthly here.
3 months.
Versus 11.25. Both are depot.
So I usually use the 22.5 for 3 months. That's the standard. That's what I've always used. And it has excellent results. So are you asking that if we use half of that dose at the start and then go to 22.5? Is that the question?
Yeah, because there are some companies, some pharma companies, and even in DNF, the dose is 11.25 3 monthly for the depot form for the metastatic prostate cancer. That was a bit of a confusion, but in the standard guidelines in NCCN, it is 22.5 usually.
Exactly my point. So I usually do just 22.5. I haven't tried 11.25 before.
Dr. Zisha, sorry, you continue, Dr. Arbaz. आप कुछ कह रहे थे और?
It works effectively. और जो toxicities हैं, they're not different with 2 doses. So I usually have never the need to try 11.5. क्योंकि हर कोई tolerate करता है, response भी अच्छा है तो, and biologically कोई lower toxicities भी नहीं होंगी तो I just don't try that.
We have another question from
Dr. Mohammed Fawad, oncology consultant. I have a question regarding bladder cancer. So in patients with oligometastatic bladder cancer, for example, a single liver met or maybe a single bone met, would you, and if money is not an object, would you then start them with Gemcis plus Durva and then opt for SABR of the met and radical chemoradiotherapy or surgery versus Infotumumab plus Pembro and then wait for a complete response? So what would you do in oligometastatic bladder cancer?
Oligometastases from bladder cancer, would you still do full systemic treatment with adding EV Pembro, for example?
Or you would, give them Durva plus Gemcis and go for SABR of the met, radical cystectomy, etc. So which paradigm would you opt for?
So bladder cancer is very different from prostate cancer. Bladder cancer is biologically intrinsic disease. If there is metastases, there is metastases. You need to give effective systemic treatment for patients to do well. Even if they have muscle invasive bladder disease, you have to give effective systemic treatment because there are already micrometastases. With prostate cancer, you can just do, for example, SPRT to oligometastases, and the patient could have good remission for some time. For bladder, if the metastases, you do full treatment. And, from my perspective, although there is debate about it, but, results for EV Pembro are just fantastic. The overall survival is doubled with EV Pembro, like 32 months versus 16 months. There is nothing like EV Pembro in bladder cancer. So when I can, I give EV Pembro. I mean, nothing comes even close to EV Pembro, honestly.
Sure. So you would treat them on metastatic paradigm. Thank you.
Doctor. Okay. I'm Dr. Najib Niamatullah from SIUT and Shaukat Khanum, Karachi. The question is, do you change your staging on PSMA PET scan? Because now since we have PSMA PET scan available in Pakistan, it has become a Farmaishi program from the patient as well as the treating physician. So how much is the effect on the staging of prostate cancer and treatment? The second question is, to my understanding, we don't use LHRH or ADT before surgery because that can cause fibrosis and difficulty in surgery. So is there any problem in that study, protease study, that leads to difficulty in surgery? And can we use abiraterone instead of apalutamide? Is there any study going on that in a neoadjuvant setting?
Yeah. So anyone can answer, and all three can.
If I got the question right, अब first question आपका ये है कि क्या PSMA PET scan से stage?
Can change staging. Are you stage the patient on a PSMA PET scan or just the old bone scan, CT scan, and MRI?
100%. PSMA PET scan is very sensitive, right? So अगर आपका let's say biochemical recurrence हुई है, and you add.
I'm talking about baseline staging. Baseline staging.
Baseline for metastasis?
Without.
At diagnosis?
PET pe, if there is a metastasis which you can't pick on a CT scan or a bone scan or MRI, do you think it's a stage 4 disease or you just ignore PSMA PET scan?
At the diagnosis, his question is at the diagnosis, would you do a PET scan? If the PSMA is positive and the other scans like MRI or CT scans are negative, so would you take it as stage 4 disease?
That's a great question. So every patient who has, intermediate to high risk disease that localized prostate cancer diagnosis, I get a PSMA PET scan. If the PSMA PET scan is positive, it changes management, because if you see, for example, regional lymph nodes, prostatectomy almost goes off the table, and then you would just do, definitive radiation with hormones, and I also do SBRT to oligometastases. So I think PSMA PET scan is very useful in that perspective. Otherwise, you would do the prostatectomy, you would have missed the metastases, and for example, in the lymph nodes, and the patient would have recurrence right away.
Okay. Dr. Hidayat, you have anything to add to Dr. Baz?
I was just wondering to ask Dr. Irbaz, he has had excellent work in AI. So do you have any, share with us your experience regarding the use of AI in terms of having any markers that can predict escalation or de-escalation of treatment in terms of guiding the prognosis and treatment strategy?
So there is one AI-based biomarker which is already in the guidelines. It's called Artera AI or MMAI, multimodal AI. In patients who have intermediate to high risk localized, mostly intermediate risk prostate cancer. So for localized prostate cancer, for low risk, you basically watch them essentially. For high risk, you give them either surgery or high risk radiation plus hormones. In the intermediate risk, the question is, if you're giving radiation, is it necessary to add additional hormones, for example, Lupron? So Artera AI predicts now who can benefit just with surgery, with radiation alone, without ADT. So this is one place where AI is already in practice. So to decide whether hormones need to be added to radiation in intermediate risk prostate cancer. So that's where I'm using it. For other things, we are in the process of developing those biomarkers, so nothing is complete and ready to practice. Only one place where it is ready for practice.
Dr. Zishan, you have anything to add?
Yes. In our setup, patients mostly use AI, and they come to us prepared, giving their data to ChatGPT, and they come with all the information. And so the patients and their attendants are using more frequently AI than the doctors.
And I think that creates a big problem now, because when patients are using AI and you give them a different recommendation, then it becomes a matter of distrust. Why is doctor not telling me what ChatGPT is saying? But I think one thing we need to educate our patients when they come having looked up ChatGPT is there's a phenomena called psychophancy. And what it means is that it wants to keep you happy, right? So the more confidently you ask for something, the more it would like to corroborate with you. So two major problems. It's generally good, but it makes mistakes which are unpredictable. You never know when it is going to make a mistake. And when it makes a mistake, it sounds very confident. And the second problem is it always tries to please you, because the way it was trained, it tries to align with the user itself. So, it's very dangerous, honestly. I mean, it's very useful, but also very dangerous because of unpredictable mistakes and tendency to please the user.
Yeah, I just want to add to it, like, I mean, it is more and more talk about AI, and it is changing the whole landscape in terms of medical treatment and people interaction with you. But I think it is never going to lose the human connection. So
Yeah.
as long as...
Okay, so one last question.
Okay, so
And I get to ask the last question after this. Okay.
My name is Dr. Ali Wajid, and I'm an oncologist from Islamabad. So my question is from all three panelists. So working in a third world country where we have very limited availability of immunotherapy, what is the best way to treat patients who are cisplatin ineligible bladder cancer patients, especially who are non-metastatic early stage disease? So how would you go about treating these patients which are ineligible for cisplatin? Would you consider carboplatin in these patients, especially we do not have pembrolizumab or any other immunotherapies available, a lot of them, which are very expensive. So how would you treat those patients? And secondly, a lot of patients do now want to go towards radiation therapy, even though they fall outside the criteria of going with CCRT for bladder preservation treatments. So what is your opinion regarding that?
Anyone who wants to?
Platinum ineligible patients. You're talking about MIBC?
No, not metastatic, but yes, muscle invasive bladder cancer, MIBC.
Metastatic bladder cancer?
Yes.
Okay, so I would like to ask Irbaz to comment on this.
EV Pembro. You can safely give EV with...
Sorry, EV is not
in
available.
Resource limited
it's
settings.
Resource limited setting, please.
Like ours. So.
Because it's not available, and you can't give chemo because patient is ineligible. If Pembro is a possibility, you can do that as a single agent, or any immunotherapy that is available.
Okay.
Otherwise, the options are very limited.
And would you consider like GEM with carboplatin or not?
You could, but the responses are... Okay. It doesn't really work. You can get some temporization, but bladder cancer is a very tough disease to treat. And what has really transformed bladder cancer is essentially EV-Pembro combination. There is nothing like it. Historically, platinum-based chemotherapy was the standard. Then immunotherapy added incremental benefit on top of it. If the patient is ineligible, then with platinum-based chemotherapy, other chemotherapies are essentially just, it's like the benefit is minimal. You can temporize for a little bit, but it's not, you hardly see any durable responses.
And what about patients who are really afraid of having cystectomy and they want to go with bladder preservation with radiation therapy and or falling slightly outside the range of guidelines for bladder preservation? Have you ever recommended anything for those patients? Is that something an option?
Bladder preservation. Okay, so this is the last minute. Our time is up. Anyone wants to? Your question was option of bladder preservation.
Yes.
Yeah, so can you ask Dr. Baz later? You can catch him during lunch. Thank you for a wonderful talk, Dr. Baz. As always, we enjoyed it, and I thank the panelists for being here, and we'll stop here. I'll ask my question later because we are running out of time. Okay.
Assalamu alaikum. Good afternoon. A very warm welcome to all of you to this industry symposium. It is a pleasure to moderate today's session that is of extreme importance in modern oncology. We are going to talk about pembrolizumab biosimilar BCD201, key results of phase 3 equivalence study and real-world clinical experience. Over the last decades, we all know that IO has become the cornerstone in oncology. If we talk about starting from melanoma to lung, all of the oncological diseases have the role of IO. It has become from an innovative
Kamran is going to do the honors. जरा हिला के नीचे से जो बेचारे आए थे, ऊपर तो 8-8, 9-9 वाले होंगे. चलें. Let's see, who is the lucky one? Dr. Ghulam Asghar. Dr. Ghulam Asghar, is he here? हम 2-4 निकालेंगे, अगर नहीं हुआ तो फिर हम नंबर वाले उस पर चले जाएंगे.
Dr. Mirza Ramiz.
Is Ramiz here? Oh, there, come. Why are you sitting? Come. There you go. We have our lucky draw winner. Oh, easy to connect. Congratulations. Jao. There jao.
Okay. So without any due delay, we'll start with the next GI oncology session. Our first speaker will be Dr. Saif. Everybody knows him. Actually, he's the Phase 1 MTD and Director, Eisenberg Center for Translational Therapeutics at Carmenus Wayne State University School of Medicine. Graduated from King Edward Medical College, has been in the top institutions in USA, and he'll enlighten us on updates on upper GI cancers.
Assalamu alaikum ji, I know everybody's hyperglycemic right now, so my job is to keep you wake up. So we will be talking about the updates in GI cancers ASCO. And the major abstract that I will touch will be the pancreatic cancer, the Resolute 302, gastric cancer, Horizon GEA01. In HCC, we'll touch upon Emerald 3 and Embrave 251. In cholangiocarcinoma, Fight 302, and very briefly on NET on the cabinet study. So let's start with pancreatic cancer. We already know that Razonc has been approved by FDA about 2 days ago for patients with pancreatic cancer who have failed one line of chemotherapy or who are intolerant to chemotherapy for metastatic pancreatic cancer. So we already know the results. The median survival was more than double, 13.2 months compared to 6.7 months with a hazard ratio of 0.40, meaning that patient who will receive the daraxonrasib will have a decreased risk of dying from pancreatic cancer by 60%. So I will not go into the details because I have full presentation on that one. Now we'll move to the gastric cancer. So we will talk about the study called Horizon GEA1, which is basically a study consisting of zanidatamab, which is a bispecific targeted therapy against 2 domains of HER2, along with chemotherapy, along with tislelizumab, which is basically a checkpoint inhibitor against PD-1 for first-line HER2 positive, locally advanced or metastatic gastroesophageal adenocarcinoma. The study was designed in such a way that this was a global trial. Patients age more than 18. These are the patients who were deemed to be unresectable, locally advanced or metastatic gastroesophageal adenocarcinoma. They have to have HER2 positive immunohistochemistry 3+ or must be confirmed by FISH. These patients need to have ECOG of 0 or 1. They should have no prior therapy for locally advanced metastatic disease. At the same time, they should have no prior HER2 targeted therapy. The stratification factors include geographical region, HER2 status, and ECOG performance status. So the study was randomized into 3 arms. It consists of trastuzumab plus chemotherapy as a control arm. Then patient received zanidatamab along with chemotherapy, and the third arm was zanidatamab plus TC plus chemotherapy. The patient continued the therapy, and the primary endpoints were look at PFS, which was done by BICR, which means blind independent review was done centrally, and looking at overall survival. The primary endpoint, the PFS, was met. As you can see from this table, people who got the triple therapy with zanidatamab plus tislelizumab plus chemotherapy versus trastuzumab plus chemotherapy, it was 12.4 versus 8.1 with a hazard ratio of 0.63, telling you that patient who received this triple combination has decreased risk of disease progression by almost 27%. When you look at the overall benefit at the months of 18 as well as 24, you can see the benefit was more than doubled. At 18 months, about 43.9% patients have PFS compared to 20.9% patients without the zanidatamab and tislelizumab. When you look at 24 months, the benefit persisted, it was again more than double the difference. It was 38.2% patients have progression-free survival at 24 months compared to 15.6 on the standard arm. When you look at the overall survival in intent to treat population, you also see the benefit. It was 26.4 with the triple therapy compared to standard of care was 19.2 with a p-value of 0.72, telling you that patient who received this triple therapy has a decreased risk of dying from cancer was almost 28%. Again, the benefit persisted beyond that duration. You can see at 30 months as well as at 36 months, which is 3 years, you can see the benefit was almost 40% patients were alive who received the tislelizumab, zanitumab, and chemotherapy versus trastuzumab plus chemotherapy. The toxicity, grade 3 and higher toxicity occurred in more frequently in the patient with the triple therapy as expected, 71.8% compared to 59.6%. However, the most common side effect was diarrhea that was needed to have a primary prophylaxis. Every patient needs to be given antidiarrheal medication before giving the zanitumab and antidiarrheal support. Hypokalemia happened secondary to diarrhea, and anemia was also found more in the arm which consists of the zanitumab. So the take-home message, zanitumab plus chemotherapy plus tislelizumab is a very active frontline regimen for metastatic or locally advanced gastroesophageal cancer. The median PFS is equal to 1 year, and median OS is more than 2 years. Irrespective of the PD-L1 status, which means that the score did not change any outcome in these patients. The serious side effects were doubled, but they need prophylactic management of diarrhea. Now we're switching gears to hepatocellular carcinoma. As you know, that hepatocellular carcinoma is a disease that we have nothing to offer, and now we have too much on the shelf. So this is a study that I will talk is very, very important. It's called EMERALD-3 study. This is a study looking at the phase 3 study, randomized study of giving Tremi plus Durva with or without lenvatinib with transarterial chemoembolization in patients who have unresectable disease. So the study population selection is very important for these patients. So this patient population, they have radiologically or pathologically confirmed ACC. They were not amenable to curative treatment such as surgical resection, but they were amenable to embolization. They have child Puget classification, ECOG was 0 or 1. They have no extrahepatic disease. A patient with the main branch portal vein or the side branch main thrombosis were excluded, and these patients did not receive any prior systemic therapy. So the study was randomized to give patient stride plus lenvatinib plus TACE. The second arm was stride plus TACE, and third was just to go with the TACE as a control arm. The primary endpoint was to look at PFS A versus C using, again, independent review by a blind committee. So PFS, as you can see in this study, met the primary endpoint. The PFS for the stride plus TACE was 13 months compared to 9.8 months with the TACE alone. And again, you can see the benefit persisted. At 12 months, it persisted 42%, 30%, 19% compared to the other arm. So you can see that definitely there is a huge benefit, combination of immunotherapy in addition to transarterial chemoembolization. And I think that is extremely important data. When you look at the PFS and when you try to look at stride plus TACE versus TACE alone, you also see the benefit persisted. So whether you get stride plus TACE or whether you get stride plus TACE plus lenvatinib, the benefit was superior over giving TACE alone. And that benefit persisted even beyond that. And you can see the benefit persisted beyond 3 years in these patients. Overall survival, it also showed there was improvement in overall survival in patients who received lenvatinib, stride, plus TACE. It was almost 40 months compared to 34.7 months in the TACE alone arm. And you can again see that after initial convergence, then the benefit seems to be persistent as the both your lines seems to be separated from each other. When you look at the stride plus TACE versus TACE, again you see the benefit was quite significant. And again, that benefit seems to be benefited with a hazard ratio of 0.70. Toxicities. So grade 3 and 4 toxicities occurred in about 62.7% of the patient on the stride plus lenvatinib versus the stride arm. It was about 48.6% in the stride plus TACE, and there were no new signals of side effects either from lenvatinib or from the stride arm. So conclusions, EMERALD is the first phase 3 study to demonstrate that a stride-based regimen improves clinical outcome both in terms of PFS as well as OS when combined with TACE, supporting its role as a potential new treatment option for unresectable embolization-eligible HCC. So that is really a practice-changing approach now that we have adapted in our clinics. The second study is IMbrave 251, and just to remind you, as I told you yesterday, that continuation of a biologic treatment after progression from first line to second line is not a new concept. We have the examples of Herceptin in breast cancer. We have the example of bevacizumab in colon cancer. So this is a study that look at continuing atezo. These patients receive bev and atezo as a first-line therapy for ACC. And in this study, when they progress, they wanted to see if they continue the atezo plus TKI for VEGF, either lenvatinib or sorafenib, versus lenvatinib or sorafenib as a control arm in locally advanced or metastatic HCC. The study was designed that unresectable HCC, they have progressed on atezo plus bev, and they need to have a child-puke classification A. They were randomized to receive atezo plus len or atezo plus Nexavar, or they continued on len, they received len alone or sorafenib alone. The tumor was treated till clinical benefit or unacceptable toxicity. When you look at the overall survival, we realized that patients who continue atezo plus a TKI, it was about 14.6 versus 12.5. However, the hazard ratio did not reach a statistical significance. It was 0.88. When you look at the PFS found to be very equal on both arms. It was 4.3 versus 4.8, so the study did not meet any of its primary endpoint. Toxicity, again, as we expected, there was no new toxicity. That is always important when you're combining even the older drugs. You want to make sure there's no new red flags or signals. So there was not, but definitely people who got the combination, there was increased toxicity almost by magnitude of about 10%. So the key take-home points from this one, IMbrava 251 did not meet its primary endpoint of overall survival of combining atezo plus lenvatinib or sorafenib compared to lenvatinib or sorafenib as a single agent. The safety profile of the combination was manageable and consistent with the known safety profile of each drug and the underlying disease. Number two, IMbrave 150 established that atezo-bev as the first-line standard of care for unresectable ACC. And number three, it basically trying to show a benchmark, that what we should be looking for patient going from first line to second line. Now we're get into the liver from cholangiocarcinoma. Cholangiocarcinoma, again, used to be the first cousin of pancreatic cancer and was designated as an orphan disease. But things are changing because of the precision oncology. It is extremely important that every patient with cholangiocarcinoma should be tested for NGS. We'll be talking about the FGFR2, and I think it's very important to remind you that interestingly, the FGFR2 fusion or mutations are more common and almost exclusively seen only in intrahepatic cholangiocarcinoma. For whatever reason, very rarely you see them in extrahepatic cholangiocarcinoma. So this is a study which is looking at pemigatinib for unresectable advanced or metastatic cholangiocarcinoma for FGFR2 rearrangement. This is an extremely important study, and I will tell you why. The study design tells you that this is a study that patients were pre-screened for FGFR2 rearrangements, and they were randomized to receive, this is the first study looking at a targeted therapy in the first-line treatment of cholangiocarcinoma intrahepatic versus standard of care. So the patient was randomized to receive gemitinib 13.5 milligram once daily. Patient get treatment for day 1 through 14, 7 days off. It's a 21-day cycle. Compared to GemCis, which is the gold standard based on the APC UK study, and these patients were allowed to cross over. That is the most important thing to keep in mind, okay, because that really affects the data that we look at the results time. So the patients who were on GemCis, when they progressed, they were allowed to receive the experimental drug. The primary endpoint was PFS, secondary endpoint was overall survival, safety, and response rate. So the primary endpoint, PFS, you can see over here, it was reached. The PFS was 8.34 with pemigatinib versus 6.80 with GemCis, with a hazard ratio of 0.58, telling you that if you get this targeted therapy, your risk of dying from cholangiocarcinoma reduced almost by 42%, which is amazing. Overall survival was not improved. Any fellow can explain to me why we don't see any overall survival? It was 25 months on both arms. So why you think is that? Thank you very much. Because the study allowed crossover, which means that people who were not initially randomized to receive the targeted therapy after they failed systemic chemotherapy, they were allowed to cross over. So that's the reason overall survival was not seen. This is very similar story to the Vectibix story. The first study of Vectibix was done that way, and they say, oh, there's no benefit of survival. Yeah, because people who failed standard care, they were allowed to give Vectibix. Excellent. So when you look at the response rate, again, there was about 5 to 3 responses of 6% response rate. Partial response was about 34%, and stable disease was 35%. If you do the calculations, 34, 35 is almost like 69 plus 5, 74. Disease stability, which we call disease control, was found in about 2/3 of the patients. So that's a great news to hear about it. So definitely, it is an important part. And the duration of treatment was also longer than chemotherapy. The duration of treatment with GemCis was about 6.3 because we know we get the toxicities. On the other hand, with the targeted therapy, patients were able to continue treatment beyond a year to a median level of 14.2 months. Another part is that when you look at the waterfall diagrams, you also see the responses were very deep. Not only we have more responses, including complete responses, the responses were much more deeper compared to the chemotherapy, as very clearly evident on this slide. Toxicity, definitely there was a different toxicity. The toxicity occurred in about 78% of the patient with gemigatinib versus 67% with GemCis. So we know GemCis is not a benign regimen. The most common toxicity that we see with this agent called pemigatinib is Palmer, like hand and foot reaction. This is not hand and foot syndrome. I think it's very important to keep in mind that capecitabine causes hand and foot syndrome, but TKIs and these drugs called hand and foot reaction, which is very different. Mucositis was very common, nail disorders were very common, and also these patients happen to develop hyperphosphatemia. And my fellow asked me, how should I remember hyperphosphatemia? I say, listen, what's the first letter of the drug? What's the first letter of the drug? P. How many electrolytes you deal in your life on a normal way start with P? Phosphate, right? Potassium, no, that's too common for us. We are special people. Conclusions. So the FIGHT 302 is the largest international first-line randomized clinical trial for FGFR2 rearranged cholangiocarcinoma. Results support potential consideration of pemigatinib in the first-line setting for patients who have FGFR2 rearranged cholangiocarcinoma. Additionally, these results confirm the use of this agent because keep in mind this drug is already approved by FDA to be given in second and third line. We have 2 mutations in cholangiocarcinoma that we have targeted therapy. What is the second abnormality genetically that we find in cholangiocarcinoma that we have drugs approved? Any fellow? IDH1, excellent, IDH1. So we're getting very sexier now to treat cancer. Okay, this is a precision oncology. This is not chemotherapy and you're done. If the patient comes to you and the patient's kidney function is very bad, or patients say, hey, I already getting deaf and I don't want to lose my deafness, or patients say, hey, I'm not willing to get a port placed, I do not want intravenous, you say, let's check your genetic testing. Oh, you have FGFR2, I have a drug for you. So there is definitely, it's not only moving the field in terms of scientific discovery and advancement, but also it allows us to tailor the therapy to different patients based on their desired acceptance. Of course, every oral drug comes with a cost, just like we learned yesterday that Razonc is going to cost about $40,000 a month. Last but not the least, everybody is aware of the cabinet trial that look at the cabozantinib for neuroendocrine tumor, and this year at ASCO, they try to look for the efficacy of the drug in patients with functional and non-functional tumors. Question to the fellows, how many neuroendocrine tumors are functional? 60%, 30%, 20%? 20%, and most of them are non-functional. And this has been always a debate that how aggressive we should treat the non-functional. When you look at the benefit in the non-functional tumors, when CAB was given, it was 9.4 months compared to 3.1 for PFS. When you look at the functional neuroendocrine tumor, it was 12.7 versus 5.4. And overall, the toxicity was similar to what we have seen in the previous study. So to conclude, pancreatic cancer, the Resolute 302 shows that daraxonrasib nearly doubled the overall survival compared to standard chemotherapy in pancreatic cancer treated with chemotherapy is now approved by FDA. In the gastric cancer, the Horizon GA01 study shows that zanidatamab, which is basically a bispecific against the HER2, along with tislelizumab, which is a PD-1 checkpoint inhibitor, along with chemotherapy, has shown a practice-changing efficacy in metastatic gastroesophageal adenocarcinoma. In ACC, the practice-changing really is the EMERALD-3, which shows that now we can incorporate slight regimen immunotherapy into our locally advanced patient, which is a huge success. But that also brings to the important point, it has to be a collaborative effort, a multidisciplinary approach between your intervention radiologist and your oncologist. Fight 302 again to me is an important discovery that shows that for the first time that we can give a targeted therapy in the first line treatment. And last but not the least, the subgroup analysis of the cabinet study shows that cabo is an effective treatment irrespective of the functional and non-functionality of the neuroendocrine tumor. Thank you very much. Any questions? Okay.
Thank you very much, Dr. Saif. So next speaker will be Dr. Maliha Nusrat. She's currently a graduate of AKU, and currently she has become the Associate Professor of GI Oncology at MD Anderson. She did her fellowship from MD Anderson, and she was an assistant consultant in Memorial Sloan Kettering. She will be talking to us about the updates in colorectal cancer. It'll be a virtual talk from her.
Assalamu alaikum. I'm Dr. Maliha Nusrat, an assistant attending physician in gastrointestinal medical oncology at Memorial Sloan Kettering Cancer Center. And today I will present updates in colorectal cancers from the ASCO annual meeting 2026. These are my disclosures. I will highlight key abstracts addressing new data for the treatment of BRAF V600E and HER2 amplified metastatic colorectal cancer and advances in the adjuvant treatment of early-stage colorectal cancers. So first, metastatic colorectal cancer. BRAF V600E mutations are present in about 8% of advanced colorectal cancer patients and are associated with poor overall survival, atypical metastasis, lack of benefit from EGFR inhibitors. Monotherapy with BRAF inhibitor was ineffective in colorectal cancers, with objective response rate of 5% with vemurafenib monotherapy. Further analysis of acquired alterations as well as preclinical data from BRAF V600E mutated colorectal cancer patients enrolled in the vemurafenib trial revealed that MAP kinase pathway reactivation through EGFR is a mechanism of adaptive resistance. Subsequently, combined EGFR, BRAF, and MEK inhibitor therapy showed better outcomes in refractory colorectal cancer, as shown in this table. We will discuss the last two rows from the phase 3 Beacon trial in refractory colorectal cancers with BRAF V600E in further detail later. After the success of the Beacon regimen with encorafenib cetuximab, which showed outcomes comparable with the triplet targeted therapy with encorafenib, binimetinib, cetuximab, the triplet arm was discontinued. The encorafenib cetuximab moved forward in the first-line setting. So the phase 3 Breakwater trial utilizes encorafenib and cetuximab in combination with chemotherapy and compares that with encorafenib cetuximab alone or standard of care chemotherapy alone. The first of these presentations was with the FOLFOX cohort, and so patients with BRAF V600E mutated colorectal cancer previously treatment naive were randomized 1:1:1 to receive either encorafenib cetuximab or encorafenib cetuximab with FOLFOX or standard of care chemotherapy. The dual primary endpoint was progression-free survival and objective response rate, and the key secondary endpoint was overall survival. The dual primary endpoint was met. The study showed improvement in objective response rate to 65.7% with EC plus chemotherapy versus 45.6% with EC and 37.5% with chemotherapy. Progression-free survival improved to 12.8 months with EC plus chemotherapy, 7.1 months with EC, and 6.8 months in the control arm. The median overall survival, which was the key secondary endpoint, doubled with encorafenib, cetuximab, and FOLFOX to 30.3 months, and a hazard ratio as compared to chemotherapy was 0.49. So after this, at ASCO GI 2026, results were presented for the encorafenib, cetuximab, and FOLFIRI arm, which was the cohort 3 of this phase 3 trial, a breakwater trial. And here, patients were randomized 1:1 to receive EC plus FOLFIRI versus control, which was chemotherapy, FOLFIRI with or without bevacizumab. And the primary endpoint was objective response rate. The key secondary endpoint was progression-free survival, and the other key secondary endpoints were overall survival, duration of response, and safety. The demographic and baseline characteristics were generally similar across treatment arms, and the primary endpoint was met. The objective response rate improved to 64.4% with EC plus FOLFIRI as compared to 39.2% in the control arm. As you can see in the boxes highlighted red, the EC plus FOLFIRI arm also had complete responses in 5.5% of patients versus 1.4% with chemotherapy alone. So at ASCO Annual Meeting 2026, the final analysis of progression-free survival by the centralized review and analysis of overall survival and safety were presented. At the data cutoff of January 6, 2026, 38.4% patients on the encorafenib, cetuximab, and FOLFIRI arm and 9.5% patients in the control arm were still on treatment. And 6.8% patients in each arm discontinued treatment due to adverse events. The key secondary endpoint was met. Encorafenib, cetuximab with FOLFIRI decreased the rate of disease progression or death by 56% as compared to the control arm, with a hazard ratio of 0.44, which was statistically significant. The clinical benefit of encorafenib, cetuximab, and FOLFIRI was observed across all key pre-specified subgroups. Encorafenib, cetuximab plus FOLFIRI also prolonged the overall survival as compared to control in a statistically significant manner. The safety profile was consistent with that expected for each of the study drugs. No substantial increase in FOLFIRI discontinuation rate was seen by combining it with encorafenib and cetuximab. And no new safety signals were observed. The most common adverse events in either arm were nausea, diarrhea, vomiting, anemia. So in conclusion, encorafenib and cetuximab, which is BRAF inhibitor and EGFR inhibitor, in combination with either FOLFIRI or FOLFOX, prolonged objective response rate, progression-free survival, and overall survival as compared to FOLFOX or FOLFIRI with or without bevacizumab in treatment-naive BRAF V600D metastatic colorectal cancer. So the results of the breakwater trial are practice-changing. So the next patient that I see in clinic with a BRAF V600D metastatic colorectal cancer, I consider this regimen of chemotherapy plus doublet BRAF inhibitor and EGFR inhibitor combination therapy. The EGFR inhibitor cetuximab was used in the breakwater trial but can be substituted with panitumumab. And similarly, extrapolating from prior equivalents of 5-FU and capecitabine, FOLFOX or CAPOX can be used interchangeably in this regimen. In patients who are not candidates for intense chemotherapy and targeted therapy combination, our preference is to use the dual targeted therapy. And that is because the hazard ratio for overall survival with encorafenib, cetuximab versus chemotherapy was 0.69. In the second-line setting for patients who have previously received the breakwater regimen, second-line regimen includes alternate chemotherapy doublet with or without bevacizumab. If for some reason they have not received dual-targeted treatment with BRAF inhibitor and EGFR inhibitor in the first-line setting, then the second-line regimen of choice would be the Beacon regimen, which would be encorafenib with either cetuximab or panitumumab. So now let's talk about refractory BRAF V600E metastatic colorectal cancer. To recap, The phase 3 Beacon study randomized patients with BRAF V600E mutated metastatic colorectal cancer with 1 to 2 prior lines of therapy to receive either triplet of EGFR BRAF MEK inhibitor and encorafenib binimetinib cetuximab or dual EGFR BRAF inhibitor and encorafenib cetuximab or standard cetuximab with irinotecan or cetuximab with FOLFIRI-based chemotherapy. Objective response rate was in the 20s for both the experimental arms and 2% for the chemotherapy control arm. Overall survival among the triplet versus the doublet was very similar at 9.3 months and significantly better than 5.9 months in the control arm, and the median PFS for both triplet and doublet was around 4 months, better than 1.5 months in the chemotherapy control arm. So after this, at MD Anderson, a single-center phase 1/2 clinical trial of encorafenib cetuximab nivolumab was conducted in previously treated MSS BRAF V600E metastatic colorectal cancer with a goal to improve outcomes over that of the Beacon regimen. 26 patients were enrolled and 24 were evaluable. Objective response rate was 50% with a median progression-free survival of 7.4 months and a median overall survival of 22 months. And the outcomes did appear improved over the Beacon regimen of encorafenib cetuximab. So this then led to the SWOG S2107 randomized phase 2 clinical trial of encorafenib cetuximab with or without nivolumab that was presented at ASCO annual meeting 2026. Patients were enrolled after receiving at least 1 prior line of therapy, and the primary endpoint was progression-free survival. Primary endpoint, however, was not met. Hazard ratio for PFS was 1.06, and the secondary endpoint was also not met, with a hazard ratio for overall survival of 0.91. Objective response rate was similar between the two arms, and outcomes on control arm outperformed historical expectations from encorafenib and cetuximab in the prior phase 3 Beacon trial. So in summary, adding anti-PD-1 therapy with nivolumab did not improve outcomes over dual-targeted therapy of BRAF inhibitor and EGFR inhibitor in refractory MSS BRAF V600E colorectal cancer. Now we move on to HER2-amplified metastatic colorectal cancer. HER2 amplifications are present in 2 to 4% of MCRC, enriched in RAS-RAF wild-type patients, and HER2 amplifications or HER2 positivity is defined as having an IHC staining of 3+ in at least 50% of cells, or equivocal IHC staining of 2+, along with FISH HER2 CYP17 ratio of 2 or more in over 50% of cells. Just like with the BRAF V600E mutated targeted inhibitor experience, HER2 targeted therapy as monotherapy was ineffective in colorectal cancer. Dual HER2 inhibition is more effective when a second monoclonal antibody or small molecule inhibitor is combined with anti-HER2 monoclonal antibody. The Mountaineer trial, which was a phase 2 clinical trial, where my cursor is right here, had an objective response rate of 39.3%. This was the highest seen in a combination with trastuzumab with small molecule inhibitor of HER2 tucatinib. After that, antibody drug conjugates were developed. So Destiny CRC01, which was also a phase 2 clinical trial with trastuzumab deruxtecan and antibody drug conjugate, showed overall response rate of 45.3% with PFS of 6.9% and 6.9 months and an overall survival of 15.5 months, including in patients who were previously refractory to HER2 targeted therapy. At ASCO annual meeting 2026, Horizon CRC01 was presented, which is another phase 3 clinical trial with trastuzumab rezetecan, another antibody drug conjugate. And this showed an objective response rate of 40.7% in the trastuzumab rezetecan arm with a median PFS of 5.5 months. And I'm presenting it here in the table so you can compare this with how it stacks against the previously developed HER2 targeted therapies in colorectal cancer. So in the phase 1 trial of trastuzumab rezetecan in HER2 positive advanced CRC, objective response rate of 40.5% and median PFS of 9.5 months was seen. In the phase 3 trial of trastuzumab rezetecan in previously refractory HER2 positive MCRC, including patients who previously received HER2 targeted therapy, patients were randomized 2:1 to receive the trastuzumab rezetecan or standard third-line chemotherapy with either TAS-102, fruquintinib, or regorafenib, with the primary endpoint of progression-free survival and a pre-specified hazard ratio of 0.46. The primary endpoint was met, and the PFS improved to 5.5 months versus 2.8 months with standard of care, hazard ratio of 0.33. PFS benefit of favoring trastuzumab rezetecan over standard of care was consistent across most of the predefined subgroups, and no new safety signals were seen. So this is a treatment overview of the current landscape of metastatic colorectal cancers. Depending on which biomarker is available, we now have biomarker-targeted therapies in the first-line setting for BRAF V600E mutated colorectal cancer in combination with chemotherapy, as seen in the Breakwater study. We now have KRAS G12C targeted therapies for use of KRAS G12C inhibitor and EGFR inhibitor in third line and beyond. And we have HER2 targeted therapies for use in second line and beyond with dual HER2 monoclonal antibody with small molecule inhibitor, or after progression on that with antibody drug conjugates such as trastuzumab deruxtecan or trastuzumab rezetecan. Now we pivot to adjuvant therapy in colorectal cancer. Phase 3 challenge trial randomized patients with stage 2 high risk or stage 3 colorectal cancer who had completed previously adjuvant chemotherapy within 3 to 6 months to enroll in a structured exercise program or to receive health-related education materials alone for a total of 3 years. The patients who were enrolled in a structured exercise program received behavioral change therapy delivered by a qualified personal trainer, and each session involved behavioral coaching or supervised exercise every 2 weeks in year 1 and then monthly in year 2 and 3. The results of the challenge trial were remarkable in that the disease-free survival was significantly improved in those enrolled in the structured exercise program compared to those who received health education materials alone. And overall survival also was significantly prolonged in those enrolled in the structured exercise program. For every 14 people who received structured exercise, 1 person was prevented from dying. At ASCO annual meeting 2026, a cost-utility analysis of the challenge trial was performed. The goal was to determine the incremental costs, incremental quality-adjusted life years, and incremental cost-utility ratio of the structured exercise program and health education materials versus health education materials alone. All the startup costs for the structured exercise program were calculated, including training the exercise specialists. So roughly 9 specialist training costs was estimated for all the patients enrolled in the trial, and along with the cost per session of 1 hour of exercise specialist time with a mean number of sessions across the entire study of 63. The structured exercise program significantly improved the cost saving overall, despite the initial increased upfront startup cost to launch the structured exercise program. So in conclusion, structured exercise improves cost as well as survival of patients with early stage colorectal cancers. It is now part of the both ESMO guidelines as well as NCCN clinical practice guidelines to recommend either participation in a structured exercise program or to recommend a goal of at least 150 minutes of moderate to vigorous physical activity per week. Now let's talk about adjuvant aspirin. Previously, in phase 3 Alaska trial, patients with PI3K activating alterations from stage 1 to 3 colorectal cancers after completing standard adjuvant chemotherapy were randomized to receive either aspirin 160 milligrams per day for 3 years or placebo for 3 years. And those who received aspirin had significant reductions in colorectal cancer recurrences as compared to those who received placebo, with only slight increase in the adverse events in the aspirin group. At ASCO annual meeting 2026, episode 3 clinical trial results were presented, which is a phase 3 clinical trial in biomarker unselected colorectal cancers to receive either adjuvant aspirin versus placebo concurrently with adjuvant chemotherapy after resection of stage 3 colorectal cancer. The primary endpoint was progression-free survival, and the secondary endpoint was overall survival. In this clinical trial, the primary endpoint was not met, and neither DFS or OS were significantly improved with adjuvant aspirin in biomarker unselected stage 3 colorectal cancers. These findings corroborate with that of the previously published phase 3 ASCO trial, which was also utilizing aspirin versus placebo in biomarker unselected colorectal cancer patients for 3 years after completion of standard adjuvant therapy. So it seems that the effect of aspirin is only visible in presence of PI3K activating alterations. Lastly, circulating tumor DNA in early stage colorectal cancers reflects molecular persistence of disease or minimal residual disease. ctDNA positivity is around 6% in high-risk stage 2 and 22% in stage 3 colorectal cancers. And circulating tumor DNA positivity is highly prognostic, where the probability of recurrence is near 100% in those who are ctDNA positive, as seen in both observational bespoke study as well as the observational Galaxy study. So adjuvant chemotherapy in the observational US-based bespoke trial was associated with improvement in recurrence-free survival in patients who had minimal residual disease present, but was not associated with improvement in recurrence-free survival in patients who were MRD negative or ctDNA negative. Similarly, in the observational arm of the Circulate Japan study, the Galaxy trial, adjuvant chemotherapy was associated with improvement in recurrence-free survival in patients with ctDNA positivity, but not with MRD negative or ctDNA negativity. So at ASCO Annual Meeting 2026, the the randomized clinical trial arm of ctDNA-based decision-making for adjuvant treatment in stage 2 colon cancers was presented. Here, after the surgical resection of stage 2 colorectal cancer, ctDNA was tested, and if positive, patients were randomized 2:1 to receive adjuvant chemotherapy, which could either be capecitabine or Capox, or receive observation. And patients who were ctDNA negative were randomized 1:4 to either be observed or observed on study or go off study if they were ctDNA negative. Primary endpoint was disease-free survival in the ctDNA positive group with to understand the effect of chemotherapy versus observation, and the expected hazard ratio with chemotherapy over observation was 0.62.
in those patients. And keep in mind that these patients could be MSI high, but plus also, as Dr. Malia showed you, there are other important targets that you need to be testing in those patients.
Sir, so you think that gut dysbiosis has a role to play in early onset CRC?
I think that's possible, but keep in mind that the younger generation is also too much into smoking. Unfortunately, what I'm learning that alcohol is not absolute in Pakistan. The third thing is that processed food. Just go to the mall and find me one desi with full fiber diet. I couldn't find anything yesterday. I ended up eating golgappa and came back. So that's the problem, you know, everything is so processed around here.
Thank you, sir.
Can I ask something, sir, in my clinics, we have certainly a very difficult time treating cancers which are either signaturing or mucin secreting, So for them, I mean, do you have some sort of a different strategy? Because, I mean, the simplest thing would be to go for NGS, but unfortunately not everybody here has access to that.
So I think, unfortunately, there's no other strategy that you try to go with systemic chemotherapy with the triplet. Those patients have poor prognosis. So, it is a sad set of scenario, but unfortunately, there is no way to differentiate other than knowing we have a very poor diagnosis. What we say about those things is the term called continuum of care. So I think for the younger fellows, please listen to me. So the continuum of care is that when the patient walks to your office and he or she is diagnosed with stage 4 colon cancer, you not only decide what will be your first line therapy, this is the day you decide your second line therapy and third line therapy. We call it continuum of care. When my fellows ask me why you're making the decision for the next 3 years, I say, what if I die tomorrow? I want you to read my note and you know what was the plan. But this is about teaching you so that way you think about how to utilize. I tell people that if you're very picky like me and want to eat some food, you want to make sure you pick your choices very carefully. The point is that this will also allow you, because there was an editorial published by Axel Grothy, very famous GI oncologist from Mayo Clinic, who published that patients who are exposed to most drugs lives the longest. And we also know at this time, colon cancer or any other cancer patient who are exposed to most drugs live the longest. So I think it kind of revision for you also to kind of think about how to attack the cancer in that particular patient. Of course, you have to know about the patient characteristics, patient's wishes, patient's socioeconomic status, and comorbid conditions.
Your question.
Okay, I have a question for Dr. Malia.
My question, would be the combination of zanidatamab, tislelizumab, and chemotherapy was better compared to trastuzumab and chemo. How about, there was also one group that received only zanidatamab along with chemotherapy. So for a resource-constrained country, what would be a better option, just zanidatamab plus chemotherapy?
So that's a $1 million question, and I'm so glad you asked. So I'm going to take you back to many, many years ago, and remember when we did a study. So if you go back to the historical studies of Avastin, there is a study called ECOG 3200. You guys were not born, but we were all born. So I'm talking about 2002. That study was looking for second-line therapy of FOLFOX plus Avastin versus FOLFOX versus Avastin alone. And Avastin was found to be inferior to FOLFOX. Similarly, zanidatamab was found to be inferior to the standard therapy. Therefore, the data was not presented because it's found to be non-inferior, and it's not going to be continued. I think the important message is that these are all exciting. When we look at these new studies, we need to look at 3 ways. First of all, this is a proven of the hypothesis that newer drugs like bispecific for HER2 is active. Number 2 is the advancement of science. But number 3, this is not for every patient. Keep in mind that this is a patient who can handle very severe diarrhea, because you have to give primary prevention for diarrhea. So far, we have no treatment in solid tumor that we have to give people prophylactic anti-diarrheas. So this has to be a very, very, very selected, healthy patient who's willing to handle the diarrhea. Similarly, we have the zolbetuximab, which is a claudin 18.2 antibody, which is also very GI toxic. So we don't give to every patient. And I think that's what the term comes, tailored therapy. You have to give people treatment based on their tolerance, their age, and their comorbid conditions.
So I have a question for Dr. Malia. In the Beacon trial and the Breakwater trial, both these trials had BRAF V600 mutated patients. Were they stratified according to the KRAS status?
Yeah, that is a really good question. So the breakwater trial was definitely excluding patients with KRAS alterations, and it doesn't matter their KRAS status really in the context that you're blocking the MAP kinase pathway vertically at two levels, both at EGFR as well as at BRAF. But still, if you have an intervening autonomous activating alteration of KRAS, which is upstream of BRAF, the responses can be attenuated. So breakwater in particular was KRAS wild type BRAF mutated. There is mutual exclusion of KRAS BRAF. If you look at the oncoprints of how the genome goes together, if MAP kinase is driven by BRAF, the cancer cell actually does not require KRAS. So at the time that the Beacon study was designed, as you can see, even in the control arm, cetuximab was used, so the precision oncology field was not as advanced as to know what the different alterations do to each other. And so that trial did not stratify or did not exclude KRAS alterations at all. I do not recall any patients in the breakwater trial that had a concurrent KRAS mutation along with BRAF. There's almost like I would say it would be rare for the two to coexist.
So is it important to always use cetuximab with encorafenib? Is there any study to use encorafenib alone?
Yes, so encorafenib alone, no, but vemurafenib. Vemurafenib was a BRAF inhibitor that was first tested as just by itself monotherapy in a phase 2 trial in colorectal cancers with BRAF V600E mutations. The response rate was 5%. And this was a study that enrolled both melanoma and colorectal. In melanoma, they had high response rates with just BRAF inhibitor alone. In colorectal cancer, that strategy was ineffective. And that is what led to all the preclinical work that then revealed that you need a combination therapy because the adaptive resistance is via EGFR. And so unless you block that, the pathway actually is reactivated through the RAF has BRAF and then the RAF has CRAF. And if you block BRAF, the CRAF is hyperactivated, then the pathway kind of shifts back through EGFR, and then the blockade is ineffective with just BRAF inhibitor unless you also block the EGFR.
For the last study that you were presenting on circulating DNA, which we could not complete, I just wanted to ask you, the chromosome, the mutations that you were testing in the circulating DNA in this study, the mutations that they were testing, was the tumor also tested for it?
If I recall correctly, the Circulate study used a tumor-informed ctDNA assay. It was not a plasma-only assay. The tumor-informed ctDNA assay utilizes a tissue-based analysis to decide which of the alterations to base the ctDNA analysis on. And so, yes.
Okay, thank you.
But that only affects the sensitivity of the assay, right? The tumor-informed assays are traditionally more sensitive because what is being detected in the blood is kind of tailored to what is the known genomic alteration of the original primary tumor.
I want a question from Professor Saif, that it's a question from every clinic and we face daily in our practice when we use atezolizumab, and whenever we want to go beyond 800 milligram, we all feel kind of unsafe. There are certain known and unknown reasons for it. I mean, for those patients whose calculated dose is 1000 milligram or 1200 milligram bevacizumab, what do you think treatment remains standard, and up to which level we can safely de-escalate the dose of bevacizumab with atezo, particularly when we practice Embrace 150?
So I think you're asking an important pharmacological question. So if you go to the drug insert, I always tell people drug insert is your best friend. If you look at the drug insert for bevacizumab, it says that if somebody's dose is more than 1000 milligram, give it over a longer duration, observe them for 1 hour. Mostly I try not to go beyond 1000. I think you're giving enough dose. So I think that's where I kind of cap myself. But I think the most concern is that that you have to be careful with the reaction, hypersensitivity reaction to those patients, and you need to observe them longer and you need to give them over a longer duration. You also need to understand that the way the insurance pays us and how we utilize our chemo chair is very, very technical. So let's say the first hour the insurance pays me $50 for the chair. For second hour they pay me $10. Unless until there is a scientific reason or a clinical reason that I have to give chemo over longer duration, I will not do that thing because my institution will lose money. Let me give you an example of oxaliplatin. A patient develops pharyngeal anesthesia, so the only treatment is to give oxali over 4 hours instead of 2 hours. So I have to get approval. I have to write a scientific rationale with a logical article to be submitted so I can really got it approved for 4 hours for oxaliplatin to be given because we lose money. So I think it's a very important what I call pharmacoeconomics part in addition to clinical vigilance.
Just a query and not related to this session. I want to know your thoughts about non-operative management of lower GI cancer, particularly colon and colorectal, because patients and families come to us, they go to AI, go to Google and study non-operative management of rectal cancer and colorectal. कितना ज़्यादा ये commonly practice हो रहा है US में, कितने लोग या कितने clinician इसमें opt करते हैं to give non-operative management?
So I think in terms of MSI high, so yes, those patients can be cured. And I can count innumerable patients right now. Even I have patients, with gastric cancer who refuse to give treatment, but I have patients with colon cancer, stage 3 and stage 4, where they refuse to get immunotherapy, chemotherapy, and they happen to be MSI high. The beautiful part is that pembro, it can be given sub-Q. So that's even more beautiful. Like I have a gentleman who does not want to get the port. He has stage 4 colon cancer, does not want chemotherapy because his grandmother died 69 years ago because of chemotherapy. So he's still afraid because he was a kid. So, he gets pembro every 6 weeks sub-Q. So there is a beauty about giving, so you can give every 6 weeks over 2 minutes, or you can give, every 3 weeks over 1 minute. So I think the bottom line is this is the whole purpose of understanding different routes of therapy and trying to understand the patient. So I think now going back to the social media, you cannot stop anybody, including anybody sitting here or patients. So that brings a lot of misinformation and also a level of understanding. So I think your job is to just try to educate them, develop some patient handouts. What we use for chemotherapy, something called ChemoCare. If you guys are not aware, go to Google, type in ChemoCare. If you have access in this country, use ChemoCare to give side effects of the chemo and immunotherapy to the patient. It gives you a very beautiful layout of the most common side effects, when to call the doctor. ChemoCare.com.
Hello. Overall, would your first choice be Nivo-AP or pembrolizumab? Or is it because the outcomes are similar, or is it because of ease of pembrolizumab?
Again, if my patient is, keep in mind we see a lot of geriatric population because American people are living longer. So it's based on the age and the comorbid condition of the patient. But I'm very comfortable giving people single agent because you see very similar results and you don't have to hit them with two hammers.
So thank you very much. We'll finish the session here. If anybody has any more questions, then you can ask the panel after we are done. Thank you very much. Bismillahirrahmanirrahim. So, Assalamu alaikum and a very good afternoon, ladies and gentlemen. So first of all, on behalf of Martin Dow Limited, we would like to appreciate whole organizing team for arranging such a beautiful conference. The sessions and the exhibition area, everything is so perfect so far. So, Alhamdulillah, I'm here, Sayyid Muhammad Arif, representing Martin Dow Limited. So we have got the opportunity and a slot on cabozantinib. We have recently launched cabozantinib by Cabotrex name. It has 2 strengths, 20 mg and 40 mg available in the market. And it has very good credentials, bioequivalent. The plant is FDA approved,
WHO accredited and European agency accredited. So for that, we have the topic of the presentation, the role of cabozantinib across tumor types. And for that, we have our speaker, Dr. Amjad Zafar. He is a consultant medical oncologist based in Lahore, actively involved in the management of a wide spectrum of malignancies across multiple tertiary care hospitals, including PKLI and Hamid Latif. So please join us in welcoming Dr. Amjad Zafar on the stage. And we also have our expert panelist, Dr. Abbas Khokar, HOD Oncology and Radiotherapy Department, Mayo Hospital, Lahore, Professor Dr. Kausar Bano, HOD Oncology, Jinnah Hospital, Lahore, Dr. Tahir Bashir, Associate Professor, HOD Oncology, Allied Hospital, Faisalabad. So we request you to please come up on the stage. Thank you.
Okay. Assalamu alaikum and good afternoon. It's absolutely a pleasure to be here. Among the familiar faces, most of them we recognize, some are youngsters. I mean, it's a pretty basic talk. This is something you can see, you can look up into your Googles, in your chat GPTs. I mean, I'll be very happy to discuss a few things after the talk in the panel session if you have any queries, you know. Cabozantinib, we all know. I mean, this is sort of the roadmap of my talk. We're going to talk about a bit about the molecule, then its uses in different carcinomas, namely renal, hepatocellular, thyroid, and neuroendocrine. Okay, we all know that there are multi-kinase inhibitors, and cabozantinib is one of the multi-kinase inhibitors. I mean, mainly it hits VEGF, R2, MET, AXL, and RET genes. Why is MET and AXL alongside VEGF important? You know, once you target the VEGF mutation, you know, then you get the MET and AXL overexpressed, and targeting them simultaneously gives you an added benefit. This is the use of cabozantinib over the past 13 years, and it has led to 7 approvals across the various cancers. Renal cell carcinoma, I mean, this is the METEOR trial, cabozantinib versus everolimus. This was randomized 1-to-1 advanced RCC in at least after 1 VEGF inhibitor. What you can see is an improvement in the median progression-free survival as well as the median overall survival. This was the first phase 3 trial in advanced RCC to show progression-free survival, overall survival, and good response rates. And it held benefit across all MSKCC groups, including the intermediate and high-risk groups. I mean, a bit of caveat right now in 2026 would be that the comparator arm was everolimus, which routinely we do not use right now as second line. I mean, for some it may be an option, but for majority of our patients, we do not routinely use everolimus. So perhaps that is something we can look into. Cabozantinib was another trial in which this was the first line use of cabozantinib versus sunitinib, randomized 1:1, advanced RCC, intermediate and high-risk group. What we saw was an improvement in the median progression-free survival, 8.6 versus 5.3, an improvement in overall survival as well, although it was not powered to see the overall survival per se, but still, I mean, there was a moderate benefit. The response rates, 46 versus 18% by the investigator and 20 versus 9% by the independent review. So why does it really matter? I mean, this is something which we can still use in the first line for many of our patients in a country like ours where resources, where immunotherapy is limited. Then this is check.
Hello, everyone. It's a great pleasure for me to have the opportunity once again to share some updates from EGFR mutated lung cancer treatment from the ASCO 2026 meeting. Today we will cover some of the emerging areas, and I will try to keep it as relevant to clinical practice as possible. These are my disclosures. So I'll talk about the common EGFR mutations first, where there have been some recent developments, and then we'll talk about EGFR exon 20 insertion, uncommon mutations, and finish up talking about HER2 mutations. Now, we have seen a lot of exciting developments over the course of the past few years when it comes to treating patients with exon 19 and 21 mutation. And based on all of this, this is sort of the summary of where we are. For first-line therapy for newly diagnosed patients, the go-to drug seems to be osimertinib, which is the third-generation EGFR inhibitor, whenever it's available. Now, a more treatment-intensified approach that involves either combining chemo plus osimertinib or giving amivantamab, which is a monoclonal antibody that targets EGFR and MET, in combination with another third-generation drug, lazertinib, is also a proven option. So both the chemo plus OC combination and the amivantamab and lazertinib combination improve overall survival. I'll briefly show you the data. And the question is, which patient should receive just the monotherapy with osimertinib, and which patient should receive the combination? Based on the fact that there is clear improvement in survival with the treatment-intense combination approaches, the field seems to be moving close to giving combination for a majority of the patients. But if you have a patient with exon 19 who has minimal disease, older patient with comorbid conditions, then maybe monotherapy is appropriate. There are some changes in the second-line therapy I will talk about. I want to point out that immunotherapy does not work for these patient populations, so we don't typically give PD-1 or PD-L1 blockers. In appropriate situations when patients develop acquired resistance, it's important to think about conversion to small cell histology that can happen in 5 to 10% of the patients, or even conversion to squamous cell histology. So let's refresh our memory. This is the survival result from the FLORA study, which compared osimertinib to either erlotinib or gefitinib. They showed that there was a significant improvement in survival for osimertinib. It also has significant CNS activity, to the point where now if somebody is diagnosed with sub-centimeter CNS metastases, we typically do not offer them local therapy. We just treat them with osimertinib because it has good brain effects. And this can be said for other third-generation EGFR TKIs as well. The FLORA-2 study involved the combination of chemotherapy plus osimertinib compared to osimertinib. And here you see very significant survival improvement results with the combination. There's almost 11-month improvement in overall survival for the combination of chemo plus OC. Hazard ratio is 0.77. And the median survival now is about 4 years for this patient population with this combination approach. Then when you look at the amivantamab and lazertinib combination, once again, you see a similar hazard ratio of 0.75, improvement in survival. This regimen does have more toxicity when it comes to skin infusion reactions. There's also about a 38% chance of developing a deep vein thrombosis in the first few months of therapy, deep vein thrombosis or pulmonary embolism. So you have to give prophylactic anticoagulation. You have to be very aggressive in using prophylactic measures to reduce the severity of skin rash. You have to have plans in place to treat infusion reaction or prevent infusion reaction. So there are considerable adverse events associated with this, yet it does improve survival. In my practice, I tend to use more chemo plus osimertinib for treatment-intensified approach compared to this regimen because of the toxicity considerations. Now at ASCO this year, there was an interesting study. I wouldn't recommend this for your clinical practice. This is just to show you an interesting approach that's emerging that could help us figure which patient can be treated with monotherapy osimertinib and which patient requires combination. And for this, they used ctDNA clearance. As you know, not every patient with EGFR mutations, you can pick their mutation on their peripheral blood.
by ctDNA analysis. But about 70% of patients with EGFR mutation who have stage 4 disease, you can pick the mutation in the blood. So what did this group do in China? They enrolled patients with EGFR exon 19 and 21. All patients got osimertinib for 3 weeks, and then they got their ctDNA analysis. And in patients, the ctDNA was persistent. They randomized them to osimertinib versus the combination of chemo plus osimertinib. The assumption here is if your ctDNA is cleared in 3 weeks, those patients are already doing well on osimertinib, and they just continue on osimertinib monotherapy. So this is only patients who had persistent ctDNA positive disease, comparison of chemo plus OC versus OC. And interestingly, in this group of patients where there's persistence, where the outcome is less favorable, the chemo-OC approach was associated with better progression-free survival compared to continuing osimertinib. Now, these are small numbers, early results, but what this tells you is there are ways in the future we will be able to risk stratify patients with EGFR mutation and be able to decide who receives single-agent therapy and who receives a treatment-intensified treatment combination approach. What happens when patients develop acquired resistance? This is broadly how we are approaching it. There are known mechanisms of resistance, and strategies are ongoing to develop agents that target the specific mechanism. But I would say that's still experimental. At this point, we are still using mechanism-agnostic approaches. So I don't feel strongly about doing a biopsy at the time of progression unless we are worried about small cell conversion. And that is prompted by extensive mediastinal nodal enlargement, very rapid progression of disease, where we are worried about histological transformation. I also want to point out that for patients who have oligoprogression, when you have one lesion that's growing, we use local radiation therapy like stereotactic body radiation therapy or gamma knife to treat that particular lesion and then move forward with continuation of the TKI. There was an interesting question that was addressed at a study presented at ESMO last year, where when patients develop disease progression, they randomize them to chemotherapy or switching to chemo, or adding osimertinib on top of chemo. In other words, patients continued on osimertinib, you bring in chemotherapy to see whether continuation of osimertinib beyond progression is beneficial. And interestingly, there was a benefit for continuing osimertinib beyond progression, suggesting that even in the setting of acquired resistance, there are some sensitive clones to osimertinib, and continuing osimertinib to suppress these clones is associated with favorable outcomes. So if you're going from OC to chemo in the second-line setting, continuation of osimertinib would be appropriate. If the patient has brain metastasis, of course, at baseline, we feel more strongly about continuing OC and adding chemo because OC is helpful in stopping progression within the brain. So what are the candidate resistance mechanisms? These are old data now. We showed it in the FLORA study. Two main mechanisms to keep in mind. One is patients can develop the C797X mutation, C797S mutation. That's seen in about 7 to 10%, and MET amplification, which is seen in about 15 to 20% of the patients. So there are fourth-generation EGFR inhibitors that are being developed that specifically target C797S. There are combination approaches that target MET that are also currently being studied, and we've seen some early results. I would say the overall PFS results in these settings have been in the 7 to 9 months ballpark with some additional toxicity issues. So we've not seen anything that has wowed us at this point, and that's why if you have a trial and you do a biopsy to match patients to one of these approaches based on the resistance mechanism, it's perfectly reasonable. In a routine clinical practice setting, I don't feel strongly about getting a biopsy unless I'm worried about small cell conversion. There are some other promising approaches that are coming along. This is a drug called ivonescimab. It is an antibody that targets both PD-1 and VEGF. This is a randomized trial done in the second-line setting for patients with EGFR mutation who progressed on a third-gen TKI. So they compared patients who received chemo plus ivonescimab versus chemo plus placebo. This trial was done primarily in China. There were some Western patient populations that came in, They showed improvement in progression-free survival. The overall survival trend was favorable, but it was not statistically significant. They have submitted this. It's approved in China. They've submitted this in the US for FDA approval. And the FDA's position has been that we need to see more Western patient populations get these drugs to see if the results seen in China can be applicable to other patient populations. So curious, along with all of you, to see where this plays out, but interesting data nevertheless. One drug that was approved last year by the FDA is an antibody drug conjugate. This is datopotamab deruxtecan. It targets TROP2. The payload is deruxtecan, which you're familiar with. This deruxtecan is used in trastuzumab deruxtecan, used in treatment of breast cancer. So here, this was a study in patients with acquired resistance to EGFR TKI therapy. Giving this antibody drug conjugate intravenously once every 3 weeks resulted in modest benefits. Response rate is about 45%, median PFS is about 6 months, and the median overall survival is about 16 months. Main side effect is stomatitis. About 70% of the patients will get it. There's also some ocular toxicity in the form of keratitis. So using steroid mouthwash is a good way to prevent stomatitis. Having a high index of suspicion for ocular toxicity is important. So this is a drug that's approved in the US. We are using it in our patients in the second, third line setting for EGFR mutated non-small cell lung cancer. Another drug that's being studied is also a TROP2 targeted antibody drug conjugate. This is called sacituzumab tirumotecan. In this, patients who develop progression were randomized to either the sac-TMT or chemotherapy. This was a study exclusively done in China. They showed significant improvement in PFS. They also showed a significant improvement in overall survival. Again, you see stomatitis, which is common with this TROP2 targeted ADCs. And also the fact that whether this regimen would work in broader patient populations outside of China remains in question. So there are ongoing studies in the Western patient population. So some interesting options being developed in this setting in metastatic disease. I want to refresh your memory on early stage EGFR mutated lung cancer. The ADORA trial, which compared osimertinib to placebo after patients received surgery for stage 1B, 2, and 3A disease. There was a significant improvement in overall survival. So 3 years of osimertinib is approved and evidence-based in the postoperative setting for patients. The recent study looked at osimertinib in the neoadjuvant setting called NeoADORA. Here, patients with resectable lung cancer were randomized stage 2 to 3B to either OC mono, chemo plus OC, or chemo alone before surgery for 9 weeks, and then patients went on to get surgery. The preliminary results showed that the major pathological response rate was higher with OC-containing regimen. We don't know the impact on survival. We didn't see a big difference in complete pathological response. Regardless, these are interesting results. And in patients with N2 positive EGFR mutated lung cancer, I would favor the use of OC chemo for 3 cycles before they undergo surgical resection. And then continue osimertinib as adjuvant therapy. What about locally advanced stage disease? This is the LAURA trial. Patients with EGFR mutated lung cancer, exon 1921, completed chemotherapy and radiation, were randomized to osimertinib versus placebo, significant PFS results, and we are waiting for the survival results, final survival. We've seen a favorable trend. So that's where we are with common mutations. Let's switch gear, talk about insertion 20 mutations. This is a small subset of EGFR mutations. Look for the term insertion 20. Here, chemo plus amivantamab has been shown to improve median PFS. Chemo alone, 7 months. Chemo plus amivantamab, about 11.5 months. We have not seen the overall survival results. There are more toxicities. This is FDA-approved regimen. At ASCO this year, we saw an interesting study comparing a small molecule TKI, sunvozertinib, versus platinum-based chemotherapy in the first-line therapy setting for exon 20. And this study showed, improvement in overall survival improvement in PFS from 7.5 to 10.5 months, improvement in response rate. Common side effects with this drug are diarrhea, skin rash, and CPK elevation. So this is an option now, once it's approved, to get in the first-line setting. So currently for insertion 20 mutations, you could either go with chemo alone, or chemo plus amivantamab, or the small molecule sunvozertinib. Sunvozertinib can also be used in the second-line setting. There is another drug called zipalertinib that may receive FDA approval soon. So some orally administered drugs could be helpful in this patient population. There is no evidence that immunotherapy helps insertion 20 patients, so once again, we don't use immunotherapy. Now, one slide on atypical, or two slides on atypical EGFR mutation. These are called out in the box on your left, specifically 3 mutations, G7197X, the S768, and the L861. For this mutation subset, the combination of amivantamab and lazertinib seems very promising. Recent study at ASCO that showed that the response rate was 57%, median PFS is 19 months, and overall survival is 41 months. So for this group of patients, using amivantamab and lazertinib in the first-line setting, I think is an intriguing approach. Obviously, we talked about toxicity earlier. You have to give them prophylactic anticoagulation for a few months and prophylactic skin care and infusion reaction prevention. Finally, I'll finish up talking about HER2 mutations. Here, zongertinib seems to be a very effective drug. This is a study looking at use of zongertinib, which is an orally administered drug in patients with HER2 mutated lung cancer. The response rate here is approximately 70%, 55%. The intracranial response rate is 41%. The median PFS is about 12.5 months. So this is an interesting drug. These are patients who had previously been treated with other treatments. When you give this drug in the first-line setting, the dose is 120 milligrams per day. The response rate is 76%. The median PFS is about 14 months, and the intracranial response rate is about 47%. So very interesting results. This positions this drug in the first-line therapy for HER2 mutated setting for me. Another drug that's also available is sevabertinib. This is also a small molecule. Here you see the results of this drug in different subsets of patients. In the first-line setting, it has a response rate of 71%. In patients who already received a prior HER2-targeted therapy, the response rate is lower, about 40%. Median duration of response is about 8.5 months. Median PFS about 5.5 months. So this is, again, another interesting drug. It has some considerable safety issues related to EGFR inhibition, in the sense it has diarrhea, skin rash, paronychia, and so forth. Sometimes you have to reduce the dose of the drug. Sometimes you have to discontinue the drug. But overall, both zongertinib and sevabertinib add to trastuzumab deruxtecan, which is already approved in HER2-mutated setting. So in my practice now, when the oral agent is available, I use zongertinib. If you don't have access to it, if you can give trastuzumab deruxtecan, that's certainly a very good option for patients with HER2-mutated lung cancer. This is only about 2% of the patients with adenocarcinoma of the lung. So overall, what I have shown you is in HER2-mutated patients, chemotherapy remains still a very important component. Role of trastuzumab deruxtecan after you've given small molecules is not available, so keep an eye out for that. So overall, I think we continue to make progress in the treatment of EGFR-mutated lung cancer. We have better drugs. Now, if third-generation EGFR inhibitors are not available or the patient is not able to afford it, I think it's very reasonable to give gefitinib or erlotinib in combination with chemotherapy in the first-line setting. And if they develop T790 later on, you can hopefully get them a third-generation drug. That would not be my practice, but in a resource-constrained situation, that's certainly reasonable. Otherwise, third-gen drugs, either alone or in combination, have become standard of care. And I would emphasize the point that NGS testing is important for all patients with non-small cell lung cancer, regardless of the stage of the disease, because we're using these drugs even in patients with earlier stages of the disease. With that, I'll stop, and once again, thank you for your hospitality and your kind attention, and wish you the very best of the rest of the meeting. Thank you.
Now we'll move to the next talk, which is by Dr. Hassan Shahryar. He's an American board-certified oncologist with a special interest in thoracic malignancies, and he works in Dubai American Hospital. So, and then he will be present with us as well in Q&A session.
Assalamu alaikum and good afternoon, everyone. My name is Dr. Hassan Shahryar, and I'm a medical oncologist. I'd like to start by first thanking Dr. Najib Nematullah and Dr. Qasim for this very kind invitation. And again, it's such an honor and privilege to be part of Society of Medical Oncology Pakistan and giving you a talk today. I will be giving you some updates on the small cell lung cancer and we'll go over some of the abstracts that were presented at this year's ASCO. So first, I think there was a very nice and comprehensive educational session at this year's ASCO. It was titled Updates in Small Cell Lung Cancer, No Longer Too Small to Ignore, and I could not agree more. I highly encourage especially our trainees to look at it if they have access to it. But I will try to summarize that in the next 10 minutes, and the last 10 minutes we will go over some important abstracts. So in this slide, I think it very succinctly covers the evolution of small cell lung cancer therapeutic landscape through the ages. And as you can see, much of the progress came in the last 10 years or so. In 2018, when we saw the introduction of immunotherapy, the needles started to move, and since then, it's been no looking back. So very simply, if we were to summarize how we used to treat small cell lung cancer in the distant past, it was very simple as laid out here. In the limited stage setting, we had concurrent chemoradiotherapy with platinum etoposide. And in the extensive stage setting, we had the same chemotherapy, platinum etoposide, in the first line. And after progression, either we re-challenged them depending on their sensitivity to platinum, or we sometimes offered topotecan, which we all knew that was not a very great option. So there was a huge unmet need in this space. And then in 2018, we saw the two pivotal trials, IMpower 133 using atezolizumab and Caspian using durvalumab, changed the landscape. We saw the overall survival improvement with the addition of immunotherapy in the first-line treatment of extensive stage small cell lung cancer. This was, however, a modest overall survival benefit, but it became the standard of care and is still the current standard of care. And it showed that, as you can appreciate on the curves, that there is a tail at the end of the curve, and at the 7-year update of this trial, about 10% of the patients achieved a durable response. However, the issue is that we don't have predictive biomarkers to tell who are these patients and how to select them. And the other issue is that while most of the patients can tolerate immunotherapy, there are still some patients who will develop some side effects. So those are still some of the considerations we have to keep in mind. But this became the standard of care in 2018. And then very quickly on lurbinectedin, we saw a phase 2 basket trial in 2020, which showed a decent overall response rate of about 35% and a modest disease control rate in the range of around 70%. And this, because there was unmet need in the second-line setting, and this was better than topotecan, lurbinectedin became the second-line option in the extensive stage small cell lung cancer. However, as we know that once the drugs are approved in the later lines, they are gradually moved up. So Just recently, last year, we saw IM4 trial presented, which moved the lurbinectedin from the second line into the first line maintenance treatment with the immunotherapy. And it ended up showing a good improvement in the PFS and also in the overall survival with the hazard ratios of 0.54. And then this is an important or another option we can offer to our patients. So this is the overall survival curve, and you can see there is a clear separation in the curves. Now, this improvement in efficacy did come with a trade-off with some significant toxicities. The overall grade 3 and 4 toxicities were significantly higher with the combination of lurbinectedin and immunotherapy compared to just immunotherapy alone in the maintenance. And this is understandable since lurbinectedin is a cytotoxic chemotherapy. So there are still important questions, I think, unanswered, that while we do discuss the option of combining lurbinectedin with immunotherapy in the maintenance setting first line, it may not be for everyone. And I think another limitation of this study was that brain mets were excluded from this trials, which is an important, I think, subset in small cell lung cancer. As I said, toxicity can be an issue, and now we other challenge of how to sequence treatments, because as other promising agents are coming in this space, this space is becoming crowded, and how we sequence these therapies with immunotherapy is a question that we are going to grapple with. On the other hand, in the limited stage small cell lung cancer setting, we also saw the needle move with the addition of immunotherapy in the consolidation phase after concurrent chemoradiotherapy. So this is the Adriatic study using durvalumab, and it shows improvement in the PFS as well as improvement in the overall survival, and this is now the current standard of care in the limited stage setting. But I think what has really rocked the boat in the small cell cancer landscape is the T-cell engager, and specifically tarlatamab, which is a bispecific against DLL3, which is expressed on the small cell lung cancer cells, and CD3 on the T cells. And I think this has really made a significant improvement in our efficacy and thus changing the natural history of the disease. I will not go into too much detail in the interest of time, but we had series of Delphi studies which culminated into the Delphi 304 study. This was a phase 3 randomized trial, head-to-head comparing tarlatamab in the second-line setting with the best second-line chemotherapy. And this trial included patients who had progressed on first-line platinum chemotherapy with or without immunotherapy, and it also included patients who had asymptomatic or treated brain metastases. The primary endpoint was overall survival. And here's the result of the primary endpoint. There was a clear and significant improvement in OS with a hazard ratio of 0.60 and a statistically significant p-value. And this instantly became the preferred second-line option in the extensive stage setting. Other endpoints also show significant improvement in terms of response rates, duration of response, and PFS. Not only that, it also improved quality of life. So here is some data on dyspnea, cough, chest pain symptoms. All of these important symptoms showed improvement with the use of tarlatamab. But I think what is also very quite impressive is the safety profile. Actually, this had a better safety profile than the chemotherapy. Overall, grade 3 and higher side effects were far less with tarlatamab compared to chemotherapy. However, we know that T-cell engagers, they come with their own specific toxicity profile. And I'm referring to cytokine release syndrome and ICANS, or immune effector cell-associated neurotoxicity syndrome. So in the pooled analysis of all the Delphi studies, it showed that the CRS occurred in about 57% of the patients. But what is reassuring is that most of these events were grade 1 or 2, which can be very easily managed with steroids. And majority of these happened in the first cycle, either the day 1 or day 8. although they can still occur later, but rarely they occur later on. Similarly, in ICANS, the percent of the patients. But what is reassuring is that most of these events were grade 1 or 2, which can be very easily managed with steroids. And majority of these happen in the first cycle, either the day 1 or day 8, although they can still occur later, but rarely they occur later on. Similarly, in ICANS, the percentage was about close to 5%, mostly grade 1 and 2. So overall, even with this specific profile of toxicity, it was quite manageable, and that makes it a very compelling and promising agent. In the subset analysis of this study, focusing on the patients with brain metastases, which were included in the study, there was also a very clear signal favoring tarlatamab. I will come back to this later in one of the oral abstracts that was presented, specifically addressing this data set. So where are we going next? So currently, tarlatamab is also being moved forward into the first-line maintenance setting with immunotherapy. And while this is not currently the standard of care, but the preliminary data shows that there is already a very significant improvement in overall survival, reaching up to 2 years from the maintenance treatment. So I think this is a space where we need to watch, and it might change in the near future with early introduction of tarlatamab. And there are also several other Delphi studies using it even in earlier upfront setting with initial chemotherapy. So we will await those data with interest. So where does this all lead to now? So in this slide, I have tried to summarize the present state of our management in the small cell lung cancer. So in the limited stage, the concurrent chemotherapy with platinum etoposide followed by consolidation durvalumab is the standard of care. In the extensive stage setting, we have two standard of care options. First is the platinum etoposide chemotherapy with IO followed by just the IO maintenance, or we could intensify the maintenance with the addition of lurbinectedin with the IO in a certain selected subsets. Clearly, the second line is tarlatamab, and I don't see much role for topotecan in this space, small cell lung cancer. So now let's move to some of the important abstracts that were discussed at this year's ASCO. I would preface by saying that there was no practice-changing data. However, there were a few practice-affirming data sets that were presented. But most of the data is about where the future of small cell lung cancer treatment is going, and some of the very promising agents we are seeing very early data with those. So we'll discuss that. In the interest of time, probably won't be able to go into too much detail, but we'll highlight those abstracts. So we'll start off with the first one. This was in the oral abstract session, the concurrent thoracic radiotherapy, chemotherapy, and durvalumab in the extensive stage small cell lung cancer This was a phase 3 trial. I think this was a very interesting study which was addressing the age-old question of adding thoracic radiotherapy to the chest in the extensive stage setting with the standard of care of the platinum chemo and immunotherapy versus without the radiation. So this was a fairly straightforward study design in that sense. A primary endpoint was overall survival. The results are here. It was a flatly negative trial. The addition of thoracic radiotherapy did not improve overall survival, and in fact, it increased the adverse effects in patients who received thoracic radiotherapy. Even in the subgroup and different subgroups, we did not see any signal which could select us, which could allow us to select patients who might benefit from the addition of radiotherapy. So the conclusion is that concurrent thoracic radiotherapy does not improve survival in extensive stage small cell lung cancer patients receiving chemoimmunotherapy, and there are more adverse effects and treatment-related deaths in patients who receive thoracic radiotherapy, and it should be avoided. The second, I think, important abstract was the post hoc analysis from the Delphi 304 trial that we just discussed. And this was specifically looking at the intracranial efficacy of tarlatamab versus chemotherapy as a second-line option. And in this trial, they showed that there was a clear improvement in patients with brain mets. So here you're looking at the intent to treat population. So all comers in the Delphi study. And you see that the tarlatamab had improved the CNS progression or death compared to chemotherapy by about 46%. And when you look at patients only with brain metastases, so those who did not have brain mets at baseline. And again, it shows, those who did have brain mets at baseline, it shows again that it delayed the CNS progression or death in patients with brain mets versus chemotherapy. And this differential is in the range of 60%. So it's quite a significant improvement. And then in the aggregate analysis, I think this is an interesting graph here which shows 4 subsets. So there is tarlatamab in brain mets, tarlatamab without brain mets, and similarly chemotherapy with brain mets and chemotherapy without brain mets. And you can see in the chemotherapy curves, the blue curves, patients with brain mets do worse than patients without brain mets. But in the tarlatamab curve in orange and red, whether you have brain mets or no brain mets, tarlatamab improves overall survival. So it sort of overcomes the effects of brain mets, and patients do just as well. So the risk of death is reduced by almost 50% in patients with brain mets compared to chemotherapy. So this is just the conclusion. I just mentioned it improves overall survival regardless of brain metastases. The next important abstract is the Victory study. So this was a multi-center phase 2 single-arm study from China, which was evaluating the efficacy and safety of ivonescimab, which is a bispecific antibody against VEGF and PD-L1, combined with liposomal irinotecan as a second-line treatment option in the extensive stage small cell lung cancer. So this was a single-arm study, so we don't have a comparative curve here. But they selected the primary endpoint at 6 months of PFS, and I think it was the cutoff was around 45 to 47%, and in the results, it far exceeded that cutoff. So we saw a PFS of 69%, which is a significant improvement in the PFS compared to the historical. So the key takeaway from this abstract was that there was a promising anti-tumor efficacy with this combination, and median PFS of 8.1 months, objective response rate of about 62%, median duration of response of 7 months in second-line treatment with ivonescimab plus liposomal irinotecan. And they also did a subset analysis which showed that there was a consistent benefit across the platinum status. So whether you're refractory or sensitive, all patients benefited, and the safety profile was quite acceptable with a grade 3 about 36%. Our next abstract is ABBV706, which is a first-in-class ADC against CES6, which is a biomarker which is expressed on small cell lung cancer. This was tested as a monotherapy and in combination with a novel anti-PD-1. And we saw some really promising responses. Strong anti-tumor activity was observed. So we were looking at a clinical benefit rate exceeding 90% at the recommended dose of 1.8 milligram per kilogram across different subgroups. So this is a very early phase 1 study, but it seems to be a very promising compound, something that we will be watching in the next series of trials. So this is the takeaway. As I mentioned, it's a ADC against CES6, a neuroendocrine lineage marker, and the median overall survival of 14.3 months in a heavily pretreated population. So it is quite significant. Coming to the rapid oral sessions, so these were there were a few I think interesting studies in the small cell lung cancer. So we'll go through them very quickly. So I thought first one was the transcriptomic analysis of the molecular subsets and the correlation with clinical outcomes from the IM4 study. Remember, the IM4 study used lurbinectedin plus atezolizumab as a maintenance strategy, and the question is that are there any subsets which benefit from this combination? Again, not going into too much detail, but they divided small cell into different molecular subtypes: small cell lung cancer A, small cell lung cancer NE or neuroendocrine, and non-endocrine, inflammatory, and different subtypes. And they did the survival analyses. The conclusion, and I think the main takeaway, was that the PFS and OS benefit was observed across all molecular subtypes. And I think the more important thing to me was that the addition of lurbinectedin seems to be overcoming some of the tumor-associated macrophage-mediated resistance to atezolizumab. So the combination of chemo-IO seemed to be better because of this overcoming of the resistance. I think mention must be made of CAR T cell therapy, as we know that CAR T the role is expanding in the solid tumor area. So we saw a phase 1 study of LB2102, a DLL3 targeted autologous CAR T cell therapy. And again, the key takeaways was that there was a very favorable safety profile. There was no dose-limiting toxicities, and CRS and ICANS were manageable. And there was a very encouraging anti-tumor activity seen, objective response rate of around 30% with a disease control rate of around 80%. Durable responses, median response of about 6.5 months with ongoing responses. So I think this preliminary data is quite exciting. And my last abstract is also similar to the previous one, but using autologous natural killer cell infusion as a consolidation in the first line in the limited stage small cell lung cancer. This was a phase 2 study, and it showed that in patients who received the autologous NK cells as a consolidation had a better PF and OS, and safety signals were similar between the two groups. So this seems to be something interesting as well. So with that, I think I would stop here, and thank you for your attention.
And now I would like to invite Professor Colonel Dr. Omer Tufel. He is Professor of Medicine in Beria, University of Health Sciences, and he had FCPS Medicine, Medical Oncology, followed by two fellowships from College of Physician Surgeon, and followed by Advanced Fellowship in Medical Oncology from Birmingham University. Omer.
Bismillahirrahmanirrahim. Because we are lagging on time because of this electricity issue, so I'll be streaming up with my role. Best of ASCO here is I'll be doing non-small cell lung cancer. Best of ASCO articles. I have 3 articles to present. So the first one is Libretto 432. It's basically for the first time presented in RET gene fusion, resected non-small cell lung cancer in the use of selpercatinib in the adjuvant setting. The background is we all know that in non-small cell lung cancer, targeted therapy are getting into the mainstay of treatment as far as oncogene-driven tumors are concerned. With the advent of ADORA and ALINA, where osimertinib and alectinib are producing remarkable results in the adjuvant setting, the same concept is being used by Libretto 432, which used selpercatinib for the first time in the adjuvant setting for RET fusion gene positive lung cancer cases. So this trial is a global multicentric phase 3. Key eligibility criteria is histologically confirmed RET fusion gene positive non-small cell lung cancer. Definitive treatment is a must, either in the form of surgery or radiotherapy. Systemic adjuvant chemotherapy is optional, and there should be no disease recurrence or progression following definitive therapy. So this set population was randomized 1:1 ratio between 2 arms. The experimental arm is selpercatinib, weight-based ratio continued for 3 years in the adjuvant setting, while the control arm is placebo for 3 years. Primary endpoint was event-free survival, while secondary endpoint was overall survival and safety analysis. The results were stratified with respect to stage of the disease, and results were stratified with respect to form of definitive treatment, whether it's surgery or radiotherapy. As far as baseline characteristics is concerned, more or less all the characteristics are equally matched between the 2 groups. Median age is 60 years between the 2 groups. Male and female gender both equally distributed between the 2 groups. RET fusion types, that is KIF5B and CCD6, more or less equally distributed between the 2 groups. And PD-L1 status, again, negative and positive, equally distributed between the 2 groups. The important thing to note is 100% patient in the selpercatinib arm received surgery as the definitive form of treatment. Similarly, more than 95% of cases in both the arm received adjuvant chemotherapy before they were given selpercatinib or placebo. As far as results is concerned, the event-free survival at the cutoff point of 2 years is 90% cases in the selpercatinib arm were disease-free, while only 60% cases in the control arm were disease-free. The hazard ratio is remarkable, that is 0.172, which in other words means that selpercatinib has reduced the chances of disease recurrence by almost 80% in the adjuvant setting as compared to placebo. This result is seen in all subset population. With respect to male and female gender, the hazard ratio is very good, 0.182. Again, with respect to stage of the disease, the higher the stage, that is stage 3, is giving a better hazard ratio, 0.098, while stage 2 is giving a hazard ratio, 0.663. Considering that 95% of the cases received adjuvant chemotherapy before selpercatinib, so this trial was underpowered to state whether we can forego chemotherapy. But once the toxicity profile is concerned, selpercatinib do come with toxicity, some toxicities. For example, in transaminitis, it is 18% in the placebo and it is 62% in the selpercatinib arm. There are some more diarrhea, dry mouth and cough more in the selpercatinib arm as compared to the placebo. But the good thing is more than grade 3 treatment-related side effects were easily manageable with dose reductions and dose interruptions. 54% cases has to reduce dose in the selpercatinib arm because of grade 3 side effects. Similarly, 77% of the cases has to interrupt doses in the selpercatinib arm because of treatment-related side effects. But only 17% of the cases came off the selpercatinib arm because of these toxicities. So in the end, it can easily be concluded that selpercatinib is now the standard of care for the adjuvant treatment, RET fusion gene positive resected non-small cell lung cancer. The hazard ratio is very good, 0.17. Side effect profile is easily manageable with dose interruptions and dose reductions. And I think the take-home message from here is now the NGS-based study is essentially required even in earlier non-small cell lung cancer cases. The second study is Harmony 6. Harmony 6 is again a phase 3 trial presented in the plenary session of ASCO 2026. It's the comparison of ivonescimab with chemotherapy versus tocilizumab with chemotherapy in the squamous cell lung cancer population stage 4. Ivonescimab is the new drug in town. It's a bispecific antibody. It blocks the VEGF receptor and the PD-1 receptor. We all know that the squamous cell lung cancer, stage 4, is the most difficult one to treat. We know the traditional chemoimmunotherapy arms are showing very less response rates. Harmony 6 has tested the standard of care, that is chemoimmunotherapy, with the new drug, which is ivonescimab with chemotherapy. This trial is again multicentric, randomized, double-blind. The eligibility criteria were advanced stage, that is stage 4, but only squamous cell lung cancer population. No prior systemic therapy was allowed, no targetable EGFR and ALK mutations were allowed, and ECOG 01 was allowed. This set of population was randomized 1:1 ratio between ivonescimab chemotherapy 4 cycles, followed by maintenance ivonescimab for 2 years, while the control arm is traditional chemoimmunotherapy 4 cycles, followed by immunotherapy for another 2 years. Primary endpoint was progression-free survival, secondary endpoint was overall survival, and the results were stratified with respect to stage of the disease, that is stage 3B and 4, and respect to PD-L1 status as well. As far as the baseline characteristics, age less than 65, age more than 65, both equally represented between the two groups. The important thing to note is 95% of the cases in both experimental and control arm were male in gender, very less female participation in this trial. PD-L1 status less than 1, more than 1, 1 to 49, and more than 50%, equally distributed between two groups. And the tumor characteristic, whether it's a central tumor, history of hemoptysis, it's a cavitary squamous cell carcinoma, again equally distributed between two groups. When we see the results, it's the interim analysis presented in ASCO 2026, and it shows that what we typically see with all chemoimmunotherapy arms, the Kaplan-Meier curve starts widening apart at 6 months' time. And the cutoff point of 30 months, overall survival with ivonescimab is 27.89 months versus 23 months in the traditional chemoimmunotherapy arm. The hazard ratio is 0.66. This means that the ivonescimab is improving the median overall survival by 3 to 4 months. Again, this better hazard ratio is more or less seen in all subgroup, but important thing to note, age less than 65, the hazard ratio is 0.43, but with age more than 65, the hazard ratio is nearing to 1, which means that probably ivonescimab is not producing the same effect in elderly population. With respect to PD-L1 status, PD-L1 less than 1, more than 1, 1 to 49, more than 50%, everybody is showing the same hazard ratio, that is 0.64 and 6.5. So ivonescimab is working irrespective of PD-L1 status. Again, with respect to sites of Mets, liver or brain, both the sites of Mets are showing beneficial response with ivonescimab in chemotherapy. Side effect profile, as we see the chemotherapy side effects, that is anemia, thrombocytopenia, and neutropenia, more or less same between the two groups. Immunotherapy side effects, transaminitis, more or less same between the two groups. But we all are concerned to see what are the VEGF-related side effects between the two groups. So as far as proteinuria is concerned, it is 9.8% of grade 1 in the control arm, while it's 42% in the experimental arm. Similarly, hemorrhage is 24% in the experimental as compared to 10% in the control. And hypertension is again more in the ivonescimab arm as compared to chemoimmuno arm. The good thing is thromboembolism is more or less same between the two groups. In the end, Harmony 6 has proved that probably the new standard of care in squamous cell lung cancer stage 4 is ivonescimab with chemotherapy instead of traditional chemoimmunotherapy. The hazard ratio is 0.66. Last but not the least is the trial which has redefined the eligibility criteria for lung cancer screening. We all know that lung cancer is #1 leading mortality cause worldwide, and this cancer mortality has been reduced by 20 to 25% with the introduction of the concept of lung cancer screening in high-risk population. High risk has traditionally been defined by history of pack year history of smoking. So by 2021 US PSTF criteria, any patient who has more than 20 pack year history of smoking qualifies to enter into lung cancer screening. One thing to note is pack year means packets of cigarettes smoked per day multiplied by number of years of smoke. This trial has introduced a new concept of screening eligibility, which is based on duration of smoking rather than pack year of smoking. So the new proposed criteria says that any person who has more than 20 years of smoking qualifies to enter in lung cancer screening. And the question of this trial was whether smoking duration criteria behaves equally as compared to pack year history of smoking as far as lung cancer incidence is concerned. Now, this trial is a retrospective analysis of 1 million veteran cohorts who presented to Veteran Health Association hospitals of USA between the year 2021 and 25. Smoking history was taken from electronic records. There were 2 cohorts made. One of the cohort used smoking history duration criteria as an eligibility to enter into lung cancer screening, while the other cohort used pack year history of smoking as an eligibility before they enter into lung cancer screening. And the outcome is lung cancer incidence between these 2 cohorts. The first thing that they noted is once USPSTF criteria was used for lung cancer screening, 67% of the veteran patients enrolled in lung cancer screening. While the new proposed criteria, which is smoking duration criteria, was used, 87% of the veteran patients enrolled in the lung cancer screening. In other words, the new proposed criteria is increasing the cohort of lung cancer screened patients by about 30%. Another important thing to note is smoking definitely increase the chances of lung cancer. For never smoker, this trial showed the incidence of lung cancer was 0.14%. While for those who has more than 20 years smoking duration, they have the incidence of lung cancer 1.59%. And those who have more than 20 pack years history of smoking, the incidence of lung cancer is 1.85%. In other words, any patient who has more than 20 years history of smoking duration has 11 times more chances of developing lung cancer as compared to never smoker. Last but not the least is potentially missed lung cancer diagnosis. 13% of the cases developed lung cancer in the cohort which used pack year history of smoking as an eligibility to enter lung cancer screening. But only 3% of the cases developed lung cancer in the cohort which used smoking duration as a screening eligibility criteria, which means that smoking duration criteria is reducing the chances of missed lung cancer diagnosis by almost 70%. In the end, it can be concluded that smoking duration criteria is easier to use rather than pack year history of smoking. This new criteria is increasing the cohort of lung cancer screening by 30%, and this newer criteria is reducing the chances of missed cancer diagnosis by almost 70%. This has been endorsed by the fresh update of NCCN as well, where history of 20 years of smoking gives the eligibility to enter into lung cancer screening protocol. I end my presentation here. Thank you for your patient listening.
Thank you very much, Dr. Omer. May I invite our panelists, Dr. Kamran Rashid, Dr. Abbas Khokhar, and Dr. Hira Khan Afridi to the podium, please. Omer is already there. And probably Dr. Suresh Ramalingam and Dr. Sharyar will join us. They're online? So let's start the discussion once our guests arrive. So first, I would like to ask Dr. Omer about the libretto trial. So in sulpercatinib, how many patients were there who had received IO? Or do you use IO in early or late phase or advanced phase red positive adenocarcinoma? ऊपर से चेक कर लेना. Welcome Dr. Suresh Ramalingam and welcome Dr. Hassan Sharyar. I'm Dr. Qasim Buttar moderating this session for you. So we have started the discussion and you had a wonderful talk and so did Dr. Hassan Sharyar. So let's start the discussion and questions from the audience, please. Omer.
So, Dr. Qasim, the thing is, Libretto 432 trial is the adjuvant sulpercatinib use. It's RET gene fusion positive cases. We know that PD-L1 positive cases and negative both were included in the population. And when we see the subset analysis, both PD-L1 negative and positive is producing good hazard ratio. I personally feel even in the metastatic disease, if there's a RET fusion gene positive, we don't use IO in the initial first line setting. We use always the targeted drug first line. And then once there's a progression, we use chemotherapy. Even NCCN endorsed that with RET fusion gene positive, the response of immunotherapy is very less. So I personally feel immunotherapy has no role in the adjuvant setting for RET fusion gene positive resected lung cancer.
Okay, so no IO for RET, obviously. And what about the discontinuation rate? It was 17% in this adjuvant study, but it was only 5% in the advanced study. So what could be the reason for that?
Again, the thing is, it's the adjuvant setting. And all the patients have received chemotherapy before they were started on sulpercatinib. So in the adjuvant setting, we all are very wary of even the grade 1 side effects. So 17% took off the trial because of majority of them had grade 1 side effects. Very less had grade 3 and side effects.
Okay. Then coming to Dr. Kamran, most of our driver mutation positive lung cancers are non-smokers. So what is the strategy? Is there any strategy for screening or early detection for these patients? Because they do not qualify for the usual screening guidelines.
Well, there is a study which was done in Taiwan, South Asia, known as the Talent Trial, in which what they did was they took certain population of patients who were non-smokers or light smokers. And they had certain characteristics, like they had a family history of lung cancer, they have a history of COPD or any allergies, and or a history of passive smoking, that somebody smokes heavily in the house and they get second-hand smoke. And what they showed in that study was, and these patients got low-dose screening CT scans. And what they showed was that the detection rate of these non-smoker population was 2.5 to 3.2%, which was as high as the NLST study which was done in the smokers. And 96% of the cancers were at stage 0 or stage 1. So in these population, offering them low-dose CT scan screening can be a good strategy to pick them up earlier on so that they don't become metastatic disease.
Okay. Taking this question further to Sir Suresh Ramalingam. Sir, is there any role of ctDNA in these driver mutation positive for early detection? So is there any role in sputum or in blood of getting the ctDNA?
Thank you, Dr. Qasim. Good evening, everyone. There is a lot of interest in using these early detection tools based on blood-based ctDNA, so-called MSET tests. I would say we saw the results of a randomized trial at ASCO from the UK National Health System study, where in a large 150,000 patient or subject study, there was no difference in incidence of advanced stage cancers, which was the primary endpoint for using blood-based detection. So my view is these tests are very promising. They are still early technology. I would not recommend it for routine screening at this time because we still have to show that they are able to detect cancer early at a point where we can intervene and cause cures, so there is an overall mortality reduction. I look forward to further large longitudinal studies that will show this. None of the companies that are doing these studies right now have a mortality endpoint. Understandably, they want to get the product to the market, and they want to say that our test can pick more early stage cancers, but even at that, these tests are failing currently. So I'm cautiously optimistic. I think the future state is we will be using these tests, but I suspect it will be the next generation and the following generation. And we may use it in conjunction with something else. The test alone may not be sufficient to narrow the risk. Test positive is helpful, test negative is not helpful in excluding the possibility of cancer.
Now going to Dr. Hassan Shahyar, are the molecular subtypes of small cell lung cancer ready for the prime time, or you think it is still immature to consider this?
Yeah, it's a good question. First of all, thank you for having me, and apologies for not being able to make it in person. I think the molecular subtypes are further defining our understanding of biology of the disease, But at this point, they are not helping us decide on the treatment approach. I think it's still early. We saw some transcriptomic data from the IM4 study, which characterized according to different molecular subtypes, but it seemed like it was irrespective of their classification, all patients seems to benefit from the combination of chemo and IO. So I think this is an evolving field. At this point, our treatments are not directed against any particular subtypes, but I think that's where we need to focus more on, and hopefully we'll see some more developments.
Dr. Naila, please. Thank you.
So I want to share a real-time case from our part of the world, and I think a lot of us face this. So I had this patient with adenoceal lung, and he was PD-L1 positive and red gene positive. So at that time, red celiprolol was not available, and I wasn't even sure if I'll get it. So he was started on pembrolizumab along with chemo, and then a couple of months later, celiprolol became available. So what should be done? Should he be switched or not?
I think I'll let Dr. Suresh Ramalingam to please take this question.
Yeah, thank you for this question. It reminds me of a very similar patient I had a few years ago, and I was also in the same window where the drug was not available outside of a clinical trial. The patient came to me after having started immunotherapy. And if the patient is, at that time, the patient was actually responding to chemoimmunotherapy. Now, I don't know if it was responding just to chemotherapy or adding immunotherapy had an effect or not, but I let them stay on what was working, and at the time of progression, I switched him to selpercatinib. So if your patient is benefiting right now, leave them on what they are on. If the disease is progressing or he's not tolerating, I would have a very low threshold to switch to selpercatinib.
So just to give a follow-up, I actually decided to switch. I think I was just very attracted that this drug is now available, knowing that having used immune checkpoint inhibitors and then using TKIs can increase the pulmonary toxicity. But still, I took a chance and started on selpercatinib, but patient developed grade 3 hepatotoxicity, which persisted for like 2 months. So then
I think, as you saw from the previous presentation, the ALT, AST elevation is a fairly common event. I would say dose interruption and dose reduction can help in a lot of these situations. I also tolerate some level of ALT elevation in these patients. I treat them. If the ALT is 150 and AST is 140, I'm okay as long as it's not continually rising. So maybe, perhaps you've already tried it.
So it was continuously rising, and so I had to stop. Once it corrected, I switched back to immunotherapy and chemotherapy. So, and then the patient had a complete response. He's now 5 years out. He's on just immunotherapy. But now, for how long should I continue?
What you point out is the practical realities we deal with, right? The science of medicine versus the art of medicine. So if the patient is free of disease 5 years, my approach to using immunotherapy in advanced stage diseases, at the 2-year time point, I get a PET scan. If the PET scan shows no evidence of disease, I feel very comfortable stopping the immunotherapy and following them closely. I don't tell them you're cured of your cancer, because I always find that majority of them still end up having recurrent disease. But I feel comfortable stopping if there is no visible disease on the scans.
Thank you, sir.
Dr. Hira? So I have a question from Dr. Suresh. So looking at the FLORA-2 trial, on Monday morning, if a patient is fit enough to receive Aussie plus chemotherapy, do I offer FLORA-2 or I switch to the FLAME study? Looking at it, that it's a phase 2 trial. What would be your take on it?
I think the FLAME study is more a proof of principle. It's a very small trial at this point. There are a lot of open questions about what p53 mutations, persistence of ctDNA when you measure it. Is 3 weeks the right time point? Do you give it a little more time and so forth? So I feel that the field has already shifted to using chemo plus osimertinib in the frontline setting. In a patient who has a co-mutation, patients with brain metastases, patients with more bulky disease, moving forward with chemo plus osimertinib is sort of already how we're treating patients. I like the FLAME study because it helps us identify intensification strategies. My view is we're going to start doing FLORA2 and then use the FLAME approach to see what else we can do if, despite using chemo plus OC, you still have persistence of ctDNA. That'll be the question for the next wave of trials, and I think there are going to be some interesting combination approaches coming in that direction.
Thank you. Dr. Hassan, do you use prophylactic cranial irradiation or MRI in extensive stage small cell lung cancer who respond to treatment?
Right, yeah, I think, especially in the extensive stage setting, I think the role of PCI is very, very limited. I think, we are not curing these patients. Our focus is on quality of life. And there is a lot of cognitive impairment, associated with PCI. So I'm very cautious to offer it to any patients. Usually I would avoid it. I think the question is probably more relevant in the limited stage setting where you're still trying to cure patients. And there again, I think there is now, data is shifting, although we don't have a head-to-head comparison with frequent MRIs versus PCI. I think a lot of us are shifting towards more frequent imaging if it is accessible, and limiting the use of PCI. So I don't see much role now in the extensive stage setting in my practice.
And Professor Vas, what is your practice in limited stage as well as in extensive stage? Do you do PCI or not?
So I am of the same opinion, and that in limited stage we should consider PCI upfront, and in the extensive stage the quality of life is the major target. So it's preferable not to give PCI in those with the extensive stage of the disease.
Okay. Dr. Jamshed.
So thank you very much, Dr. Suresh, for the excellent talk. So we know that there is an evolving role of TROP2 directed ADC in EGFR mutant, and we did see the result of TROPION Lung-01 trial. So I would be interested in your thought. Do you think that in the EGFR mutated, that could be a potential target in the future? Thank you.
Thank you for the question. I think we are seeing some good results with TROP2-directed antibody-drug conjugates in phase 2 studies, specifically in the EGFR mutated population. Datopotamab deruxtecan is a drug that's available in the US, and I have used it in a number of patients. And we see response rates of about 40%. The median progression-free survival is approximately 7 months. Main issue tends to be toxicity. Stomatitis is a fairly common toxicity. Nearly 60–65% of the patients will develop some form of stomatitis. And there are things that can be done prophylactically, like steroid mouthwash. We ask patients to chew ice chips during the infusion to reduce mucosal exposure to the drug. And with those interventions and some dose reduction, we can continue to give these drugs in a way that most patients tolerate. There are phase 3 trials ongoing both in the frontline setting for EGFR mutated patients and in the post-TKI setting. And it'll be interesting to see these results. At this point, whether there can be biomarkers, looking at TROP2 expression that can help narrow down the patients who are likely to benefit is of interest, and there are some efforts underway in that. But I think overall, when you consider that after EGFR TKI and platinum-based chemotherapy, we do not have good options for patients, I believe that these antibody-drug conjugates against TROP2 could be a useful addition in the toolkit.
Thank you. Dr. Suresh, a couple of quick questions. EGFR mutant de novo metastatic adenocarcinoma lung, brain solitary lesion, asymptomatic, limited disease burden systemically. Would you choose FLORA or FLORA2 or Mariposa?
I tend to use FLORA2 as a compromise between both ends. Because of the brain mets, we know that chemo plus osimertinib has an added benefit there. We know there's a survival improvement. The Mariposa regimen is also effective. It does have some toxicities to contend with. So I end up choosing the chemo plus osimertinib approach.
Okay, and what about patient is asymptomatic, will wait for the response in the CNS, or would you go for SRRs if patient is asymptomatic?
For sub-centimeter asymptomatic, I would wait for the response to targeted therapy before I use local therapy.
Okay. And similarly, if I find a patient tomorrow morning with HER2 mutant, first line metastatic adenocarcinoma, and I don't have zigatinib, so should I give chemo or should I have access to TDXD? So TDXD or chemo, platinum-based chemo?
Well, it's a very timely question. I think there's going to be a randomized trial reported comparing TDXD to chemotherapy in the front line that we know from a press release is positive, and those data should be available, I believe, in the WCLC or ESMO meeting. So I think we're going towards an era where frontline HER2 targeted agents will become standard of care.
And secondly, if we find a stage 3 adenocarcinoma and turn out to be EGFR mutant, so it is resectable, but would you give Neodora approach? Would you recommend it right now, or should we go for resection if we can do it?
If they have N2 positive disease, I would go with the Neodora approach. I would give chemo plus osimertinib. If they don't have N2 disease, I think upfront surgery and then you can give adjuvant chemo followed by osimertinib.
Okay. So if there are no further questions, thank you very much to our expert panelists and Dr. Suresh Ramalingam. Is there anybody?
Yes. Hi. So quick question. So a patient who's been treated on FLAURA2 and he's progressed on chemotherapy and osimertinib, would you continue the backbone of osimertinib when you're changing the chemotherapy in second line? Or would you stop osimertinib even if the patient has repeat NGS shows that the patient has EGFR mutated mutation present?
Thank you. That's a timely question. I would say for a long time, for patients who have known CNS disease, we have tried to continue osimertinib even when systemic chemotherapy is changed and you're bringing in a new systemic therapy. At last ESMO, we saw the results of the COMPEL trial, which is a small 100-patient randomized phase 2 trial, where they showed that even in the absence of CNS disease, continuing osimertinib beyond progression and changing the systemic therapy around it, as opposed to instead of it, was beneficial. So I believe we have more evidence that there is EGFR dependence even at the time of progression, and continuing a TKI beyond progression has merit.
Thank you very much, Dr. Suresh Ramalingam and Dr. Hasan Shahryar. And with that, we conclude this session. Thank you very much. We really appreciate your time so early in the morning, and same is the case with Dr. Hasan Shahryar. Thank you very much, sir.
You're very welcome.
All right. Thank you. There were these two last electrifying sessions. The first one was with our future president, that we had sparks in the back. So the first electrifying session was with our future president, and the second one was Qasim Buttar. Both of them were excellent sessions. I thoroughly enjoyed them. The next session is going to be an update by Recon. Most of you know what RECON stands for, a Resident in Early Career Oncologist Network. Nawaz Niazi, who is a oncology resident at AKU, is going to come up and he's going to give a quick briefing and they've been doing around the year. They're going to have a workshop tomorrow in the morning. This session update is especially for supervisors and the residents to know what is going on and be part of this. Nawaz.
Good evening, everyone. I am Nawaz Niazi. I'm the General Secretary of RECON. Wow, it feels actually very special to be standing here again, because almost exactly 2 years ago, RECON was still an idea that we pitched to this community. 2 years later, whether or not we're wiser or not, you can debate on it, but we've certainly been a whole lot busier. So let me take you through what we've been doing over the past 1 year. For those who are joining us for the very first time, RECON stands for Residents in Early Career Oncology Network. We started off in August 2024 with a simple idea to make a platform that is specifically catering to the needs of oncology trainees and early career oncologists. The agenda is four-pronged: professional development, mentorship, research collaboration, and strong networking. We introduced that vision here. To actually put that vision into practical implication was the test. So last year when we returned to Best of ASCO, we introduced the RECON Oncothon. Rather than another lecture, the trainees worked together to identify real challenges in oncology training, develop solutions, and pitch those ideas. We had a sizable turnout, but more importantly, we saw people from different institutions coming together, collaborating, and that is exactly the kind of space we wanted RECON to create. So, then we moved on to Karachi. Alongside the sidelines of Oncology Research Symposium, we conducted another workshop, and this time this was a practical workshop focused on how to write, present, and communicate research effectively. Again, the emphasis is on practical skills rather than passive learning. So as the year progressed, we expanded our reach further, this time along the sidelines of Pakistan Bone Marrow Transplant Society meeting in Islamabad. And the third workshop was titled Building Bridges, Not Silos, and this was focused on professional networking. 3 cities, 3 national meetings, 3 workshops, but one simple, clear goal: professional development. So besides the workshop, we also wanted something longitudinal. So this led to the RECON Pathway program. The idea was to connect motivated medical students with mentors and research teams, and then actually follow through those projects, rather than ending the interaction after one session. So far, we're proud to have 20 students working across 11 projects. 6 abstracts have been accepted at various conferences, and one of them has won a Best Poster Award. For us, this is capacity building, which is translating into measurable output. So we continued building the bridges. We extended those bridges beyond Pakistan. RECON was formally invited to the ESMO National Young Oncologist Group meeting, joining representatives from more than 20 countries, and we were the only South Asian group at the table. Dr. Waqas Ahmed Khan represented RECON, shared our initiatives and challenges, and explored opportunities for greater engagement with ESMO. We were honored to have our dear friend Saad Nasir, who's also the founder and president of RECON, chair one of those young oncologists sessions. For us, moments such as these show us that a trainee-led initiative from Pakistan could genuinely have a seat at the international tables. So we also wanted the international collaboration to become routine, not something that happens only at conferences. This led to the Pakistan-Turkey RECON case rounds. We have now conducted 6 sessions with monthly case discussions involving trainees from both countries and faculty alternating as moderators. So the point is, difficult cases, different perspective, and sustained cross-border learning is what we've achieved so far. So we continued spreading the word of RECON and how we're making an impact. We were fortunate enough to be given a stage at the CPSP International Medical Education Conference, where we presented the RECON model within the medical education community. We were very fortunate and delighted to receive recognition from Dr. Kerry Baker of the Royal College of Physicians. Her kind words, they did serve as a major confidence boost to our efforts. We didn't stop there. We continued to explore new uncharted territories. RECON then reached the global stage at the annual Japanese Society of Medical Oncology meeting in Japan. The message is consistent and has remained same. You don't need a ton of resources to make professional development to promote it. You require structure, you require collaboration, and you require people who are willing to invest in one another. Somewhere along this journey, RECON's story became worth telling. We wrote to ASCO, and we were fortunate enough to be featured in ASCO Connection. Our writing titled Ripple Effect was featured in its pages. And we were also extremely delighted to have our dear friend Saad Nasser receive the prestigious ASCO International Development of Education Award. And this recognition is actually one more feather in the hat for Recon to keep doing what it is and to keep exploring new uncharted territories. And at the same time, at ASCO, we were not simply attending, we were presenting Recon's impact data. Our work was presented as a poster at the ASCO annual meeting. It was published in the Journal of Clinical Oncology, and Recon was featured by OncoDaily. The initiative we introduced on this stage in 2024 was now being discussed on one of oncology's largest global platforms. We're very proud to have to claim that our largest research training initiative so far was the Researchers Roadmap. It brought together more than 200 participants with structured research training, the course length spanning 23 hours with 4 national, 5 international faculty members, and having oncology colleagues join us from as far as Malaysia as well. For us, this is a demonstration of how far the Recon model can be scaled. So this brings us back to where we started. Tomorrow we have Recon Oncothon 2.0 again as part of Best of ASCO meeting. And conveniently, it is happening right here in the same hall. So my fellow residents, this year I couldn't find the venue, won't be an acceptable excuse. So please join us, don't be late, the registration starts at 7:45. Before I finish, I would like to say we believe that none of this belongs to one person, one group, one organization. We're very deeply thankful to all our Recon members, students, faculty, mentors who've come along and who've contributed to Recon's growth and who continue to offer us support. We're deeply grateful to Dr. Zeba, Dr. Najib, Dr. Yasmin, Dr. Munira, and all our faculty mentors. I particularly want to acknowledge Dr. Adnan Jabbar. Thank you for giving us that honest advice, for giving us that patient ear and the confidence to keep moving. I would say 2 years ago, we stood here and we claimed that this is what we hoped Recon could become. Today, we think we're beginning to see that vision take shape. And hopefully, next year when we stand here again, there will be even bigger stories to tell. Thank you very much.
Hear me now? All right. This is the part of the evening we all want to be here. Before that, since you guys have been really patient with us, we are going to have 3 lucky draws by 3 companies. The first is going to be by Firosans. We have 5 up-to-date subscriptions for the lucky people who are here. For that, I'm going to invite Mr. Tariq Arshad up on stage, who has been really patient. He started on Friday, and he's been here patiently with us and being part of Best of ASCO 2026. I would also like to invite Syed Mahmood, Senior Support Manager, and Furqan Ahmed, Senior Patient Support Manager, up on stage for the lucky draw. If we can come up here. The rule, as always, is you have to be in the room to win it. If you are not there, you lose it. Let's see. You got to pick 5. Can I have a mic? I'll read for you. Dr. Hafiz Umair, Genome. Dr. Hafiz from Genome. कोई बात नहीं. We need 5. Don't worry. मैं एक-एक करके बुलाता हूँ. The next one is Sarah Isaac for T8. All right. Sarah, you've been lucky. Dr. Zeba, what have you been feeding them? The third lucky person is Dr. Asma Saif, JPMC Karachi. Two more. Fourth person is Dr. Alicia Ilyas from Cancer Care Hospital. Do we have Alicia here? Unfortunately, she lost it. Yep, we need two more. All right. Oh my God. This person has also been lucky. Saba Ilahi. She was the sixth person to win the first day, and now again her name is called, but this time she's among the one who lost it. All right. Let's see. Ammara Khalid, Fauji Foundation Hospital. Do we have Ammara? No, ye nahi hai. Keep going, keep going. Dr. Zahid Khanzada, PKLI. Dr. Zahid, there you go. One last one. Dr. Muhammad bin Zafar from Dr. Muhammad bin Zafar. Is he here? Nope. Dr. Aisha Amir from Mayo Hospital. Dr. Aisha, all right, nope. Koi baat, koi baat. It's been a long day. Dr. Rifa Ramzan, Jinnah Hospital. Dr. Rifa, all these friends must tell them that they were not here. Especially people who have been. Where is she? Oh, there she is. All right. These were my lucky fives. I'm going to call out their names. You're going to keep this here. All five of you, please come up on stage. Dr. Hafiz Umair, Sara Isaac, Dr. Asim Kiran Saif, Dr. Zahid Khanzada, and Muhammad bin Zafar. Five of you are lucky winners of. Bache, sabko khada karte, just hold on to it. Yes, sir. You stand. There you go. Aap kahan ja rahe hain? Ah, please. Stand, stand, stand. Come, come, come. All right, everybody, all five, behind that, claim a position. There you go. थोड़ा सा आप बाहर को आ जाए, छोड़ दें, चलें, पकड़ो तुम में से एक. There you go. दूसरा तुम पकड़ो. There you go. All right. Thank you very much. Thank you very much. ये slips आप ले लीजिए. Please claim your thing. Take the box. Who is the next one? The next lucky draw is going to be by Pharmasol. Why don't you stay? There are actually three more. Dr. Vasif has left for the day, so I think you stay. So this one is by Pharmasol. Again, 3 up-to-date subscriptions. Ms. Sundas, Product Manager. Mr. Ishtiyaq Ahmed, Regional Business Manager. Please come up on stage. Ms. Sundas, there you go. 3. All right. Eamon Rabbani, Jinnah. There she is. Yep. Dr. Kainat Hamid Latif. Kainat is here. Do I see her? I don't see her. Oh, there she is. All right. Dr. Shavez Ali from Mid-City Hospital. Dr. Shavez. Nope. Dr. Safia Zafar, Pinam. Dr. Safia Zafar. Nope. Dr. Sidra Riaz, Life Hospital. Sidra Riaz. Dr. Muhammad Nawaz. Nawaz, Noreen. Where is Nawaz? He's not here. There he is. You are not Noreen. I'm sorry. You are Noreen. You are Nawaz Niazi. This is Muhammad Nawaz. Okay, sorry. Dr. Faryal Asghar in Mole. दो तीन निकाल लें. Dr. Iram Naeem, Mayo Hospital. Dr. Iram, please stand behind the thing. There you go. Sir, please come. और इधर हो जाएं, इधर और हो जाएं. Thank you. You all know society is always about education, education, education. So we're going to turn the gears. There are two more lucky draws. We're going to change that. Thank you very much. All right, we can remove this as well, please. Team, do we have all the seats? Wow. How many teams do we have? Can I please call upon two of my shoulders, Dr. Adiba Zaki, Dr. Tariq. Please come up on stage. Can we flip? Anas, there you go, thank you. Can we flip? 29 teams, come up on stage. Where's your mic? Can I have 2 mics, please? As always, we're going to start Jeopardy. I wasn't here last year, and I would really like to thank all the people who were with me during that difficult time, and your support really means a lot. You guys have been family. So I really appreciate that. Dr. Noman stepped in. I heard he did a good job. I was getting jealous. I was there online. I'm like, they have a replacement for me already. So this year, I sent him to Australia so that he doesn't do the same. All right, Dr. Tariq, you were all suited up. I'm sorry, मैं तारिक को कह रहा था इतना तो तुम वलीमे में भी तैयार नहीं हुए थे हैं? And then the electrifying event happened and we had to skip his presentation. While we are setting up, I'm going to just go through the rules. This is... Huh? You can speak up. Where's your mic? Here. This is Jeopardy. This was something that was conceived by myself and my 2 friends out here. We're going to have 3 sessions of oncology-related questions. We are really grateful to Himmel for supporting this plan. Before we start the Jeopardy, we would like to call upon Himmel to do the 2 remaining, lucky draws. Why don't you come up? Come. We were trying to do this for the longest time, and they've always been patient enough. I would send them back. Time is up. Go back. We're going to do it again. So, and I would also like to call upon all the teams with your partners. Usually these are residents who have to be within their 3 years of education. Once you graduate, you cannot. You are free to find a partner from another program. So please find a spot. We're going to have 3 sessions. In the first session, top 10 teams will qualify for the next round. In the second session, we have increased the number. Top 5 teams are going to qualify for the final round. And the final session, which will also have 30 numbers, the lucky winner couple is going to go and attend an international conference, all paid off. So that's always our biggest prize for the students. Last year, which PIMS won, right? PIMS. So PIMS was the team which had broken Shaukat Khanam's record in the past. Shaukat Khanam was having a streak, and then PIMS walked in and they took over. I know quite a few people here, they may be having PTSD of their previous experiences at Jeopardy. So I'll be keeping a sharp eye on those people. You want to come up, please? All right. So what are they getting? They are getting something really special, and that you always have something special for them. All right, Dr. Mahajibeen from Sinar. I did see her. Dr. Mahajibeen was there. She's not here now. You have to be here. Sorry, sir. Sorry, rules are rules. Sorry, sir. Rules are rules. I feel for her. I hope she feels better. Dr. Sikandar Munir, Jinnah Hospital. Dr. Sikandar. Do we have Dr. Sikandar here? No. Dr. Aisha Amna, Mayo Hospital. Dr. Aisha from Mayo Hospital. No? All right. Dr. Mariam from KTH? Huh? Dr. Mariam from KTH? Oh, abhi se दिमाग कहीं और है. All right. Dr. Mudassir from Mayo. सारे Mayo वालों ने एक साथ डाले थे हैं. Come, Dr. Mariam, come. We need one more. ये भी गिरा दिया तुमने. हाँ? One more. अच्छा तुम्हारी है. Okay, there you go. तो फिर आप गिफ्ट देंगे. आ जाइए. आपकी इंटर्न है तो. Congratulations. Thank you very much. Dr. Inbrat, Mayo Hospital? That's it, you have a, huh? Yeah, okay, there you go. That's an interesting name. You can come from this side as well. You don't have to come all the way. Come. Break the lines. You got to break the rules sometimes. This is one of them. And, okay, come. Stand here. All right. Anybody who needs to know what the rules are for Jeopardy, please raise your hand. And I'm talking to the 2 rows up here. I didn't break it. That's okay. Please. Thank you. Is my team ready? Are we ready? No, I'm sorry, if you don't have your partner, you lose him, a spot. You cannot start on your own. You got to have your partners here. It's time. Rules are rules. One thing that I need to incur in all my residents, they try to bypass rules. Unfortunately, you do not qualify if your partner is not there. Time was 6:30. Please take a step back. People who are already here, come together. My apologies. At this stage of your life, you've got to be there. Go and grab it. Okay, come on. What are the rules? Tariq, do you want to tell us the rules, please?
So the rules are very simple. We have 3 rounds. Each round has 30 questions. First 5 questions will be carrying no marks. They will be just to make you familiar with the process. And we will have 2 double pointers in each session. And the first 10 teams will move to the second round. Okay? Please choose your names, different names, so that 2 teams don't have the similar names. Okay?
All right. So we're going to be starting the first quick questions. This is just for testing. You have to log in. This is to check your internet. If your phones have any issues, raise your arm. We have my team members on left and right to help you out connecting. Remember, this round is just for testing. This is just to getting your hands wet. Quick fingers win. You may know the answer, but if you respond slow, you may not get the points. Adiba, are we ready? Introduction start kar do. We can start introduction. Please stand up, state your name. We have 2 mics so that it will be quicker. Tell your name, program, and your team name, please.
From Mayo Hospital, and my team is on COEX.
Assalamu alaikum. My name is Dr. Kamal Parvez. I am PG4 from Mayo Hospital, Lahore. My team is OncoX.
All right.
Assalamu alaikum. Dr. Ahmed Raza from Mayo Hospital, Lahore. I am a 3rd year resident, and our team name is OncoNexus.
Assalamu alaikum. My name is Dr. Fatma Shafiq. I am from Mayo Hospital, 4th year resident, and my team is OncoNexus.
Oh, hold on. How come? Don't you have any support? Where is Mayo Hospital? Can I have some, applause? All right. We need you here for your team. We don't want them to be just here representing you and no claps. Come on, next team, stand up. We want to hear.
Hello, my name is Dr. Danish. I am from Mayo Hospital, and my team name is Genomic Guardian.
Hello, my name is Mehek Khalid, Dr. Mehek Khalid. I'm a fourth-year resident, and our team name is the Genomic Guardians.
Assalamu alaikum. I'm Dr. Munir Ahmed. I'm year 1 resident at Aga Khan University Hospital, and we are team Sherdils.
Assalamu alaikum. I'm Nawaz. I'm a final year resident from Aga Khan, from the team Sherdils.
I think the team which gets the loudest applause should get a gift anyways, right? Can you turn on these lights? It's a little bit dark out here. Okay.
Dr. Abdul Basit, resident oncology, Mayo Hospital, and our team is DNA detectives.
Assalamu alaikum. My name is Dr. Imsat. I am PGR Medical Oncology from Mayo Hospital. My team name is DNA Detectives.
Assalamu alaikum everyone. My name is Dr. Dua Shah from Aga Khan Hospital, and my team name is the Titans.
Assalamu alaikum. My name is Dr. Maha Javed. I am a year 4 resident from Aga Khan, and my team is the Titans.
Hello everyone, my name is Alina Hafiz and I am from Aga Khan Hospital, and our team name is Coco Melons.
Assalamu alaikum everyone. My name is Dr. Sundus and I'm resident medical oncology, and we have the same team, Coco Melons.
All right, you're not going to be helping the team to your left, right? Same team.
Assalamu alaikum everyone. I am Dr. Amara Zafar from PNS Shifa Hospital. Our team name is Mutant Minds.
Assalamu alaikum. I am Dr. Taira, resident oncology, and our team name is Mutant Minds.
All right. So we have a very special moment. Since we didn't have a partner, what happened was I think he went and found a partner from another institute who didn't have a partner. And we all should give them a big hand of applause for having the spirit. Please state your name and institution.
Hello everyone, my name is Dr. Nakibullah, oncology resident R5 from Liaquat National Hospital.
And team name is?
OncoNexus.
All right, OncoNexus. And you are
I
from?
am Dr. Nahid Shakur from Jinnah Postgraduate Medical Center, Karachi. I am year 2 resident medical oncology.
All right, great. Good luck. You can come up front.
Assalamu alaikum. I'm Dr. Fauzi Iqbal from Mayo Hospital, resident final year, and our team name is CRISPR Crew.
Myself, Dr. Mozam Ali from Mayo Hospital, Lahore, and our team name is CRISPR Crew.
All right, we have a lot of representation from Mayo.
Assalamu alaikum everyone. My name is Dr. Myra Salim, and I'm a year 2 oncology resident at Dr. Ziauddin Hospital, and our team name is Malignancy Minds.
Assalamu alaikum. Dr. Mariam from Ziauddin Hospital.
Assalamu alaikum. My name is Dr. Aisha Stika. I'm third year medical resident, Jinnah Hospital, Lahore. My team name is OncoDu.
Jinnah, come on.
Assalamu alaikum. My name is Dr. Amara. I am from Jinnah Hospital, Lahore. My team name is OncoDu.
All right, yeah, please.
Assalamu alaikum. My name is Dr. Lubna. I'm fourth year resident from Jinnah Hospital, Lahore. My team name is Amigos.
Can we have another mic, please? Yeah.
I'm Dr. Amna Hussain from Jinnah Hospital, Lahore, and my team's name is Amigos JHL.
All right, please. Who was remaining?
Assalamu alaikum. My name is Dr. Durnayab. I'm a first year resident at KTH.
Team name?
Team Onco KTH.
Okay. You got to stand up, state your name. Come on. Nobody sits.
Assalamu alaikum everyone. My name is Dr. Suman Wahab and I'm a fourth year resident, and our team name is Team Onco KTH.
There you go.
Assalamu alaikum everyone. I'm Dr. Alina Nazar from Hamid Latif Hospital, and my team name is AK Warriors.
Assalamu
Pehla
alaikum.
what to yahi chala gaya.
I'm Dr. Kainal from Hamid Latif, and our team name is AK Warriors.
All right.
Assalamu alaikum everyone. My name is Kiran Shaheen. I am final year resident at Khyber Teaching Hospital. Our team name is Chemo Champion.
Assalamu alaikum. My name is Dr. Zaki. I'm a first year oncology resident, and our team name is Chemo Champions.
While we are going through introductions, Anas, can we make sure everybody is connected with their internet? Yes, please.
Ji, Assalamu alaikum. My name is Dr. Shadev Ahmed from Shaukat Khanam Hospital, third year fellow.
You
Our
guys
team
have
name is Team Baraka.
big shoes to fill in.
Dr. Faisal here, fellow medical oncology, SKM, same team.
Welcome.
Assalamu alaikum. My name is Dr. Asma Kiran Saif, and I'm from Karachi, JPMC.
All right. Well, JPMC, come on.
Assalamu alaikum. Assalamu alaikum. I'm Dr. Tuba Babar and I'm final year trainee of JPMC Medical Oncology. Acha, the name of our team is Healing Horizons. Healing Horizons.
Okay.
Ray of Hope.
Assalamu alaikum. My name is Dr. Mariam Nisar, currently doing residency in Jinnah Hospital, Lahore, and our team name is Carcinex.
Jinnah Lahore.
Assalamu alaikum. I'm Dr. Zishan Majid, resident medical oncology, Jinnah Hospital, Lahore, and we are Carcinexes.
All right, there you go. Here are our teams. Are you all ready? Are you all connected? Oh, this row is here. Give me 1 second. Are we connected? People who have introduced themselves, please make sure that you are all connected. Is there a specific internet that we are using? Jeopardy? All right. So please just let them know the passwords, right? Please go ahead.
Assalamu alaikum. My name is Dr. Mahnoor Chaudhary from Jinnah Hospital, Lahore. I'm a first-year trainee, and our team name is Metastatic Minds.
Metastatic minds. That's crazy.
Assalamu alaikum. My name is Dr. Hemant Rabbani. I'm resident Jinnah Hospital, Lahore. Our team name is Metastatic Minds.
Assalamu alaikum. My name is Dr. Bakhtawar Hasib. I'm a resident at Jinnah Hospital and our team's name is Risky Destiny.
Wow, risky.
Assalamu alaikum. Dr. Hatim Rashid, medical oncology resident from Jinnah Hospital, Lahore. Our team name is Risky Destiny.
Assalamu alaikum. Dr. Hamza from PIMS, second year resident. Our team name is Cytotoxic Minds.
Psychotoxamides.
Cytotoxic.
Assalamu alaikum. My name is Dr. Muhammad Ibrahim. I'm resident at PIMS Hospital. Our team name is Cytotoxic Mind.
All right, and the last team.
My name is Dr. Farzan Ali, Fellow Medical Oncology, Shaukat Khanam, Lahore. And our team name is MedStorm United.
There you go, MedStorm United.
Assalamu alaikum. My name is Dr. Umair. I am fellow Madong at Shaukat Khanam Hospital. Our team name is MedStorm United.
All right, let's give a big hand of applause for all the teams. Our numbers have been increasing every year. Everybody is connected to the internet. Raise your hands who is not. Are you all connected with the internet? Yes? All right. Simple ground rules. Anyone sitting beyond the second line does not get connected. Please do not get the passcode. Do not start answering. That's a simple thing. It's only going to interrupt. It's only going to make things a little difficult for us to manage. So enjoy it. Let's hear it for your team. But please do not use the code which you see over there. Anyone up here, there's going to be a code. You're going to sign in with your team name, and you're going to have a first round that does not have any marking. It is only for you to get used to it. Are we ready to start? Please raise your hand if you're not connected. All right, my own team is not connected. That's okay. Anyone else? All good? All right. There's only one team. I think we need to get started soon. Huh? Anas niche hai. Kahin hai. Anas, your hand. I need to see your hand. Yeah. Next, we're going to have Jeopardy T-shirts. Specific dedicated Jeopardy team. Acha, by raise of hands, do you guys want to read the question by yourself, or you want me to read it? If you don't want me to read it, raise your hands. All right, there are a few people who do not want. And who wants me to read it? Raise your hands. All right, very few, unfortunately, you lose. I am not going to read the question. It's going to just come on the screen. There are only 120 characters, so that you can read at your own pace, and I will not interrupt. All right? Are we ready, Tariq? All right. Yeah. There's another announcement. Please pick up that slide. I'm sorry. Apologies to Himil. I forgot about this. There is going to be a lucky draw tomorrow. This is going to be after your hematology session. Once again, you have to be here in order to win the prize. There are 3 grand prizes. The first prize is a laptop. Second prize is a mobile tab, and the third prize is LED TV 50 inches. If you have visited their booth, you're going to put your name over there, and you have to be present here after the hematology, which is the last session. Apologies to Himel, but this is something I forgot, so this is on me. We can take it away. Omar, are we ready? Yes. Nahi ho raha? Okay. Can somebody help Myra and kya hua? Ho gaya? All right. Are we ready? Let's begin. Huh? Flight mode kar lein. Yes, koi message nahi aayega. Everybody change your phone to flight mode. That will not interrupt, because if, let me say this. If for any reason you get disconnected, there is no way for me to get you back on. Your points gets lost, your connection gets lost, and there is no way for me to stop it. So make sure that your phones are on your flight mode. If you have any issues, raise your hands now. Once we get started, we won't be able to stop. Do not disturb is what you should do with your phone. And if anybody needs help how to do it, can you please come up and let them know? Okay, that's fine. Here. Do not disturb is what you should do with your phone so that you do not get disconnected. We have already taken 30 minutes, but that's okay. Can we please remove these from here, somebody? From the team? We don't need these here anymore. वो कर रहे हैं. So I must say, Adiba and Tariq puts a lot of sweat in here. We were up until 5 o'clock yesterday. We slept at 5:17. Of course, there were a lot of moments in between where we were, besides doing questions, also talking, and we sent a lot of people to Jannah as per the members who were sitting there, because of course we were gossiping. 23 teams made it instead of 29. 29 registered, 23 teams on board. Please, we need to get started, guys. Huh? Yes, that's what I'm saying, but we need to get started. All right, I want to hear from some of you guys why we are doing it. Why do you want to be an oncologist? Can I have a mic, please? I'm sorry to put you on the spot, but why oncology? Who is your role model? Quickly, I'll speak it loud for you. Go ahead. Mike, hello. My team, sleeping. Yes, Mike, 1, 2, 3. There you go, behind you. Yeah, why did you want to be?
Because I like this field. I like to do researches.
Okay. And anyone?
I want to work in a Shaukat Khanum hospital. That's why.
Who's your role model?
My senior, Dr. Manan.
Dr. Manan, nice to hear. Anyone else who wants to tell us a little bit about themselves, why they wanted to be an oncologist? Or just because they got a seat in oncology, that's why they got into it? May I know the last team in the corner? Why did you want to be an oncologist? And anyone do you aspire to be like?
Actually, during house job, oncology fascinated me a lot. So that's why I chose oncology. And when I joined oncology, Dr. Amjad Zafar, he became my role model. And
Ooh,
Dr.
Amjad Zafar.
And
Tough
Dr.
shoes to fill in, huh? He's a great guy.
Thank you.
I love him too. So, anyone else who wants to share his or her feelings? Yeah, there you go. That's what I like. Spirit to speak about themselves. Go ahead. Give them the mic. Saad, can you please help us out? We can remove the extra chairs. Please remove the extra chairs as well. Yes, please.
I want to do medical oncology because my father has renal cell carcinoma.
Sorry about that.
My role model is Dr. Neelam Siddiqui.
Oh, yes. A great lady, an iron lady. We all aspire to be like her. I wish I could be half what she was. Until her last day, she was doing her clinics. Until the last day, she was taking care of her patients, and that was only what she wanted to do. All right. So, that's your game pin. Log in. Mutant Minds were the first. I think you have to watch out for them because they were the quickest with the finger. Dior was next to follow. Let's see. We need the quick fingers, AK warriors, metastatic minds from here. Quick fingers. Mutant minds, Onconexus DNA detectives are there. Medstrom, genomic guards. I think Risky Destiny, Marisol. MGOS, GHL. Chris, I think there are a few spelling mistakes, but that's okay. That's how you're going to be recognized. Take a little sec to, get your names right. BRCA, Carcinexus. Yes, issues here, hands raised. Who is my IT people? Who all are my IT people? Can I see hands of my IT people, Anas? We need your two people here to help them out quickly. Bache, Umar, we need IT people here to help out. Nusrat, thank you guys. Can you please help out? Half an hour gone. They must be all hungry. We're taking it. You're going to log in with your team name. You're gonna, get out of there, log in again, log in with your team names. How many people have logged in? 5, 8, 11, 21. We are missing 2 teams. If you don't see your team name up there, can you please raise your hands? Whichever teams does not log in with the next minute already gets disqualified because I'm going to start at 7:05 sharp. Coco Melon. That's a nice name. Who is Coco Melon? Okay, Coco Melon. I thought you said something else. Did you change your name? Okay. All right. Coco Melon. Cosmic Guardian. No, Genomic Guards. Isn't it Guardians? What's the name? Cosmic what? Who is Genomic Guardians? Guardians or what? Guardians. We are missing an I. Okay. There's no I in a team, right? You are a team. There's no I in a team. That's okay. That's okay. So again, there's no I in a team. You guys are a team. All right, we're going to start in the next minute. Raise your hands if you don't have anything. Huh? We need this screen, guys, for what? Yeah, you have this thing. Speak in this. You are my... Speak in this. Okay, there you go. This. I think it's getting boring now, me speaking. We need to get the action started. All in? Do you see your team's name in there? If not, raise your hands. Are we ready, guys? Adiba, Tariq. Are you ready? Please. Adiba, you're going to be on the computer, or Tariq? Who's going to be on the computer? Adiba, you can be on the computer. You guys are not going to intervene. Both of you be here. Let me see. Whoever does not see your name, just raise your hand. Do you all see your name out there? All right. I'm going to speak up in the first session because this is without any numbers. This is for you to get used to it. We're going to start. There is no scoring for it, but it is just for you to get used to it. Let's get started, guys. Ab kya hua? Use the mic. Speak, speak, speak. Communicate.
So there are 28 teams. 28 teams have logged in.
Okay, 28 teams. I'm going to call out names. Which? There's mutant minds twice. One is mind and the other one is minds. What did you guys do? Which one do you want to minds? So we need to exit one of them. Mutant mind or mutant minds. Which one are you logged in right now? S. We need to get rid of minds. Yeah.
Mind or minds?
No, this is mind is which you will remove. Okay. No, not this one. Mutant minds is correct. ऊपर लेके जाओ थोड़ा सा. All right, everybody check their team's name. Scroll down slowly. All right, I'm going to start from the left. You're good? Thumbs up. I need thumbs up from each team. Thumbs up, thumbs up. Are you set? Ready, steady. Are you up? I'm not seeing any thumb. Thumbs up. Ears here. All right, thumbs up if you're ready to go. Thumbs up, thumbs up, thumbs up. Are you guys ready? Come on, wait nahi karne ki zarurat. Ha, there you go. All right, start. Whom did you do? Okay. Start, guys, start. All right, this is going to be just something to get you all. Fun quiz. 3, 2, 1, go. Question number 1. Who is the president of SMA for the year 2027? One is missing. Yeah, there you go. Answers. All right, 18 of you got it right. There are 6 teams who doesn't know who's going to be the president. Where's my president 2027? Do I see him around? Dr. Kamran, do I see your hand out there? I don't see him. All right. Next question, please. क्या तारिक और अदीबा को भी तारीफ के तौर पे टैबलेट मिलना चाहिए? ज़रूर मिलना चाहिए, ज़रूर मिलना चाहिए. तारिक की बातों पे मत आना. They deserve more than tablet. All right, whoever knows तारिक की बातों पे मत आना. All right, वैसे आपस की बात है, इसके लिए हमें शरीफ एंड अरशद इन दोनों से रब्ता करना पड़ेगा. Next question.
So 3 extra teams has been logged in.
Which 3 extra teams have been logged in? Guys, anyone from out there? बच्चे, what you do is you exit, you go through each. ठीक है ना? Doesn't matter. अभी next में देख लेंगे ना. अभी निकालते हैं. Let's go with the remaining 3 questions. Come on. All right. Well, we will go through that. किसकी जोड़ी इस दुनिया में बेहतरीन है? शाहरुख खान एंड कजोल, ब्रैड पिट एंड एंजेलिना, वकार एंड अनस, फवाद खान एंड मायरा खान. अरे इसमें भी भाई सिर्फ 17 समझते हैं कि एक ही जोड़ी है, बाकी और भी दूसरी हैं. नेक्स्ट क्वेश्चन प्लीज. The person preparing for a major upcoming Karachi Marathon for Cancer Awareness on 31st October 2026 is Noman Zahir, Nawaz Niazi, Mohammad Huzaifa, Mohammad Tariq. All right, for those of you who do not know, there's going to be a big marathon in Karachi on 31st. It's going to be a national event. We're going to have 2 more in Lahore and another one, but we're going to have one, so mark your calendars, 31st. That was Huzaifa, and 6 of you got it correct. Next one, the last one. I see Munira. Hey Munira, congratulations. Happy anniversary. Yeah, talking to you. Happy 25th anniversary. ये कौन सा महापुरुष इंसान है जो इफ्नॉस से बेस्ट ऑफ अमेरिका आए और टैबलेट लूट के चले गए? डॉक्टर हिदायत, डॉक्टर वकास, Naqibullah and Samad. Dr. Hidayat is correct. He was there to represent SMOP at IFNOS in Australia along with Dr. Numan and Dr. Yasmin. We had a session and we were asked to take part in that meeting. So thanks for going all the way and coming back to be part of the meeting. So this was a little dry run. We have 3 teams extra. We need to figure out. I'm going to call out names and you're going to raise your hand if that is your team. If not, that team is going to be eliminated. You guys, you okay with that? Tariq and Adiba. Read out the name. If someone doesn't claim it, remove it. All right. Let's see. Just get the names on. You know what? We can just do it. वो नहीं होंगे तो खुद ब खुद पता चलेगा. Just start. If you just start, those 3, if they're not here, it doesn't matter, right? All right, we're going to get started. Now, your numbers will be counted. There will be 30 questions, 20 seconds each. The top 10 teams are going to move on. I'm going to be silent between questions as requested. The quickest finger gets the point. There are going to be 2 questions with double points. It's going to be a surprise. Team will get the opportunity. If you are down below, can get up very quickly. Are we ready to start? What happened? Are we doing it again? Huh? Oh, yes. Okay, so now you all know what to do. You all know how to log in again. This is your new QR code. Each round has a new way of logging in. There were 25 teams, 2 extra teams. We don't want them to be there. Now you know they're not to add an S with your mind or minds. If you're not there, let us know. I'm not going to wait for too long. Starting for the left. If you're not there, raise your hand. I just want to see hands who is not on the board. Anyone who is not on the board, raise your hand. Are you on the board? Then raise your hand. Are you not on the board? Yeah, I want to see hands, and as soon as you see on your board, your hand should go down. Act as a team. 1 person from each team should raise your hand if you're not on the board. Hello, ladies. Are you on the board? Yes? Should raise your hand. If you're not on the board, all people here are good. Good. Do you see yourself? No? Have you logged in? All right. What's the name? CRISPR. Can we see if CRISPR is down below? Can you scroll down? Please. Thank you. CRISPR. We don't see. Why don't you do it again? The code is right there. If you have logged in, logged out, and log in again. What's your name? Chemo Gems? Titans? Which Titans? Okay, you're good. I heard something from there. Anybody else said something else?
One has logged in with the number 30922. Who is that?
Who is 30922? 30922. Please exit it. CRISPR crew is here. All right. That I don't see any raised hand. Everybody is in. Started. We don't need to count. It's their responsibility to raise hand if they do not see their name. Let's begin. All right. I don't see any raised hands. We are ready to go. Start, please. 30 questions. Here we go. Good luck to all of you. Let's hear it. Round 1. 3, 2, 1. Wasim Akram is the leading wicket taker. This does not have a point. It was just to get you guys going. Come on, next question. Go ahead, next question, guys. Doesn't matter. If 3 extra teams are not here, you know, come on, man. We are all educated doctors here. 3 teams are extra. What can I say? Leave them. Ethics. BRAF V600E is the correct answer. Go ahead, please. Next question. We're going to be a little quick. Connection lost? What? Okay, keep going, keep going. Nahi aa raha. Hold on, hold on, hold on, hold on. Anas, what's going on? What's going on, Nusrat? They all got disconnected. Who is not connected? Raise your hands. Who is not connected? All right, hold on. आप लोगों को नजर आ रहा है? डिले है. ओके, So, आपके कनेक्शन में प्रॉब्लम है. हमने इन लोगों को क्या कनेक्शन दिया है वकार? कौन सा कनेक्शन दिया है? Okay, see, we need to get started. I'm sorry, if you are connected with that, is it the same for everyone? There's a lag? There are only 2 teams who are saying there's a lag. 3 teams lag. Huh? Okay, that's fine. There will be a little issues. Let's see if they're all connected. पहले क्वेश्चन का कोई मार्क भी नहीं था, इसीलिए ऐड किया है. Okay? All right. Are we ready to go? All right, let's begin. 1000 points you can make up. That's not a big deal. Okay, Sherdils are up with 1902. Deletion 7 is the correct answer. This is something that we were told in our first year. Next question, please. Cocomelon have taken over. Next question, please. That's okay. What's wrong with the connection, guys? Nusrat. Anas. हाँ? आपके इंटरनेट की प्रॉब्लम आ रही है. I know आप सबके इंटरनेट की प्रॉब्लम आ रही है. We're going to start again, but we are going to start from question number whatever that was. क्या? Let me find out. Guys, come on यार. हाँ? नहीं इसका नहीं है, लेकिन पुराने में किसी ने भी इसका आंसर नहीं दिया है ना. That's fine. You know, what's going on, man? नहीं आप लोगों से नहीं पूछ रहा. All right. जब पूछता हूँ तो जवाब नहीं देते, जब नहीं पूछ रहे तो फिर फौरन जवाब देते. My team, what is going on? I need an answer. Guys, don't talk amongst yourself. I need an answer. Guys, I'm talking to you guys. I need an answer. क्या हो रहा है? क्यों हुआ है? तुम लोग अपने नेट का वो चेंज करो ना, जो तुम लोगों ने इनको नेट दिया है वो वो दिया था, हाँ? लास्ट टाइम हमने डेडिकेटेड लाइन दी थी ना इसके लिए, सो फिर अभी क्या है? कॉल द निशात पीपल, हाँ? सो देन व्हाट इज गोइंग ऑन? अच्छा जी, अब कौन बताएगा अपने बारे में? एक माइक तो दो, मैं नीचे उतर जाता हूँ, बहुत देर लगती है माइक को लाने में। हाँ जी, वैसे भी मैंने कुछ बोलना तो है नहीं। We're going to start all over again. All those points will be taken away. माइक का क्या करना है? मुझे पता है, तुम लोग सो रहे होते ना, तो इसलिए मुझे माइक चाहिए। हाँ जी, क्या है? You guys are good? You guys are good? We're going to start again. Everybody is good again? Okay. अब रुका तो मैं दोबारा नहीं करूँगा। Okay? सारे पुराने पॉइंट्स गए। All right? चलो, let's, हाँ? तीन चार नहीं करना है, एक बार करना है। ओके गाइस, स्टार्ट विद द फर्स्ट क्विज। इसको खत्म कर दो। ये कौन सा क्वेश्चन था? क्वेश्चन नंबर 4 था ना? सो वी आर गोना स्टार्ट। जब पूछो तो जवाब नहीं। ओके, यस। Let's start with the first 5 again and check same Wi-Fi or not. All right. Let's start. Cancel it. Exit. Start all over again. 1 घंटा तो हो गया बॉस। 1 घंटा तो इसी में निकल गया। No sir. Can somebody ping and see what is the bandwidth? All right, let's see. Tell me something about yourself. We heard your name, go ahead. That's okay, nothing to be stressed about.
It's not working, I think.
Yes, go ahead.
Yeah, my name is Danish. I'm a resident of oncology from Mayo Hospital.
We know that. Tell me something else.
Something like what do I do in free time or something?
Yes, why not?
Yeah, I'm a kickboxing player.
Okay.
Yeah, MMA fighter.
So did you get the first question right, Wasim Akhtar?
Yeah, I did.
All right, good, very good. Yes, you know that I'm buying time while you guys are trying to get your act together, right? Haji, you want to tell me something about yourself? Why oncology? And why Jeopardy? You guys will give me a signal when you are ready.
Because it's challenging.
Hmm?
Because it's challenging.
Because it is challenging and you like challenges. All right, can you share some challenge that you have shared and overcome? No? So it was the biggest challenge right now to tell me something about yourself, wasn't it? And I thought you love challenges, right? हाँ जी, अब बोलिए। जब बोल रहे थे बताइए क्या करते हैं हम फारिग वक्त में? सेट हो गए? अच्छा अभी क्या इनको नहीं डिस्टर्ब करते। यहाँ से कौन बोलेगा? Anyone? 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 आप लोग सेट हो? All set? आप बता चुके हैं। हाँ अब बताएं, बहुत अब बोलिए। सेट हैं? इंटरनेट सेट है? नहीं फिर अब तो आप आउट होंगे। अब मसला हुआ जिस टीम का तो वो आउट है। All right. बस अब तो इसी में करना है। Come on, 5 सवाल अगेन करो। Everybody is logged in? 5 सवाल अगेन। 1 मिनट रह गया। ठहर जाओ। क्या हुआ बच्चों? 2 बार हम ऑलरेडी कर चुके हैं। तुबा क्या हो रहा है कि कौन सी टीम है? ऐसा क्यों हो रहा है? पहले ऐसे क्यों हुआ? बस ऐसे ही है। पाकिस्तान में हो। कौन से सेंटर से हो? JPMC वेयर? कराची? भाई कहाँ है हमारी जेब? हाँ मुझे पता है शुमाइला। वेर इज शू? शुमाइला ऐसा क्यों हो रहा है? उसको पता ही नहीं है मैं क्या बात कर रहा हूँ है। आई एम वेटिंग फॉर अ सिग्नल फ्रॉम अनस। अच्छा जी, हाँ, यू गाइज आर रेडी? यू आर रेडी? टेल अस समथिंग मोर। पता है ना हम वक्त गुजार रहे हैं, इतने सारे लोग आपका इंतज़ार कर रहे हैं, थोड़ा कुछ उनको महसूस कीजिए ना। अब मैं फ़ाद मुस्तफ़ा तो हूँ नहीं कि मैं जो है फिर करूँ, तो थोड़ा सा बताओ ना कुछ भी। फिर मैं गाना कह दूंगा गाना गा दो।
नहीं सर, फिर सब बाहर चले जाएंगे। अगर मैं गाना गाने लगूंगा तो सब बाहर चले जाएंगे।
तो इसीलिए तो कह रहा हूँ नहीं गाओ, कुछ और बताओ।
ठीक है सर, बस अभी थोड़ा सा टेंशन में है, स्ट्रेस है।
टेंशन में, ओके चलो, आई लेट यू बी। इनका नहीं चल रहा। पिन बता दो भाई, एक बार फिर पिन बता दो। क्या है पिन मेरी जान? 784 लाउडर।
784,559.
784,559. 784,559। बच्चों को बहुत टेंशन में डाल दिया, आप सुपरवाइजर्स को टेंशन में डालते हैं। जी सर, कुछ भी बताइए। हाँ, आपके इतने होनहार बच्चे बैठे हुए हैं, उनके बारे में कुछ कहना चाहेंगे आप? वेरी होपफुल।
आज हाँ, एक बात रह गई।
हाँ हाँ,
आज मेरे 4 बच्चों के इनाम निकले,
हाँ,
वो
हाँ।
चारों यहाँ पे नहीं थे, वो मुझे दे दें।
भाई काश ऐसा होता, मेरे भी 4 निकलते। हाँ जी, आपका जवाब यहाँ से आ रहा था, तो माइक मैं कहता हूँ यहीं दे देते हैं।
बेस्ट ऑफ लक हमारी टीम्स के लिए।
आपकी टीम कौन सी है?
4 टीम्स है सर, 4 टीम्स।
आपकी 4 टीम है। आप 4 टीम में आपकी कौन सी, 5 टीम में कौन सी पसंदीदा टीम है आपकी?
सारे पसंदीदा।
सारी पसंदीदा है। तो आवाज़ तो आ नहीं रही थी जब लेट्स हियर फॉर योर टीम। अच्छा, ये वही टीम है जो कहती है हमारा नहीं लगा, फिर तो मसला है यहाँ, मसला है। हाँ जी, कम ऑन, कनेक्ट हो गया? अरे वाह भाई, क्या बात है। इससे पहले वरना मेरे अब जो है ना वो पेटी निकल जाएगी। कम ऑन। कौन रह गया? आप रह गए, ओके। हाँ बच्चे, तो आप डबल होंगे। आपका क्या नाम है इसमें? हाँ, Amigos. Do you see Amigos there twice?
No, sir. No, sir.
Amigos is not there?
No, sir.
Amigos नहीं है यार। ये कनेक्शन इस बार कुछ मज़ा नहीं आया, मेरी टीम स्लो हो गई है जी। Amigos आप लॉग आउट करो, लॉग इन करो, सारा मज़ा ख़त्म हो गया है, 1 घंटा हो गया है। You guys have lost connections. भाई I am losing connection. Mind to tongue, क्या करना है? उसको बुलाया आईटी को, तो यार कोई बोले तो सही ना। Who's gonna? Somebody has to stand and talk. अच्छा जी, all right. कनेक्शन मुनक़ता हो गया था, एक बार फिर कनेक्शन वापस आ गया है। हो गया है, हम स्टार्ट करें? ओके, 1 more second. PTSD guy reconnecting. You are in. Come on, he's in. Come on, let's do it. शुरू के 5 कर रहे हैं हम अगेन। हाँ, फन कर रहे हैं ताकि अभी पता चल जाए, फिर बाद में ये होगा डॉक्टर अदनान ने हमें निकाल दिया। ओके, ये फाइनल रन है, इसके बाद वी विल नॉट गिव यू अ चांस। इसका टाइम कम कर देते ना, 20 सेकेंड से कम कर देते ना। ठीक है, नेक्स्ट क्वेश्चन, जल्दी करो। एनी इश्यूज? नो इश्यूज। इसमें नहीं होंगे, जैसे ही शुरू करूंगा सारे इशू शुरू हो जाएंगे। कम ऑन, इसके तो जवाब भी आने चाहिए 100%। लेट्स सी हैं। नेक्स्ट, सब चल रहे? ऑलराइट, अगर सब चल रहे तो एग्जिट कर दो और दूसरे पे चले जाओ। ऑलराइट, हाँ लेट्स स्टार्ट। क्या हुआ? किसका हाथ आया? किसका इशू आ रहा है? बच्चे ऑल सेट हैं, ऑल सेट है। देयर इज इंटरनेट इशू, देयर इज एन इंटरनेट इशू। यस सर, हम अब आपसे नाम पूछते हैं। आपका नाम क्या है? आप बताइए आपकी पोजीशन क्या है? जरा इनको टेंशन में डालें ना, अभी तक तो बच्चे टेंशन में थे। जी सर, क्या बताना चाहेंगे आप इसके बारे में? इंटरनेट क्यों नहीं चल रहा? ज़्यादा टेंशन में आ गए तो मेरी मुश्किल होगी। वेल, कंग्रेचुलेशंस। कुछ कहना चाहेंगी आप फॉर योर टीम? 25 साल। उसको सॉरी करूँ, आपको सॉरी करूँ?
कोई बात नहीं ना, अब जो हो गया वो हो गया।
ऑलराइट,
थैंक यू, वेलकम एवरीबॉडी।
थैंक यू वेरी मच। अपनी टीम के बारे में कुछ कहना चाहेंगे? मैंने एनिवर्सरी का नहीं पूछा।
गुड लक एवरीवन। और अपनी टीम के लिए ये कहूँगी कि इट्स गुड दैट पार्टनर मिल गया, वरना मुश्किल हो जाता है।
पार्टनर मिल गया, देखो भाई पार्टनर कैसा मिला। हाँ, हो गया। चलिए मुझे बताएंगे, अभी मैं नहीं देखता। ओहो, हमारे आउटगोइंग प्रेसिडेंट कुछ कहना चाहेंगे। ओ, शरीफ साहब भी बैठे हैं, शरीफ साहब से भी कुछ कहेंगे। जी बोलिए।
मेरे ख्याल में ऑस्ट्रेलिया से साजिश की गई है।
ऑस्ट्रेलिया से साजिश की गई है
आपका तख्ता उलटने के लिए।
हाँ जी, बहुत से लोग शरीफ साहब को शायद वैसे नहीं जानते जैसे हम जानते हैं। जी शरीफ साहब, हम आपको ढूंढ रहे थे। ये डब्बा आपने यहाँ क्यों रखा हुआ है? हिमेल को पैरों के नीचे क्यों रोन रहे हैं आप? अपना तारुफ कराइए।
मेरा नाम शरीफ सज्जाद है और मैं हिमल फार्मास्यूटिकल का चीफ एग्जीक्यूटिव हूँ। और अदनान साहब की कंपेयरिंग देख के आज मैं ये कह रहा था कि इनको तो बाकायदा होस्ट होना चाहिए।
अच्छा जी, आज ये तो बताएं, वो जो उन्होंने मेरे दो लोगों ने सवाल पूछा था कि मिलना चाहिए या नहीं मिलना चाहिए?
मिलना चाहिए, जरूर
मिलना चाहिए। देख लो भाई, ये दो लोग यहाँ से जवाब आया है मेरे दोनों, मिलना चाहिए। इनसे रब्ता करना। हाँ जी, आर वी रेडी? आर वी रेडी? नो, वी आर नॉट रेडी। अब तो आई एम रनिंग आउट ऑफ ऑप्शंस। किसको टारगेट करूं? अस्सलाम वालेकुम रईस साहब, कैसे हैं आप?
अल्लाह का शुक्र।
आपका हज कैसा रहा? हज के बाद एक और विजिट हुआ था, सारे 900 पूरे हो गए हैं। कैन यू टेल अस समथिंग अबाउट योर हज एक्सपीरियंस?
सर बस अल्फाजों में बयान नहीं कर सकता। अल्हम्दुलिल्लाह बहुत अल्लाह ताला ने आसानियाँ की और जो इमेजिन कर सकते हैं।
अल्लाह मियाँ आपका हज कबूल करे, आपकी तमाम दुआएं ख़ास तौर से जो आपने मेरे लिए की वो पूरी हों और दूसरी दुआएं भी पूरी हों।
थैंक यू।
ऑलराइट, हाँ जी। अच्छा, दे यू गो, हम आपका नाम निकला। आप देखा, झूठ वहीं पकड़ा गया। एक ने बोला तबीयत ख़राब है, दूसरे ने बोला नमाज पढ़ने गए थे। बस अब तो निकल गई हैं, अब तो निकल गई।
सर, आई एम डॉक्टर जमीला शुजा।
डॉक्टर जमीला शुजा, हाउ आर यू?
फाइन सर।
हाँ।
डायरेक्टर सीनार हॉस्पिटल कोयटा। आई एम द फर्स्ट फीमेल ऑन्कोलॉजिस्ट ऑफ बलूचिस्तान।
माशाअल्लाह, फर्स्ट फीमेल ऑन्कोलॉजिस्ट ऑफ पाकिस्तान।
ऑफ बलूचिस्तान।
यस सर। वो भी पाकिस्तान ही है ना हमारे?
जी। And I am working as radiation oncologist from 2007 in Balochistan, and my mentor is Dr. Misbah Masood. I salute her, sir.
Dr. Misbah Masood, a big hand of applause.
Thank you, sir.
हर बार एक शख्स से मिलने के बाद मैं अपनी टीम की तरफ देखता हूँ और मायूसी के साथ आगे बढ़ जाता हूँ, ये देखने के लिए कि अगला शिकार कौन है मेरा। और फिर मुझे डॉक्टर अजहर शफ़ी मिल गए जो खामोशी से DHA प्रॉपर्टीज़ पे जोर वो करे। जी डॉक्टर अजहर, कैसे हैं आप?
जी, अस्सलाम वालेकुम।
वालेकुम अस्सलाम। बेस्ट ऑफ ASCO 2026 क्या कहेंगे आप?
आई थिंक इट्स गोइंग वेरी वेल और प्रॉब्ली वन ऑफ द मोस्ट अटेंडेड मीटिंग है और जिसमें अभी तक पीपल हैव शोन ग्रेट इंटरेस्ट। थैंक यू सर।
बहुत सारी टीमें हैं, आप किसको रूट कर रहे हैं? आपकी टीम नहीं देखी मैंने यहाँ।
इन दैट केस आई विल सपोर्ट एवरीवन।
नहीं, ऐसा नहीं होता, ये तो बहुत ही आसान है। यू सपोर्ट एवरीवन है, एक टीम को चूज करनी पड़ेगी।
आई डोंट सी इट
नाम अभी तो BRCA सबसे ऊपर टॉप है। वैसे रिस्की डेस्टिनी भी बुरी नहीं है। रिस्की लाइफ,
रिस्की डेस्टिनी,
रिस्की डेस्टिनी। ऑलराइट, लेट्स हियर इट फॉर रिस्की डेस्टिनी। Yes, Wakar, I need a thumbs up from you guys. Okay, all right. कहाँ चलें? किसी को अपने पास बुलाना है तो वैसे ही बुला लें। बहुत से लोगों को मैं जानता नहीं हूँ ना, इसलिए मैं थोड़ा सा डरता हूँ कि शायद वो ये कहें कि भाई मैं कौन, आप कौन, इन्होंने फंसाया है, पहले इनको फंसाएंगे फिर आपको फंसाएंगे। जी अपना तारुफ कराइए।
My name is Isha Khan and I am from FMH, final year MBBS student.
The final year, oh very nice. We have aspiring oncologists there. What brought you to oncology meeting? बहुत आसान होते हैं ना दूसरे की तरफ हाथ बढ़ाना, अब खुद फंस गए, बताइए। कुछ भी बोल दीजिए।
तो बस रिसर्च ये अटेंड करने आए थे।
That's good. आपके साथ और कौन कौन आया है? माइक में बोलिए।
ये सब,
ये सारे कौन हैं?
ये मेरे क्लासमेट्स हैं और ये हमारे सीनियर हैं।
देखो भाई, मैं हूँ, ये मेरी टीम है और यहाँ पार्टी हो रही है। थैंक यू वेरी मच। वेलकम टू बी हियर मेडिकल स्टूडेंट्स। आप कहाँ जा रही हैं? ओके, आपकी टीम की पार्टी हो रही है। अरे भाई, हाँ, जब शक्ल जानी पहचानी मिल जाए तो फिर जाहिर है थोड़ी बात तो होती है। हाँ जी, अस्सलाम वालेकुम।
वालेकुम सलाम।
कैसे हैं आप?
जी ठीक ठाक सर।
ठीक हैं। और क्या खबर है?
बस सर फर्स्ट क्लास चल रहा है, इसमें सारे ऑडियंस बैठी हुई हैं, सबकी एक्टिव पार्टिसिपेशन।
आप कहाँ जा रहे हैं? जेपीएमसी कहाँ जा रहे हैं? हाँ, देखा जाए भी आपको मौका मिलेगा, पहले इनको बोलने दीजिए। बताइए। हाँ
जी सर, बड़ी अच्छी पार्टिसिपेशन है। 8 बजे से लेके अभी तक सारे लोग आपकी वजह से इंटरेस्ट से सुन रहे, देख रहे हैं।
बेचारी जबरदस्ती में बैठे हुए, नहीं तो
सबको घूमने जाना है। स्टॉल बंद करके आए देखने।
चलो भाई, यहाँ पे दुकानें बंद होके फिर ये आए। थैंक यू वेरी मच, वी डू अप्रिशिएट। हमें यही चाहिए जिसकी वजह से हम आप लोगों को यहाँ पे सुबह 5 बजे सोने के बाद शाम के 7:30 बजे तक है। इट विल हैपन, बी पॉजिटिव, होगा।
वरना मैं कह रही थी कि कंपैशनेट बेसिस पे जेपीएमसी को आप दे दें बस फर्स्ट प्राइज।
नहीं तो क्यों जेपीएमसी मजलूम क्यों है?
मजलूम नहीं है
तो आप कंपैशन तो मजलूम के साथ
वैसे दे दें, मतलब
क्या दे दें?
फर्स्ट
प्राइज दे दें। जेपीएमसी को जरूर देंगे। आपकी टीम माशाल्लाह बहुत स्ट्रांग लग रही है। आप जा कहाँ नहीं है? अच्छा, आ रही है। तो यहाँ से कुछ कहना जाएगा? हाँ जी, जब मैंने कहा था कि लकी ड्रॉ नहीं होगा तो किसी ने मुझे ऐसे देखा कि जैसे मैंने उनका टाइम खा लिया।
नहीं सर।
जी सर, बताइए। बताइए हैं नईम साहब, क्या हुआ था? चले, कोई बात नहीं, होता है। बड़े बड़े शहरों में छोटी छोटी बातें हो ही जाती हैं। यार अब मैं बोर हो गया हूँ, और इससे पहले कि लोग मुझे निकालें, आई एम सॉरी, हमारा तारुफ नहीं हुआ।
My name is Dr. Zahir Chirag, and Himal has gone a step forward. Now we have a new company, Himal Medical Technologies. I'm leading that company and will be dealing in medical equipments and devices. So for now, I am leading, by profession, I am a nuclear medicine physician. And now I have turned to the commercial side.
Well, welcome. And thank you very much. Have a seat. And जोड़ियों में 2 जोड़ी, एक जोड़ी तो यहाँ भी बैठी है। All right. एहसन साहब, कैसे हैं आप?
बिल्कुल ठीक।
क्या खबर?
बस thrilled to know who the winner is gonna be.
बोर तो नहीं हुए?
अभी तक तो नहीं।
अभी तक तो नहीं। चलो गुड। मैं शादी के हवाले से कह रहा था
ना,
यहाँ के हवाले से नहीं। ओह, द लकी पर्सन 2 प्राइजेस जीती भाई, 1 नहीं 2। हाँ जी, क्या बात है?
सर अल्लाह का शुक्र है, बस अल्लाह का करम है।
अल्लाह मियाँ नजर ना लगाए।
और अभी के लिए शेर है एक, बांध लिया है सामान, अब बताओ मोहसिन, वो कहाँ रहते हैं जो कहीं के नहीं रहते।
क्या बात है जी, हिडन टैलेंट है जी। ये अभी आमद हुई थी या ये हमेशा से ऐसे? अच्छा जी, 2 मिनट। कानों में जब आवाज़ आए वकार की तो समझो काम हो गया है। डॉक्टर ज़ेबा ने मुझे यही सिखाया। हाँ, no, we are not going to eat. I know you are hungry. Munira is, when she's hungry, she's like a camel. She doesn't eat, and when she needs to eat, then she needs to eat. हाँ जी, we are ready now. All right, guys, let's start. बिस्मिल्लाहिर्रहमानिर्रहीम। अल्लाह के नाम से शुरू नहीं किया था, इसलिए इतने हिकअप्स थे। All yours, हाँ? ओके, 2 क्वेश्चन। यार ये आपका माइक है, यू आर इन चार्ज, प्लीज माइक में बोलिए ताकि थोड़ा मुझे भी ब्रेक मिले।
Two questions from fun quiz and then we start, okay? Just check your connections first, one last time.
अभी भी 4 लोग हुज़ैफा को नहीं जानते। हुज़ैफा है कहाँ भाई? हुज़ैफा क्या किया है तुमने ऐसा? क्या वो अभी भी प्रॉब्लम आ रही है? स्किप करके निकाल दिया 5। हाँ जी, हो गया। ये तो तुमने पहले भी बोला था। क्या नाम है? मामू कहेगा, चाचा कहेगा, क्या हुआ? हो गया? अच्छा जी, पहले 4 निकाल देना। विल स्टार्ट, उनको डिलीट कर दो ना 4 को। पहले राउंड के पहले 4 निकाल दो। फिर नहीं कर सकते, नहीं तो फिर अच्छा ठीक है। अब जब आपको पता है तो लेट्स सी हु इज़ द क्विक फिंगर। लेट्स सी, पहले 4 सवालों के जवाब आपको पता थे। नाउ यू न्यू कोड, नया नंबर, नई जिंदगी। अब मत कहिएगा कि नहीं हुआ। ये हैं भाई हुज़ैफा, जिनको अभी भी लोग नहीं जानते। कितनी प्रैक्टिस कर ली? कितने किलोमीटर्स? क्या कर रहे हो 31 को? हाफ मैराथन। मैं फुल कर रहा हूँ, तुम हाफ कर रहे हो। मैं गाड़ी में बैठूंगा, फुल मैराथन। 23 टीम्स ऑन। 3, 6, 7, 8, 9, 10।
One team remaining.
Who is missing? Anyone who cannot see their name, please raise your hand. Had to be Niazi. 804. भाई फुल बैंडविड्थ के बावजूद एक टीम घूम रही है। पहले ही उसको PTSD हुआ था। खून तो अच्छा ले लेते। सारी दुनिया में घूम रहे हो और रिकॉन के नाम पे, फोन चल नहीं रहा तुम्हारा। हाँ 17 है भाई, इसका फोन क्यों नहीं चल रहा भाई? इसको मैं लैंड कर दूँ अपना, लेकिन बेकार सा है भैया। वो 17 है, ये 16 है। हाँ फिर कहेंगे तुमने चीटिंग की है, बॉस ने अपना फोन दे दिया था। हाँ अब निकला ना, मुनीर साहब छुपा के बैठे हुए थे अपना। जल्दी जल्दी जल्दी, आई वॉन्ट यू गाइस टू बी क्विक मैन।
स्टार्ट करें?
बिस्मिल्लाह। योर लक। पहले 4 के जवाब आप जानते हैं, लेकिन हम एवरीबडी इज ऑन द सेम बोट। We'll be going through very quickly. 3, 2, 1, 0. Begin this. Mutant minds. Fastest. Next, please. VRAP, V6. Cytotoxic minds. Next, please. appreciated. Next, please. Deletion 7. All right, new questions coming up. Met Strom took advantage of these 4 questions. I think we got this one as well. That was fast. Who took the advantage? Mutant minds. Huge large B-cell lymphoma. Team guys will be happy. Oh wow, jump up 7 places. Interactive. I'm not going to talk, we are behind time. Share deals are catching up. SPRT is correct. BRCA moves up. That was fast. There is no negative marking. If you're going to be late, you're going to lose the point. Double points. Homologous recombination repair is the correct answer. For double points, let's see who went up. The team which jumped up is Sherdils again. Sherdil is, who is Sherdil? Raise up. Oh, okay. The Niyazis. 7 more questions left. Sherdil is our leading.
Last two questions.
All right, we're done with the first round. Let's see who the top 10 teams are. We'll only see 5 up here. On number 3 is Titans. Please rise as your name come up. Titans, Onco Pro Max, and Sherdil, I suppose. Please rise, whoever, the top 3 teams. Come on, who is Onco Pro Max? All right, good. There are 7 more teams. Just give us some time. We're going to work those other 7 teams. Please have a seat. You can sit down, please. Thank you very much. At least no PTSD this time. All right. So, in order to increase interest, we will take top 10 teams. These 3 teams are already going to be there. Anas is going to help us find out which the remaining 7 teams are. I would like everybody to give a big hand of applause to all the 23 teams that are up here. Really enthusiastic about having fun and learning at the same time. 23,000, 21,000. That was a close one between Onco Pro Max and Titans. I think there was. All right, here are the remaining teams. Please, the 10 teams that I'm going to call upon can rise once again. Sherdil with 84%, Onco Pro Max 84%, Titans 77, Braca, Coco Melon, Risky Destiny, Cytotoxic Mind, Mutant Minds, Carcinexus, and CRISPR Crew. These are the teams that are going to move on. No, keep standing. Take one step forward. Remain there. We're going to put you back together. Just come forward. Rest of the teams, best of luck. Apologies. But again, you guys have been great fun. Thank you so much for participating. Better luck next time. All right, we can take the remaining seats away from here. If you are comfortable where you are, you can stay there. Be seated, but I want more room between. If you are more comfortable, किसी का बैग वहाँ रह गया. अगर तो उसमें अच्छी चीज़ है तो फिर तो फायदा है आपका बैग. आपस में एक कुर्सी की जगह छोड़ें, please. Teams, can you move one chair? I need room between, just one chair, is it? That's fine, that's fine. Okay, good. Can you two move a little bit to the left? There you go. I need one chair difference between each team. All right. इधर बैठ जाएं, बाकी chairs हटा दें बीच से. Thank you, Saad, for helping out. We are going to move on. We are late. I'm not going to talk too much. We're going to quickly move on to the second round. Once again, there are going to be 30 points. This is your code. Log in with the code. 30 questions again. 5 teams will move on for a chance to have a trip for an international symposium abroad. All right, are we all ready? If you do not see your team name up there, please raise your hand. If you do not see your team name up there, please raise your hand. Thank you. Only one person from each team can do that.
We are ready. Proceed.
We are ready.
Yes.
Are you guys ready for the next round? This, once again. All right, let's begin round 2. Tariq, please. सामने से हट जाइए प्लीज, तस्वीरों के लिए सामने ना आए. All 10 teams got it right. Cytotoxic mind went up. For double points. Venetoclax and dexamethasone is the correct answer. Raka comes up, Sherdil holds on to their lead. Everybody was so quick on that. Cocomelon with the lead. Last 4 questions. That was a quick one. Last question coming up of this round. Top 5 teams move on. Keep going, keep going. They're gone? That's okay, one last question. Keep moving. Round number 2, Titans in 3rd place. Number 2, BRCA, Braca. And on the top, we have Cocomelon. It seemed like Cocomelon was the only team that had some support coming from here. All right, there was a little support here as well. Since I was quiet, many people thought something was going on. I was quiet because I was saving time. All right, there was a little issue where Shaydil, who have been leading all this time, had an issue with that. You don't need to worry, you're still top 4. And top 5 are going, so you don't have to worry about that. All right, so the top 5 teams that move on the top, Cocomelon. Big hand of applause, people. Braca, BRCA on number 2, Titans number 3, Sharedil's number 4, and Mutant Minds number 5. Thank you to the other teams. Thank you for participating. Wish you best of luck. All right, the 5 final teams may just come up close. We're going to give you some time to relax your fingers. You can do a little push-ups with your fingers to get them sorted. If you guys want to come closer, we can remove the rest of the chairs. This is the final round. And I don't hear applause at all. Yes. We can have the team name again. They will up on the board. You have to identify the teams. Okay, we're going to get settled. Give them a little time to acclimatize. All right. So, Cocomelon was on the top. Cocomelon, please stand up. Cocomelon, 2 candidates from AKU, Sundas and Alina. Sundas and Alina on the top. Team 2. I think this is in no order. BRCA, BRCA from Shaukat Khanam, once again. Team 3, Sher Dils. Stand up. Once again, team from AKU, raise their hand twice because there were some issues. No extra time, unfortunately. You were lucky there because you were always in lead. Number 3, Titans, please stand up. Very good. Titans from, once again, you've got to make out, you're going to speak up, AKU. All right? And the last team is Mutant Minds from PNS Shifa once again. So these are your top 5 finalists. Are you guys ready? If you guys give me a green signal, I will start. I don't want to delay it any further. That's why I'm not talking in between. But what I would like you to pick a team, even if you don't have, and please applaud for that team. I wish I had a 5th row and I would have dedicated each column to one of the teams. All right, Shaukat Khanam, because that corner, this row is for Shaukat Khanam, all right? I want you guys to root for Shaukat Khanam. There you go. I'm sorry, team? Team name. Mutant Minds. Mutant Minds, any takers? This column is going to be Mutant Minds. They're going to be supporting Mutant Minds, all right? Since the other 3 teams are from AKU, Sundas and all, this row takes over Sundas. And these 2 teams are this column. All right? I wish I had a 5th row. So, Sherdil and Titans. Column. Sherdil and Titans. Come on. Your team. All right, we're going to get started, right? Bismillah. There'll be 2. Wait, what happened? Everything okay? All right, you got to root for your team. There'll be 2 questions which doesn't have. Come on, root for your team, guys. One team lost connection. हाँ? दोनों नहीं हुए? दोबारा नहीं कर सकते. अभी 2 सवाल हुए. One team lost connection. So what happened? You don't have connection? It changed what? That's okay. अभी तो early questions है ना. अभी तो 2 ही सवाल हैं. Tough luck, girls. It's only the beginning. You have got 30 questions there. And those 30 questions, some of them are double. So if you are the quick finger, you're going to get it. So who was supporting Titans? There you go, Sadhnavi wala hai. I thought Titans was supported by this column right here. Both of them. You also lost it. What's going on? क्या उन्होंने दोबारा नुसरत वो तो नहीं कर दिया रिवर्स? हाँ? Nusrat, what's going on? Everybody lost it. 2 of them lost it. हाँ वो मेरे ख्याल से उन्होंने रिवर्स कर दिया होगा, उन्होंने कहा 2 घंटे पूरे हो गए, अब इनको आगे बढ़ाओ। हाँ क्या चीज़? मोबाइल डेटा पे नहीं करो ना, व्हेन यू गाइस वी हैव अ डेडिकेटेड लाइन फॉर यू गाइस। Other teams are using. How many of you are using Jeopardy? 1, 2. Who's using the code Jeopardy Wi-Fi? 3. You guys are using your own? They are using Nishad Emporium. Nishad Emporium is better than us. Come on, Yan. हाँ? तो इससे बेहतर तो हम निशाद एम्पोरियम कर लें भाई। सब अपना नंबर डालो, निशाद एम्पोरियम लगा लो, फिर वो भी रुक जाएगा। एवरीबडी विल बी ऑन। किस पे भाई? तो वो चल ही नहीं रहा ना, मैं क्या करूं? राइट, इट्स व्हाट 8:30 मैन। व्हाट टू डू? क्या चीज? नहीं नहीं नहीं, अब सबका जो है ना वो बैटरी डाउन हो चुकी है। हाँ, सबको प्राइज दे दें। अच्छा सही, सबको प्राइज दे दें, लकी ड्रॉ कर देंगे हम। दैट्स राइट, 5 टीमें, लकी ड्रॉ, यही हो सकता है। म्यूजिकल चेयर कर लें। चलो भाई, अच्छी बात है। आई होप म्यूजिकल चेयर पे दवा ना चूज की जाती हो। नहीं काम कर रहा? use Nishad Emporium to log in. All 5 teams use Nishad Emporium to log in. This time my IT team lost in first round. पब्लिक वोटिंग कर लें। अच्छा, फिर तो जो यहाँ की टीम है ना वो जीत जाएगी, बिकॉज सिर्फ यहाँ के 3 और वो 2 उनकी आवाज़ आ रही थी और किसी की भी आवाज़ नहीं आई। म्यूट इन माइंड्स। So what are we going to do, Tariq? These 2 questions, are we going to start all over again? देखो जरा वो 2 यस यस यस। ठीक है ना, दैट्स फाइन, क्या फर्क पड़ता है 2 और क्या। जैसे क्विक फिंगर्स, अभी 2 सवाल हुए ना, फिर कल को मुझे 365 दिन रोने को मिलेगा। We are not starting. Don't panic. Don't panic. One thing about oncology is you should have some patience and let's see. Technical difficulty को overcome कर रहे हैं ना। अच्छा, you guys are logged in? You guys are logged in? You guys are logged in? हाँ? देखो भाई, मैंने जो बोल दिया, अब अगर तुम लोगों ने स्विच किया एट योर ओन रिस्क। क्या कर रहे हैं हम? क्या कर रहा हूं मैं? Should I be following Josefa? Should I be following you guys? Whom am I following? Please speak, mic. You guys have mics. I cannot hear you. काश मुझे अल्फाज हिलते हुए समझ में आ रहे होते। Kahoot.it, ओके, Kahoot.it। उससे क्या होगा, जितने पुराने वाले हैं वो निकल जाएंगे, क्योंकि वो सब अभी भी वाईफाई पे लिंक्ड होंगे। क्रिएट अ न्यू पासवर्ड फॉर द सेम वन, बिकॉज पुराने वाले उस पर अभी होंगे। वो 23 टीमें जो पहले थी वो सब अभी वही इस्तेमाल कर रही होंगी। तो आप एक न्यू पासवर्ड बना लो सिर्फ 5 टीमों के लिए। क्विकली प्लीज़। Kahoot.it is the Wi-Fi you're supposed to use. If you're not using it, then please, we are not responsible. एक टीम मिसिंग है। Shadel, Cocomelon, Braca, Mutant Minds, Titan is missing. क्या हुआ Titan? Titan Titanic बन गया भाई। You have a long day tomorrow. In the morning, there's a workshop for the students. Once again, that's by Recon. We're going to have a busy day. कह रहे हैं अपना program discontinue कर दो. हाँ? काश ऐसा होता. हजारों ख्वाहिशें ऐसी. Unfortunately, हम ऑन्कोलॉजी जहाँ घुस जाते हैं तो फिर घुस जाते हैं. फिर काम मुकम्मल करके ही निकलते हैं. आगे, ओके. अच्छा बच्चों, you know, trial. This is when we will say that it's your luck. Okay, you all are on the same page. You all have been given the same passwords. If something stops, it's your luck. Just raise your hands when you are ready. Nobody listens, huh? Raise your hands when you are ready. There you go. Are you ready? So then raise your hands. Let's go, Tariq. We're going to do the 2 questions again. We're going to restart. You all know the answers. Quick finger gets the advantage. So it's plain game. 3, 2, 1, go. Each column, root for your team, please. I didn't know why. Look confused. These are some of the easy questions. It's all about how quick you are. Patient diagnosed with cancer is the diagnosis. None got right. for double points. जब भी आता है statistics पढ़ लेना. No change in leaderboard. Three of you got it correct. Dendritic cells is the answer. Cocomelon goes up. एक तो न्यूरो बनता है ना मेरी और उनकी. Zolbetuximab is the oral monoclonal antibody is the correct answer. Everybody got it right. No change in leaderboard. I think that was an easy one for round 3. Cocomelon maintains the lead. No change in leaderboard. It's the mTOR pathway. Cocomelon is maintaining the lead. Sotorasib is the answer, and the fastest is Cocomelon. Permanently discontinue. Ah! Before and after radical prostatectomy is the correct answer. Who got it right? Any fast fingers? It's Cocomelon who's taking it away along with the Titans. Titan. We're going to hold on for a little bit there. All right. There's 7 questions left. 5 of them will mean something. There's going to be a double question there in as well. Some questions do not have points. Are you get ready? Let's see who's up for it. All right. These questions will have points now. This is the last stretch. Let's see who's going to take it this time. Go ahead. Fibrous tumor was the correct answer. Last 4. Cocomelon got their lead back. Go Coco. But the streak is with BRCA. Oh, that everybody got it so quickly. Only one got it right. Reno criteria is correct. Now, we have our last question of the day. All right, we will have our last question. The top three will be decided on this penultimate question. Go ahead, Tariq, take us home. That was an easy one. Come on, guys. Yeah? All right, hyperlipidemia. Let's see who is the second runners-up for Jeopardy 2026. Now on number 3, Shadil. Stand up as your team goes up. Titans. And the winner is Coco Melon. All right, that's a streak for AKU. All three teams, I think that's a first, right? All right, I would like to have a representative from Himmel up on stage. Dr. Zeba, please do us the honors. I would also like someone from their teams to come up on stage to represent their teams. Dr. Munira, I guess you would be that person. Dr. Zeba, Dr. Arshad, Mr. Sharif, please come up. Guys, you were great. Sorry, only 3 teams had to win. But, you know, if I had a prize, I would give it to this row for being the perfect cheer for their teams. Next time, I'm going to have flags. And each team, we will distribute those flags. And the last round will have only 4 teams. So each row will represent that. Please come up. Let's hear it for the top 3 teams. Go Titan, go Coco Melons, and Shadils. Come on, guys. Come on, guys. Come up. Shadil was 3rd runners-up, right? So you come up here. Number 2 goes on the right side, right? And the top team is in the middle, Titans. Oh, Coco Melons. Coco Melon did it, right? All right, Dr.
Najib. Dr. Najib.
Dr. Najib, yes, I'm sorry. Dr. Kamran hai? No. Sharif Saab hai? Okay.
Dr. Naila, please. Yes.
इधर हाँ पहले उनको वो दे तो दे उनके गिफ्ट आए ना गिफ्ट तो दे पहले डॉक्टर नजीब सो डॉक्टर नाइला रनर्स अप ये क्या है ये किसका है नंबर 3 के लिए डॉक्टर नाइला प्लीज नंबर 3 इज राइट देयर शेयर दिल्स कम ऑन हाँ हाँ अच्छा ओ तस्वीर नहीं आप छुपा रहे हैं उनको सो आप लोग फिर राइट पे आ जाए हाँ पोडियम के हिसाब से रहिए नंबर 1 नंबर 2 नंबर 3 ओलंपिक्स कम ऑन ऑलराइट टाइटंस नंबर 2 आप यहीं रहे प्लीज आप इधर को आ जाएं हाँ Dr. Najib, the prize for Titans on 2nd place. चलें आप वो कर लीजिए, come on, बस इधर को आ जाओ. And the final prize goes to Coco Melon, Munira, Dr. Najib, Dr. Arshad, please come up. That's your team, right? Well, they are all your team. Please, बीच में. इधर आप लोग यहीं रहे, आप यहीं रहे. इधर. Stay on your side. Guys, move a little bit. एक सेकेंड डॉक्टर अर्शद, थोड़ा सा इधर. आप लोग उस तरफ चले जाओ. छोड़ दो.